Congenital anomalies of the kidneys. Congenital anomalies of the kidneys and urinary tract, KCUT, are one of the most common malformations diagnosed in newborns. The pathogenesis of KCUT is multifactorial, both specific genes and environmental factors, example in utero exposure to ACE inhibitors, have been implicated in the development of KCUT. Even though most cases are initially asymptomatic, up to 50% of children with end-stage renal disease have an underlying KCUT. For this reason, early identification of these malformations is essential in order to prevent renal damage. FOFA, OO. Overview. Anomalies of the collecting system. Cent duplex collecting system, a complete or incomplete duplication of the collecting system, pelvic-calyceal system and ureter, has different clinical manifestations depending on the degree of fusion. Copyright. The most common congenital anomaly of the urinary tract O complete duplication, an additional ureteric bud forms resulting in two separate ureteric buds that interact with the same metanephric blastema. The affected kidney has two separate pelvic-calyceal systems and two ureters that enter the bladder at different points, double ureter. O incomplete duplication. The ureteric bud splits before interacting with the metanephric blastema. The affected kidney has two collecting systems that merge between the ureteropelvic junction and the urinary bladder, resulting in a single ostium in the bladder bifid ureter. The affected kidney has two separate pelvic-calyceal systems and two ureters that merge and share a single ostium into the bladder, Y-shaped ureter. Bifid pelvis. The affected kidney has two separate pelvic-calyceal systems that merge into a single ureter at the ureteropelvic junction. C. Associated with vesicoureteral reflux, ureteral stricture, hydronephrosis, and UTIO. Ureteroureteral reflux may occur due to Y-shaped ureter. Cent ectopic ureter. The ureter opening is located caudal to the normal insertion site on the bladder. O. Prenatal hydronephrosis. 1. Copyright. Postnatal UTI. Copyright. In female individuals, the ureter may bypass the external sphincter and insert directly in the vagina, resulting in incontinence. Cent ureterocele, abnormal dilation of the terminal portion of the ureter, which bulges into the urinary bladder or extends to the bladder neck and the urethra, often appears balloon-shaped on cystoscopy. O. Prenatal hydronephrosis. Copyright. Postnatal UTIE. Ureteropelvic junction obstruction. See article on urinary tract obstruction. Malformation of the renal parenchyma. Renal dysgenesis. Renal agenesis, the absence of the kidney and the ureter. ODZO. Pathophysiology. Ureteric bud does not develop. Complete lack of stimulating signals for differentiation of metanephric blastema. Kidney fails to develop. Copyright. Unilateral renal agenesis, usually asymptomatic, depending on the condition of the other kidney. See congenital solitary kidney. Copyright. Bilateral renal agenesis, causes Potter sequence. Cent renal hypoplasia, underdevelopment of the kidney characterized by a reduced number of nephrons. Cent renal dysplasia, abnormal development of the kidney that results in a non-functional kidney with abnormal features, example cysts, increased amount of connective tissue. O. Pathophysiology, ureteric bud does not properly stimulate differentiation of metanephric blastema. Disorganized nephrons, reduced number of nephrons, and abnormal cells. Copyright. Unilateral dysplasia is usually asymptomatic. See congenital solitary kidney. Copyright. Bilateral dysplasia leads to early renal insufficiency and Potter sequence if present in utero. EO examples: polycystic kidney disease, multicystic dysplastic kidneys, obstructive cystic dysplasia, medullary sponge kidney. E. Associated with anomalies of the collecting system that predispose to UTI. Cent renal aplasia, kidney with only rudimentary renal parenchyma present with no residual function. Congenital solitary kidney. Cent definition, the presence of a single functioning kidney due to absence or anomalies of the contralateral kidney. O. Anatomical congenital solitary kidney, the absence of one kidney due to renal agenesis. O. Functional congenital solitary kidney, a non-functional kidney due to example renal aplasia, severe renal dysplasia or hypoplasia. Cent often asymptomatic and diagnosed during prenatal ultrasound screening. AQO. Collapse. Fine text outline. Sent often asymptomatic and diagnosed during prenatal ultrasound screening. Sent a solitary kidney is usually hypertrophic to compensate for the contralateral kidney. Sent higher incidence of anomalies, example vesicoureteral reflux, increased risk of hypertension, renal insufficiency, and progression to end-stage renal disease. Anomalies of kidney migration. Sent horseshoe kidney, fusion of the left and right inferior renal poles. Normal ascent interrupted as fused kidney gets caught on the inferior mesenteric artery, IMA. Copyright increased incidence in patients with chromosomal aneuploidy, example trisomies 13, 18, 21, and Turner syndrome. Copyright usually asymptomatic, typically diagnosed incidentally on abdominal imaging for unrelated conditions. Rarely requires treatment. Copyright increased risk of renal stones, ureteropelvic junction obstruction, hydronephrosis, infections, and renal cancer. Sent renal dystopia and renal ectopia, displacement of the kidney within the retroperitoneum. Sent cross dystopia, displacement of the kidneys, both kidneys located on the same side of the spine. Sent malrotation, torsion of the orthotopic kidney. OES. Etiology. Sent disturbance of embryonic development. Sent environmental factors. Sent in utero exposure to ACE inhibitors or angiotensin receptor blockers. Juxtaglomerular hyperplasia, absent proximal convoluted tubules, or renal fibrosis. References. WA. CES. Clinical features. Sent most K-cut are incidental findings with no clinical significance. K-cut are considered clinically significant if they can lead to chronic kidney disease, vesicoureteral reflux, urinary tract infections, hydronephrosis, or urinary incontinence. Sent signs that an underlying clinically significant K-cut may be present include hydronephrosis on prenatal ultrasound. Copyright urinary tract infection in children. WA. OCs. Diagnostics. Ultrasound imaging of the kidneys and bladder. Copyright first-line imaging modality. detects anatomical abnormalities. Renal ultrasound is warranted for all children with recurrent UTIs or UTI in children. Al. Collapse. Find text outline. OOX. OCO. Diagnostics. Ultrasound imaging of the kidneys and bladder. First-line imaging modality. Copyright detects anatomical abnormalities. Copyright renal ultrasound is warranted for all children with recurrent UTIs or UTI in children. References. FBO. OES. Differential diagnoses. Floating kidney. Sent description. Downward displacement of the kidney due to reduced perirenal fat, thin individuals, anorexia nervosa, hypermobility of the kidney. Sent clinical features. Copyright flank and lower abdominal pain with exacerbation in upright position, nephroptosis causes painful strain. Copyright alleviation of pain in supine position. Sent diagnostics. Renal ultrasound in upright and supine position. Copyright intravenous pyelogram in upright and supine position. Sent treatment. Copyright conservative, abdominal muscle training and stabilization with abdominal wall binders. Copyright surgical, laparoscopic nephropexy. CA references. The differential diagnoses listed here are not exhaustive. WA and treatment. The majority of cases do not require treatment. If there is vesicoureteral reflux, administer antibiotic prophylaxis. See vesicoureteral reflux. If there is vesicoureteral reflux with recurrent cystitis or pyelonephritis, perform surgical correction. Abnormalities of the ureter or its insertion into the bladder, example ureterocele, ectopic ureter, are treated with resection of the distal ureter followed by ureteral reimplantation. Laparoscopic nephrectomy may be indicated in cases with recurrent pyelonephritis and loss of kidney function. OCE. Sources. Last updated March 23, 2022. QAL. Collapse. Find text outline. Urocongenital anomalies of the kidneys, 1/6. Bifid //ureter 2 ureteral orifices. Duplex collecting systems. VV. Copyright Boss. Knock mixture. Overlay. Horseshoe kidney with hydronephrosis VV intravenous pyelogram and scintigraph 35-year-old patient with recurring urinary tract infections, horseshoe morphology of the kidney, red overlay, in scintigraphy, which is a predisposing factor for the hydronephrosis, green overlay, seen in the pyelogram. Hydronephrosis may cause recurring urinary tract infections. Source: copyright IMPP. Knock mixture. Overlay. Horseshoe kidney with hydronephrosis VV intravenous pyelogram and scintigraph 35-year-old patient with recurring urinary tract infections, horseshoe morphology of the kidney, red overlay, in scintigraphy, which is a predisposing factor for the hydronephrosis, green overlay, seen in the pyelogram. Hydronephrosis may cause recurring urinary tract infections. Source: copyright IMPP. Overlay. Horseshoe kidney VV. Mr. Angiography of the aorta, maximum intensity projection, MIP, a fusion of the two inferior renal poles is clearly visible, green overlay. In addition, an upper renal pole artery on the left side is shown as an anatomical norm variant. Source: Uepizenier 01, MRT, Mr. CE Angiography, MIP, 008.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Further notes: this image is part of a series. Copyright overlay. Horseshoe kidney Mr. Angiography of the aorta, maximum intensity projection, MIP, a fusion of the two inferior renal poles is clearly visible, green overlay. In addition, an upper renal pole artery on the left side is shown as an anatomical norm variant. Source: Uepizenier 01, MRT, Mr. CE Angiography, MIP, 008.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Further notes: this image is part of a series. Overlay. Horseshoe kidney VV MRI abdomen, T2 weighted, transverse plane, a fusion of both kidneys ventral to the aorta can be seen, green overlay. Source: Uepizenier 01, MRT, T2 axial, 008.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Further notes: this image is part of a series. Copyright overlay. Horseshoe kidney VV MRI abdomen, T2 weighted, transverse plane, a fusion of both kidneys ventral to the aorta can be seen, green overlay. Source: Uepizenier 01, MRT, T2 axial, 008.jpg by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Further notes: this image is part of a series. Aorta celiac trunk superior mesenteric artery renal artery horseshoe kidney inferior mesenteric artery. Horseshoe kidney VV congenital abnormality of the kidney. Ventral view. Copyright Boss. Overlay. Horseshoe kidney VV. CT abdomen, with contrast, axial plane, the lower poles of the kidneys, green overlay, are fused across the midline by an isthmus of enhancing parenchyma, red overlay. Note the lack of parenchyma at the level of the left renal hilum, indicated by white arrow, which is directed anteriorly as a result of incomplete medial rotation of the kidney along its longitudinal axis. This is a classic appearance of horseshoe kidney. C: with contrast. Source: Uepizenier CT axial by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Horseshoe kidney VV. CT abdomen, with contrast, axial plane, the lower poles of the kidneys, green overlay, are fused across the midline by an isthmus of enhancing parenchyma, red overlay. Note the lack of parenchyma at the level of the left renal hilum, indicated by white arrow, which is directed anteriorly as a result of incomplete medial rotation of the kidney along its longitudinal axis. This is a classic appearance of horseshoe kidney. C. With contrast, source, Hyophysianaire CT Axial by Hellerhoff, Wikimedia Commons, licensed under CC by SA 3.0. Copyright overlay abdomen and pelvis VVCT abdomen and pelvis, coronal view. No pathologic features are noted. Source, copyright IMPP. X. Polycystic kidney disease. Polycystic kidney disease, PKD, is an inherited disorder characterized by the development of multiple cysts in the kidneys. It is classified into two distinct disorders, autosomal recessive PKD, ARPKD, and autosomal dominant PKD, ADPKD. ARPKD manifests with severe pulmonary insufficiency and progressive renal failure with onset during infancy or early childhood. If left untreated, ARPKD is typically lethal before adolescence. ADPKD manifests with flank pain, arterial hypertension, and progressive kidney disease with onset in adulthood. Early diagnosis and treatment may prevent or delay end-stage renal disease in both conditions, but kidney transplantation is the only curative treatment option. OIOE. Epidemiology. Cent incidence ADPKD, 1/1,0001. Equals the most common inherited cause of chronic kidney disease, responsible for 5-10% of end-stage renal disease, ESRD, 3 ARPKD, 1/20,000 I. Prevalence, 140,000 patients with polycystic kidney disease in the US. 5 plus sex, A equals 9. Epidemiological data refers to the US, unless otherwise specified. VAA, shared no. Etiology. Plus ADPKD 7. O. Autosomal dominant inheritance, complete penetrance but variable expressivity. Copyright mutation in 81L9L equals PKD1 on chromosome 16, 85% of cases, the gene that encodes polycystin 1, or PKD2 on chromosome 4, 15% of cases, the gene that encodes polycystin 2. Copyright positive family history, 1E ARPKD. O. Autosomal recessive inheritance. O. Mutation in PKHD1 gene on chromosome 6, the gene that encodes for fibrocystin, a protein involved in the maintenance of primary cilia of the renal collecting duct and biliary epithelial cells. OAII. Phi. Pathophysiology. ADPKD. Cent 2 hit hypothesis. Copyright inherited mutation in one allele of PKD1, polycystin 1, or PKD2, polycystin 2, genes, 1. Polycystin 1, involved in cell-cell and /or cell matrix interactions, equals polycystin 2, a non-selective cation channel transporting Ca2*O. Additional second somatic acquired mutation in tubule epithelial cells, 1. Abnormal cilia-mediated signaling pathways, formation and expansion of cysts in the renal cortex and medulla, compression of renal vessels with activation of the renin-angiotensin-aldosterone system, RAAS, ischemia, and destruction of the kidney parenchyma. 11 ARPKD. Inherited mutation in the PKHD1 gene, defective fibrocystin, also called polyductin, cystic dilation of collecting ducts and bile ducts, intrahepatic and extrahepatic bile ducts, 12. Back collapse. Fine text outline. Clinical features. ADPKD, 5. Cent symptom onset. O. Symptoms usually occur after 30 years of age, but the disease may also manifest during childhood. 1. O. Symptoms are less severe and tend to manifest later in individuals with the PKD2 mutation compared to those with the PKD1 mutation. 13. Cent renal manifestations. O. Gross hematuria. O. Flank or abdominal pain. O. Recurrent urinary tract infections. O. Nephrolithiasis. Copyright kidneys might be palpable and enlarged on abdominal exam, they are usually normal at birth. Copyright signs of chronic kidney disease, example hypertension, fluid overload, uremia, plus extrarenal manifestations. O. Multiple benign hepatic cysts, prevalence increases with age. Copyright cysts may also occur in the pancreas, spleen, ovary, and testicles. Copyright cerebral berry aneurysm, 8%. 14 equals the risk is higher in patients with a family history positive of ADPKD. May rupture and cause subarachnoid hemorrhage. The risk for growth and rupture is the same in patients with ADPKD as in the general population. Copyright cardiovascular equals signs of arterial hypertension, example morning headaches, through increased renin production heart valve defects, particularly mitral valve prolapse, equals left ventricular hypertrophy equals potential association with coronary artery aneurysm and aortic aneurysm. Copyright diverticulosis, abdominal or inguinal hernias. ARPKD. Symptom onset. Symptoms most commonly manifest in infancy or childhood. Renal manifestations. Copyright protruding abdomen, non-tender abdominal mass, due to bilateral renal enlargement and/or hepatomegaly. Copyright chronic renal failure, frequently hematuria, proteinuria, and oliguria. Severe in utero renal impairment. Oliguria in utero. Maternal oligohydramnios. Potter sequence equals craniofacial abnormalities, retrognathia, low-set ears, flat nose, and clubbed feet. Pulmonary hypoplasia. Respiratory insufficiency in neonates. 1e extrarenal manifestation. O. Hypertension. Early manifestation. 4 equals often not responsive to monotherapy equals can result in complications if inadequately controlled, example cardiac hypertrophy, heart failure, cerebrovascular diseases, progressive renal impairment, liver involvement, congenital hepatic and portal fibrosis. Progressive liver failure and portal hypertension. WA and diagnostics. Imaging plus ultrasound / 15O ADPKD in adults, enlarged kidneys with multiple cysts bilaterally of varying sizes, anechoic masses, equals in children, evidence of cysts in combination with a family history positive of ADPKD equals hepatic, pancreatic, and / or splenic cysts may be visible. ARPKD equals enlarged kidneys with multiple cysts bilaterally of equal size. Diffuse increased echogenicity, despite the presence of liquid-filled cysts. Anechoic, equals hepatic cysts equals hepatic and portal fibrosis. CTO not the method of choice. Copyright should only be used if ultrasound findings are unclear, due to the radiation exposure of CT. Back collapse. Find text outline. OE shows equals multiple cysts, usually hypodense, well demarcated, not septated, and thin-walled equals bilateral enlargement of the kidneys. St. Mr. Angiography, screening for Barry aneurysms in patients with ADPKD is recommended in the following scenarios. 16O family history of aneurysm. Copyright prior to extensive elective surgeries, example transplantation. Copyright occupations in which unconsciousness represents a public safety risk, example driver. Copyright the patient wishes to be screened. Further diagnostic tests. Scent genetic testing, DNA linkage analysis to identify ADPKD1 and ADPKD2, often not necessary. 9e laboratory measures, to evaluate and monitor renal function. Copyright blood cell count, can show renal anemia. Copyright creatinine clearance. Copyright urinalysis, can show proteinuria, hematuria. Scent, diagnostic laparoscopy and liver biopsy, in ambiguous cases. Pathology. ADPKD-O progressive cystic dilatation of the kidney tubular system. Copyright cystic dilation in other organs such as liver and pancreas. O left ventricular hypertrophy. Copyright vascular dolichoectasias, elongations and distensions of the arteries caused by weakening of the vessel walls. Copyright cardiac valvular abnormalities, example defects of the mitral valve and the aortic root, annulus, and / or valve. ARPKD. Copyright cystic dilatation of the collecting ducts. Other nephron segments are usually not affected. Hepatic fibrosis, see pathology section in cirrhosis. Differential diagnoses. Renal cysts. See renal cysts. Acquired cystic kidney disease. Etiology. No gene mutation. Copyright typically seen in advanced chronic kidney disease, especially in patients on renal replacement therapy. Clinical features. Copyright small, usually bilateral cysts. Copyright multiple cysts, 4 cysts per kidney. Small to normal size kidney. Complications, cyst infection or bleeding, renal cell carcinoma diagnostics, ultrasound. Back collapse fine text outline. Scent diagnostics, ultrasound scent treatment, see treatment in renal cysts. Prevention, prevent or delay progression to ESRD, see treatment below. Multicystic dysplastic kidneys. Scent definition, renal dysplasia with multiple cystic dilatations of nephrons during embryonic development. Scent etiology, predominantly non-hereditary. Pathophysiology, sporadic occurrence during embryonic development of the ureter and nephrons. Copyright defective interaction of the ureteric bud and the metanephric mesenchyme. Non-functional kidney with multiple cysts and connective tissue. Scent clinical features. Copyright onset, birth to childhood. Rarely symptomatic. Large cysts might impair urinary output, due to constriction of the urinary tract. Usually unilateral cysts. Copyright in the case of bilateral involvement. Potter sequence, due to oligohydramnios, equals spontaneous abortion in case of failure of amniotic fluid production. Renal insufficiency is rare. 1. Extrarenal manifestations, equals congenital heart defects, equals esophageal or intestinal atresia, equals spinal anomalies, equals bacterial association. Scent diagnostics, ultrasound showing unilateral, rarely bilateral, cysts of varying size. Scent treatment. Surveillance in most cases. Nephrectomy is indicated in severe cases, example hypertension, progression of cyst growth. Prognosis. Most cases regress spontaneously. Copyright the non-dysplastic kidney usually functions properly and takes over the function of two kidneys. Autosomal dominant tubulointerstitial kidney disease, ATCADE, 117. Scent definition, a group of rare kidney diseases characterized by tubular damage and interstitial fibrosis in the absence of glomerular lesions. Scent etiology. The three major genetic causes include autosomal dominant mutation of one of the following genes, 18 equals UMOD, encoding uromodulin, 70% of cases, 1 MUC1, encoding mucin 1, 30% of cases, and equals REN, encoding renin. Scent pathophysiology. ATCADE due to UMOD mutation, accumulation of uromodulin within the cells of the thick ascending loop of Henle. Mitochondrial dysregulation, tubular cell death. Chronic kidney disease, uromodulin production. Apical expression of the NAK2Cl cotransporter T. natriuresis. Compensatory proximal tubular sodium reabsorption, secondary increase in proximal urate reabsorption. Hyperuricemia. ATCADE due to MUC1 mutation, possible dominant negative or gain of function effect of MUC1 mutation. ATCADE due to REN mutation, accumulation of preprorenin in the renal tubular cells. Apoptosis. Chronic kidney disease. Scent clinical features. Copyright small to normal size kidney. Copyright signs of chronic kidney disease, example hypertension, fluid overload, uremia. ESRD usually develops between 30 to 60 years of age. Copyright occasional bilateral cysts, mostly medullary. 1. Absent or minimal proteinuria with a bland urine sediment. ATCADE due to UMOD mutation, gout since the adolescence. Copyright clinical findings associated with low renin in ATCADE due to REN mutation equals low to normal blood pressure equals hypoproliferative anemia in childhood equals mild hyperkalemia equals hyperuricemia. Scent diagnostics. Ultrasound equals small kidneys in advanced stages of CKD equals medullary cysts can rarely be seen. Genetic analysis provides a definitive diagnosis. Scent pathology, tubulointerstitial fibrosis. Scent treatment. Degree curative, kidney transplantation. Copyright treatment of chronic kidney disease. ATCADE due to UMOD mutation, allopurinol for gout. Back collapse fine text outline. ATCADE due to UMOD mutation, allopurinol for gout. ATCADE due to REN mutation, fludrocortisone or high sodium diet may be used for low blood pressure, hyperkalemia, and to potentially preserve kidney function. Scent prognosis, poor, due to progression of chronic kidney disease. 17 medullary sponge kidney. Definition, calcified cysts originating from the collecting ducts and/or tubules in one or both kidneys. Epidemiology, 1 degree. Copyright 1/5000 persons. Copyright 12 to 20% of patients with calcific renal stones. OFOF. Copyright. The mean age of diagnosed patients is 27 years. Etiology. Most cases are sporadic. Some cases are attributed to genetic mutations. Pathophysiology. Disruption at the ureteric bud metanephric mesenchyme interface. Distal tubular acidification defect. 7 urine pH and urinary stasis in the dilated ducts. Calcium phosphate and/or calcium oxalate. Lithogenesis. Clinical features. Copyright usually asymptomatic. Incidental finding. Copyright signs of nephrolithiasis, example colicky flank pain. Copyright signs of urinary tract infection, example polyuria, dysuria, hematuria. Copyright painful excretion of small stones with the urinary flow is common. Diagnostics. Copyright ultrasound, dilatation of collecting ducts, cysts, and/or kidney stones, nonspecific. Copyright contrast. CT urography, parallel striations from contrast which extend from the papilla to the medulla and persist on delayed imaging, papillary blush. Copyright IVP, irregular ectatic medullary collecting ducts, classic paintbrush-like appearance, treatment. Copyright prophylactic treatment of kidney stones with thiazide diuretics, high fluid intake, and/or potassium citrate. Extracorporeal shockwave lithotripsy for stones in collecting tubule. Copyright in rare cases of kidney failure, renal dialysis may be required. Complications. Recurrent UTIs can lead to renal obstruction. Copyright dilatation of the collecting ducts, impaired renal filtration, metabolic acidosis. Rarely, renal tubular acidosis, ESRD. Nephronophthisis, NPHP. Scent definition, a hereditary cystic kidney disease that typically manifests in childhood, characterized by renal ciliopathy, reduced renal concentration ability, and progression to ESRD. Plus epidemiology, 2-degree. Copyright incidence, 1/1,000,000 in the U.S. Copyright. One of the most common genetic disorders leading to ESRD in children. Etiology. Autosomal recessive inheritance pattern. Mutations in genes encoding nephrocystin protein. Scent. Clinical features. Copyright. Similar clinical and histopathological features as ATCATE. Renal manifestations equals multiple, bilateral, mostly corticomedullary, kidney cysts equals polyuria, polydipsia, due to impaired ability to concentrate urine, equals signs of chronic tubulointerstitial nephritis. Signs of chronic kidney disease, example hypertension, fluid overload, anemia, uremia, equals ESRD usually develops before the age of 20 years. 21. Extrarenal manifestations, 10 to 20% of cases, include retinal defects, liver fibrosis, skeletal abnormalities, cardiac defects, or brain developmental disorders. Scent diagnostics. A renal ultrasound may reveal corticomedullary cysts. Copyright genetic analysis allows definitive diagnosis. Scent treatment. Copyright treatment of chronic kidney disease. Copyright curative, kidney transplantation. Obstructive cystic dysplasia. Scent definition, renal dysplasia and cystic dilatation secondary to obstruction in the urinary tract, example ureteral stenosis, urethral agenesis, during fetal development. Scent etiology. C equals, AO. Back collapse. Find text outline. Scent etiology. Ureteral stenosis. Posterior urethral valves. Bladder outlet obstruction. Urethral agenesis. Copyright duplex collecting system with obstructing ureterocele. Copyright congenital vesicoureteric junction obstruction. Scent pathophysiology, urinary tract obstruction. Urine retention in functioning nephrons. Formation of glomerular cysts in the nephrogenic zone. Scent clinical features. Copyright onset, birth to childhood. Copyright during pregnancy, oligohydramnios. Copyright the cause, the severity, and the timing of the obstruction determine the extent of symptoms. Equals asymptomatic in mild cases. Equals acute renal failure in severe cases. Extrarenal manifestations. Equals congenital heart defects. Equals CNS anomalies. Equals bacterial association. Scent diagnostics, ultrasound showing unilateral or bilateral cysts of varying size. Cysts are usually smaller than those seen in patients with multicystic dysplastic kidneys. 22. Scent treatment, elimination of the obstruction as a curative approach, example urethral valve ablation. Von Hippel-Lindau disease. Sense C. Von Hippel-Lindau disease. The differential diagnoses listed here are not exhaustive. WA. CE. Treatment. Scent treatment/prevention of renal dysfunction. Copyright ACE inhibitors, ACEs, or angiotensin receptor blockers, ARBs, to prevent/treat hypertension as well as to slow proteinuria and ESRD progression. Copyright tolvaptan equals indicated in patients with rapidly progressing ADPKD and mild chronic kidney disease, GFR equals 25 ml/min/1.73 m, and or chronic kidney function estimated between 30 to 90%. 23 equals slows down the growth of kidney cysts in ADPKD patients equals delays progression to ESRD. Copyright early treatment of urinary tract infections, to prevent renal cyst infection. Copyright high fluid intake to prevent kidney stone formation and to possibly slow cyst progression. Avoid nephrotoxic substances, example NSAIDs, sulfonamide antibiotics, aminoglycosides. Avoid ADH, vasopressin may stimulate cyst growth, scent in severe cases, example ESRD, hemodialysis or peritoneal dialysis. Copyright kidney transplantation is the only curative option. See also end-stage renal disease. Portosystemic shunting or liver transplantation may be required in ARPKD patients with severe hepatic involvement. Copyright treatment of complications, example portal hypertension, subarachnoid hemorrhage, general measures. Regular sonographic monitoring and laboratory evaluation of renal function. Copyright regular sonographic and laboratory monitoring of liver and treatment of hepatic failure. Genetic counseling. FO. Good. Prognosis. ADPKD. Copyright 50% of ADPKD patients have ESRD requiring dialysis by the age of 60 years. 124 Copyright chronic hypertension and cerebral aneurysms, in particular, are associated with a poor prognosis. ARPKD. Neonates with severe cystic dilatation have a poor life expectancy. Probability of death within the 1 degree year of life is 30%. 125-26 Copyright the majority of children who survive infancy have a life expectancy greater than 10 years. 25 Copyright the prognosis depends on the extent of renal and hepatic impairment, equals renal cysts and enlargement lead to systemic hypertension and progressive renal failure. Equals progressive portal hypertension and hepatic fibrosis lead to liver failure. Back collapse. Find text outline. Autosomal dominant polycystic kidney disease. Extrarenal manifestations. Renal manifestations: flank or abdominal pain. Mitral valve prolapse / enlarged kidneys with multiple cysts. Chronic kidney disease. Hypertension. Hepatic cysts. Degree: 6. Recurrent urinary tract diverticulosis infections. Gross hematuria. Autosomal dominant polycystic kidney disease. Copyright Boss. Polycystic kidney disease, 1/4. MI, 1.1. Overlay. Polycystic kidneys. In polycystic kidney disease VV ultrasound kidney, longitudinal view, note that the poles of the kidney extend beyond this view. Multiple, sharply demarcated anechoic lesions, green overlay, have replaced the majority of the renal parenchyma. Part of the renal sinus, red overlay, is still visible. These findings are consistent with polycystic kidney disease. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Polycystic kidney disease, 1/4. MI, 1.1, 79 dr. 6C1 div 5.0 15 cents 14 fps. Copyright. Overlay. Polycystic kidneys. In polycystic kidney disease VV ultrasound kidney, longitudinal view, note that the poles of the kidney extend beyond this view. Multiple, sharply demarcated anechoic lesions, green overlay, have replaced the majority of the renal parenchyma. Part of the renal sinus, red overlay, is still visible. These findings are consistent with polycystic kidney disease. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Polycystic kidney disease, 2/4. Dip 5.017 fps. Overlay. Liver involvement in polycystic kidney disease VV. Ultrasound liver, transverse plane, of a patient with autosomal dominant polycystic kidney disease, ADPKD, multiple rounded, anechoic lesions, green overlay, are seen within the liver parenchyma. Hyperechoic posterior acoustic enhancement artifact, white overlay, is visible, indicating that the structures are fluid-filled. The findings are consistent with liver cysts. Polycystic liver disease is a major extrarenal manifestation of ADPKD. The cystic structures, which result from structural changes of biliary tree development, may not present until adulthood. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Polycystic kidney disease, 2/4. 4 dip T 5.0. 17 fps. Overlay. Liver involvement in polycystic kidney disease VV. Ultrasound liver, transverse plane, of a patient with autosomal dominant polycystic kidney disease, ADPKD, multiple rounded, anechoic lesions, green overlay, are seen within the liver parenchyma. Hyperechoic posterior acoustic enhancement artifact, white overlay, is visible, indicating that the structures are fluid-filled. The findings are consistent with liver cysts. Polycystic liver disease is a major extrarenal manifestation of ADPKD. The cystic structures, which result from structural changes of biliary tree development, may not present until adulthood. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Uropolycystic kidney disease, 3/4. Overlay. Autosomal dominant polycystic kidney disease, ADPKD. CT abdomen, with contrast, coronal plane, both kidneys are markedly enlarged and feature multiple round to ovoid, hypodense lesions of various sizes, examples indicated by green overlay, compatible with cysts. Some smaller cysts are present in the liver, examples indicated by red overlay. Contrast-enhanced renal parenchyma is seen between the cysts, yellow overlay. The CT features are consistent with autosomal dominant polycystic kidney disease, ADPKD. B. Bladder, L. Liver, SB, small bowel source, CT scan autosomal dominant polycystic kidney disease by Stephen Fruitsmock, Wikimedia Commons, licensed under CC by SA 3.0. Uropolycystic kidney disease, 3/4. Copyright. Overlay. Autosomal dominant polycystic kidney disease, ADPKD. CT abdomen, with contrast, coronal plane, both kidneys are markedly enlarged and feature multiple round to ovoid, hypodense lesions of various sizes, examples indicated by green overlay, compatible with cysts. Some smaller cysts are present in the liver, examples indicated by red overlay. Contrast-enhanced renal parenchyma is seen between the cysts, yellow overlay. The CT features are consistent with autosomal dominant polycystic kidney disease, ADPKD. B. Bladder, L. Liver, SB, small bowel source, CT scan autosomal dominant polycystic kidney disease by Stephen Fruitsmock, Wikimedia Commons, licensed under CC by SA 3.0. Uropolycystic kidney disease, 4/4. Polycystic liver VV. Diagnostic laparoscopy of the liver. Numerous, variably sized, fluid-filled structures are seen on the surface of the liver. These findings are consistent with polycystic liver disease, which is commonly associated with polycystic kidney disease. Source: Copyright IMPP. Uropolycystic kidney disease, 1/2. Hepatic cysts in autosomal dominant polycystic kidney disease VV. Gross pathology liver specimen, cross-section, multiple, variably sized, thin-walled lesions are visible within the liver parenchyma. These findings are consistent with polycystic liver disease, which is associated with autosomal dominant polycystic kidney disease source, copyright IMPP. Multiple cysts in the kidney in ADPCADE. Macroscopic image of the left kidney, which shows numerous cysts. These findings are consistent with autosomal dominant polycystic kidney disease, ADPCADE. Source, copyright IMPP. Polycystic kidney disease, 1/1. Equals C4 diffs. 10 degrees 19 fps. Overlay. Medullary sponge kidney VV. Ultrasound right kidney, longitudinal plane, there is dilation of the hypochoipapillary collecting ducts, green overlay, surrounded by hyperechoic renal pyramids, turquoise overlay. The renal capsule is defined by a spotted white line. These findings are consistent with a medullary sponge kidney. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. Polycystic kidney disease, 1/1. MI, 1.5. 6C12 diffs. 10 degrees 19 fps. Copyright overlay. Medullary sponge kidney VV ultrasound right kidney, longitudinal plane, there is dilation of the hypochoipapillary collecting ducts, green overlay, surrounded by hyperechoic renal pyramids, turquoise overlay. The renal capsule is defined by a spotted white line. These findings are consistent with a medullary sponge kidney. Our great thanks to Sono.Gallery, a medical ultrasound library by Dr. Daniel Merkel, for providing the images and videos. X megaureter. Megaureter is defined as ureteral dilation 7 mm. Primary megaureter is due to obstructed or refluxing vesicoureteral junction, while secondary megaureter is caused by bladder outlet obstruction. Although rare, primary megaureter is responsible for up to 20% of hydronephrosis cases in neonates. About half of the patients with megaureter are asymptomatic. The other half may present with a urinary tract infection, abdominal pain, or features of uremia. Ultrasound, prenatal and postnatal, shows ureteral dilation, which may be accompanied by hydronephrosis. CT or Mr. urography shows a constricted terminal ureter with proximal dilation, while voiding cystogram detects vesicoureteral reflux in refluxing megaureter. Prophylactic antibiotics and regular follow UPS are sufficient in patients with primary megaureter and preserved renal function. Surgery, terminal ureter resection and reimplantation into the bladder, is indicated in patients with deteriorating renal parameters. Patients with secondary megaureter require treatment of the underlying cause. Those who do not receive treatment can develop recurrent urinary tract infections, hydronephrosis, and obstructive nephropathy with permanent kidney damage. RO4N Ed notes. Definition. Plus ureteral dilation 7 mm in children 6. C. CE. Epidemiology. Plus incidence, rare, $4:1, 3 * occurrence, second most common cause of hydronephrosis in newborns, 20% of cases, -2 epidemiological data refers to the U.S., unless otherwise specified. OOST. Etiology. Primary megaureter. Sent primary obstructed megaureter 1. Congenital developmental defect of the muscular layer of the terminal ureter 2. Distal upper peristaltic segment of ureter causing functional obstruction 3. Increased intraureteral pressure in dilation * primary refluxing megaureter, dilation of the ureter secondary to primary vesicoureteral reflux, VUR, secondary megaureter. Secondary obstructed megaureter copyright bladder outlet obstruction, copyright high intracystic pressure copyright functional obstruction of the vesicoureteral junction, VUJ, urine cannot pass into the bladder ureteral dilation * secondary refluxing megaureter, bladder outlet obstruction with ureteral dilation caused by secondary vesicoureteral reflux. References 4L. Ven. AE. Clinical features. SENT prenatal detection of hydronephrosis and dilated ureter on antenatal ultrasonography. SENT postnatal presentation 50% are asymptomatic, with normal renal parameters. Copyright often an incidental finding on ultrasound. 50 symptoms of urinary tract infection. Copyright abdominal/flank pain. Features of uremia. Back collapse. Find text outline. Or clinical features. Prenatal detection of hydronephrosis and dilated ureter on antenatal ultrasonography. SENT postnatal presentation 50% are asymptomatic, with normal renal parameters. Copyright often an incidental finding on ultrasound. 10 symptoms of urinary tract infection. Copyright abdominal/flank pain. Features of uremia. WA or diagnostics. SENT ultrasound, best initial and confirmatory test. Hydronephrosis. Copyright ureteral dilation 7 mm. SENT further evaluation. Copyright voiding cystourethropy, VCUG, to identify retrograde reflux of urine into the ureters. Copyright radionuclide renal scanning, to identify obstruction and evaluate renal function. A. Tiled. Treatment. Primary megaureter. SENT conservative therapy. Copyright indicated in children with preserved renal function. Copyright prophylactic antibiotics. Copyright regular follow-up. SENT surgery. Copyright indicated in children with deteriorating renal function. Copyright procedure, resection of the distal segment of the ureter and reimplantation into the bladder, ureteroneocystostomy, secondary megaureter. SENT treatment of the underlying disease. XGOES. Complications. Urinary tract infection. SENT hydronephrosis. SENT obstructive nephropathy. We list the most important complications. The selection is not exhaustive. WA. OXO. Sources. Back. Last updated December 1, 2022. V. Collapse. A. Find text. Al. Outline. Refluxing megaureter in avoiding cystourethrogram, 1/2, VV. Contrast filled, ballooning of the renal pelvic-calyceal system, left-right, can be seen, as well as a dilated ureter with numerous kinks. This finding indicates grade V vesicoureteral reflux. Source, copyright IMPP. Megaureter, 2/2. Refluxing megaureter in avoiding cystourethrogram, 2/2, VV. Contrast filled, ballooning of the renal pelvic-calyceal system, left-right, can be seen, as well as a dilated ureter with numerous kinks. This finding indicates grade V vesicoureteral reflux. Source, copyright IMPP. X. Abnormalities of the male urethra and webbed penis. Abnormalities of the male urethra are common and the need for treatment depends on the condition and the symptoms. Epispadias and hypospadias may result in difficulty urinating and infections, and surgical repair is indicated for restoring functionality and reconstruction of external genitalia. Posterior urethral valves are the most common cause of urinary obstruction in newborn boys and can be associated with hydronephrosis, renal failure, and pulmonary hypoplasia. Early identification by prenatal ultrasound with diagnosis by voiding cystourethrogram allows for cystoscopic valve ablation and relief of the obstruction. However, despite treatment, many patients will develop chronic kidney disease. OFE, CE. Epispadias. SENT definition. Embryonic malformation due to malpositioning of the genital tubercle that causes incomplete urethral tubularization on the dorsal penis when associated with bladder exstrophy, although in an attenuated form. O may also be due to chronic pressure, example as a result of a transurethral indwelling catheter eroding the urethra. SENT epidemiology, incidence is about 2.4 per 100,000 live births. Isolated epispadias, NL plus clinical features 21 cleavage and exposure of the urethra equals on the dorsal penis and associated with penile curvature equals between labia and clitoris or up to bladder O urinary incontinence, vesicoureteral reflux scent diagnostics, clinical diagnosis scent treatment copyright in young patients, operative closure with urethroplasty and reconstruction of genitalia if indicated copyright in patients with long-term indwelling catheters, insertion of a suprapubic indwelling catheter, reconstructive treatment is usually not necessary, scent complications. Copyright erectile dysfunction and infertility in males. Degree UTI. S. Hypospadias. Definition: common congenital malformation with incorrect positioning of the external urethral meatus due to failure of urethral folds and foreskin to fuse on ventral penis. Epidemiology: incidence is 1 per 250 live births. 3. Etiology: genetic, example differences of sex development; endocrine, example 5-alpha reductase deficiency, and environmental factors have been implicated. Clinical features: O abnormal foreskin, dorsal hood, ventral penile curvature, and 2 meatal openings. O proximal hypospadias are associated with bifid scrotum and penoscrotal transposition. O associated with inguinal hernias, cryptorchidism, and corti, a congenital abnormality characterized by an abnormal ventral curvature of the penis. Diagnostics, clinical diagnosis, treatment. Copyright: mild cases do not necessarily require surgery. Copyright: significant displacement or symptomatic micturition warrants surgical repair equals reconstruction of urethra, penis, and scrotum at 6 to 12 months of age. Urethroplasty and orthoplasty equals severe cases require 2-stage repair with correction of penile curvature first followed by urethroplasty at least 6 months later. Complications following repair: O urethral fistula. O meatal stenosis, narrowing of ventral meatus causes thin urinary stream and straining with urination equals most commonly caused by circumcision equals treatment consists of surgery. Metotomy: the meatus of the urethra is ventrally incised. Copyright: urethral diverticulum, distinct outpouching of the urethral mucosa that most frequently leads to dribbling, dysuria, and dyspareunia. O UTIs. Circumcision is contraindicated in boys with hypospadias that includes the foreskin. In these cases, the foreskin may be needed for a skin flap when performing urethranoplasty. Back collapse. Find text outline. Circumcision is contraindicated in boys with hypospadias that includes the foreskin. In these cases, the foreskin may be needed for a skin flap when performing urethroplasty. Posterior urethral valves. Scent definition: congenital malformation in males where membranous folds of the urogenital membrane obstruct the membranous and prostatic urethra, posterior urethra. Scent epidemiology: incidence is about 1 per 4,000 live births. 4 * clinical features. 2. Most common cause of urinary tract obstruction in newborn males: O respiratory distress secondary to pulmonary hypoplasia in cases with severe obstruction. See Potter sequence. O abdominal distension due to bladder distension. O late manifestations equals difficulty voiding, poor urinary stream equals UTIs. Urosepsis equals diurnal enuresis equals failure to thrive. Diagnostics. WA and copyright voiding cystourethrogram, diagnostic study of choice, demonstrates dilation/elongation of the posterior urethra during voiding. Signs of vesicoureteral reflux, if present. O prenatal ultrasound of the upper urinary tract may demonstrate distended and/or thick-walled bladder equals bilateral hydroureters equals bilateral hydronephrosis. Marked vesicoureteral reflux with megaureter equals oligohydramnios and features of Potter sequence in severe urinary outflow obstruction. Treatment. Copyright temporary insertion of urinary catheter and correction of electrolyte imbalance. Copyright first line. Primary valve ablation equals an endoscopic procedure that involves the transurethral incision of posterior urethral valves in the membranous part of the urethra. A equals performed during cystoscopy. EO second line. Vesicostomy: a surgical procedure in which a connection is formed between the bladder and the outside of the lower abdominal wall to allow for the drainage of urine, or if ablation is not possible. Also indicated in patients with functional bladder outlet obstruction, example neurogenic bladder, copyright close follow-up due to high risk of chronic kidney disease or renal transplantation may become necessary during the course of disease. Copyright fetal vesicoamniotic shunting is associated with procedure-related risks without evidence of long-term benefits for renal function complications, most common cause of chronic renal insufficiency or renal failure in boys. Webbed penis. Definition: a congenital malformation with growth of the scrotum extending to the tip of the penis, usually only extends to the root of the penis. Copyright: the urethra is typically not affected. Clinical features: formation of webbing between the tip of the penis and the scrotum when erect. Copyright: potential erectile dysfunction and ventral deviation. Back collapse. Find text. Outline. Scent definition: congenital malformation in males where membranous folds of the urogenital membrane obstruct the membranous and prostatic urethra, posterior urethra. Scent epidemiology: incidence is about 1 per 4,000 live births. 4 * clinical features. 2. Most common cause of urinary tract obstruction in newborn males: respiratory distress secondary to pulmonary hypoplasia in cases with severe obstruction. See Potter sequence. Abdominal distension due to bladder distension. Late manifestations = difficulty voiding, poor urinary stream = UTIs, urosepsis = diurnal enuresis = failure to thrive. Scent diagnostics. Copyright: voiding cystourethrogram, diagnostic study of choice, demonstrates dilation/elongation of the posterior urethra during voiding. Signs of vesicoureteral reflux, if present. Prenatal ultrasound of the upper urinary tract may demonstrate distended and/or thick-walled bladder = bilateral hydroureters = bilateral hydronephrosis = marked vesicoureteral reflux with megaureter oligohydramnios and features of Potter sequence. In severe urinary outflow obstruction, scent treatment: temporary insertion of urinary catheter and correction of electrolyte imbalance. Copyright: first line. Primary valve ablation = an endoscopic procedure that involves the transurethral incision of posterior urethral valves in the membranous part of the urethra. Copyright: A = performed during cystoscopic. Copyright: second line. Vesicostomy: a surgical procedure in which a connection is formed between the bladder and the outside of the lower abdominal wall to allow for the drainage of urine, or if ablation is not possible. Also indicated in patients with functional bladder outlet obstruction, example neurogenic bladder. Copyright: close follow-up due to high risk of chronic kidney disease or renal transplantation may become necessary during the course of disease. Copyright: fetal vesicoamniotic shunting is associated with procedure-related risks without evidence of long-term benefits for renal function. Scent complications: most common cause of chronic renal insufficiency or renal failure in boys. WA and webbed penis. Scent definition: a congenital malformation with growth of the scrotum extending to the tip of the penis, usually only extends to the root of the penis. Copyright: the urethra is typically not affected. Scent clinical features: formation of webbing between the tip of the penis and the scrotum when erect. Copyright: potential erectile dysfunction and ventral deviation. Scent diagnostics. Clinical diagnosis: scent treatment degree, early surgical correction with suturing of the scrotum to the penile shaft, generally for cosmetic reasons. References: H. OE. Sources: last updated February 6, 2024. Back collapse. Find text outline. Abnormalities of the male urethra and webbed penis, 1/2. Hypospadias epispadias blind urethral pit partially formed foreskin, dorsal hood, YY urethra displaced urethral displaced meatus urethral meatus urethra / partially formed D foreskin 7, ventral hood. Hypospadias versus epispadias VV. Copyright Boss. Abnormalities of the male urethra and webbed penis, 2/2. Week 6 Congenital tubercle labia scrotal swelling urogenital fold anus. Development of male external genitalia. Copyright Boss. Week 10 Unglands. Urethral groove. Urethral fold. Scrotal swelling lat. Full term urethral if meatus. Foreskin. Penile shaft. DN scrotum. Abnormalities of the male urethra and webbed penis, 1/3. Hypospadias VV. The external urethral meatus is located on the ventral aspect of the penile shaft instead of its normal location on the glands. Penis. Source: Hypospadias erect front view, Jurgen 88, Wikimedia Commons licensed under public domain. Abnormalities of the male urethra and webbed penis, 2/3. Hypospadias epispadias blind urethral pit partially formed foreskin, dorsal hood, YY urethra displaced meatus urethra. / partially formed D foreskin 7, ventral hood. Hypospadias versus epispadias VV copyright Boss. Abnormalities of the male urethra and webbed penis, 3/3. Full term. Urethral if meatus week 10 equals. I.e. glands plus foreskin. Week 6 urethral. NL genital tubercle groove penile shaft. AR labia scrotal swelling urethral fold urogenital fold MN scrotum. Anus scrotal swelling. Development of male external genitalia VV. Copyright Boss. Abnormalities of the male urethra and webbed penis, 1/1. Normal posterior urethral valves. Kidney. Hydronephrosis. Ureter. Ureter dilation. Bladder. Bladder distension and bladder wall hypertrophy urethra. Obstructed urethra due to posterior urethral membrane penis. Posterior urethral valves VV copyright Boss. Scrotal abnormalities. Scrotal abnormalities include various conditions such as varicoceles, hydroceles, and malpositioning of the testicles, example cryptorchidism, retractile testes. The most common congenital anomaly is cryptorchidism, which involves the incomplete descent of the testicle into the scrotum. The testicle may be located within the abdominal cavity, inguinal canal, or at the external inguinal ring. Cryptorchidism is associated with an increased risk of infertility and or testicular cancer, therefore, early diagnosis and initiation of medical or surgical treatment are essential. Retractile testes usually do not require surgical intervention. A varicocele is the abnormal dilation of the pampiniform vessels within the scrotum. Patients may complain of a dull, aching, and swollen scrotum, typically on the left. A bag of worm sensation may be palpable at the apex of the scrotum. Surgery is required in complicated cases, i.e. concurrent testicular atrophy or infertility, while conservative treatment may be considered in older patients. A hydrocele is a fluid-filled sac derived from the tunica vaginalis or remnant of the processus vaginalis, infantile hydrocele, which results in a painless swelling of the scrotum that occurs at birth or later in life. Typical clinical findings and transillumination confirm the diagnosis. Hydroceles usually resolve spontaneously, but surgery may be indicated in prolonged congenital forms to prevent inguinal hernia. Why? Or cryptorchidism. Definition: failure of one or both testicles to descend to their natural position in the scrotum. 1. Epidemiology: most common congenital anomaly of the genitourinary tract HL. Etiology: unknown, possibly multifactorial. Risk factors: prematurity. Copyright low birth weight. Clinical features: palpable, 80% of cases testicle cannot be manually manipulated into the scrotum. 2. Non-palpable, may be intra-abdominal or absent. Variants: copyright inguinal testis, the testicle is located between the external and internal inguinal ring, preventing adequate mobilization, 90% of cases. Copyright intra-abdominal testis, the testicle is located proximal to the internal inguinal ring. Ascending testes, testicular retraction into the scrotal pouch is possible. However, the testes immediately retract into the groin after manipulation. Scent diagnosis 3 Copyright primarily a clinical diagnosis o laboratory tests equals testosterone. Bilateral cryptorchidism, testosterone levels unilateral cryptorchidism, normal levels, normal Leydig cell function, inhibin B equals TFSH, TLH scent differential diagnosis, testicular atrophy or agenesis plus treatment / 4 Copyright cryptorchidism typically resolves without treatment via spontaneous descent of testicles o persistent cases require surgery, which should be performed as soon as possible after 6 months of age. Dash equals orchiopexy equals open / laparoscopic orchiopexy is used when testes are not palpable in the scrotum. Equals exposure and fastening of the testicle to the scrotum orchiectomy, in cases of non-viable testicular remnants or late discovery of undescended testicle, 2 years, copyright close urological monitoring and early treatment are necessary in individuals with an increased risk of testicular cancer and infertility. Asterisk complications, 1. Copyright testicular cancer, germ cell tumors. The risk of testicular cancer is not eliminated by surgery. Copyright infertility, higher temperature of the abdominal cavity is suboptimal for spermatogenesis oligospermia infertility. Degree testicular torsion copyright inguinal hernia. Back collapse fine text outline. Ectopic testis. Scent definition, the testicle is located outside the normal path of descent, example superficial inguinal pouch, suprapubic region, perineum, femoral canal. Close urological monitoring is necessary, as the risk of testicular cancer and infertility is increased. 7. CE. Retractile testis. Asterisk definition copyright temporary displacement of the testicle in the inguinal canal by the cremasteric reflex copyright the testis may be easily repositioned back into the scrotal pouch. Scent treatment, no treatment is necessary. Z. OX. Varicocele. Scent definition, abnormal enlargement and tortuosity of the pampiniform plexus in the scrotum due to proximal obstruction of the spermatic vein. A plus epidemiology, asterisk copyright most common cause of scrotal enlargement in men copyright found in 15% of healthy men. Etiology copyright idiopathic / primary the cause of primary varicocele is not fully understood. Equals the left testicle is most commonly affected, 85% of cases. The longer course of the left spermatic vein and its insertion at a 90 degrees angle into the left renal vein predisposes to slower drainage and increased hydrostatic pressure. Left renal vein passes between the aorta and superior mesenteric artery. 1. Susceptibility of the renal vein to compression, nutcracker phenomenon, T. Intravascular pressure in the left spermatic vein. Varicocele formation trademark copyright symptomatic / secondary. Asterisk caused by a mass in the retroperitoneal space, Ormond disease, lymphoma, renal cell carcinoma, obstructing venous drainage into inferior vena cava, right. Sided varicocele, or left renal vein, left-sided varicocele, or a thrombotic event, example pampiniform plexus obstruction in renal cell carcinoma, equals persist in the supine position due to a physical obstruction to blood flow within the spermatic vein. Scent clinical features. A painless enlargement may be present. Copyright dull, aching pain of the hemiscrotum, typically left-sided. O heaviness of the affected scrotum. Copyright soft bands / strands are palpable in the upper pole of the affected scrotum, bag of worms. O symptoms worsen when standing or when performing the Valsalva maneuver. O negative transillumination, copyright in rare cases, paresthesia is possible. Scent diagnosis copyright ultrasound, dilated, 2 mm, hypochoy pampiniform vessels trademark copyright in some cases, imaging studies of the retroperitoneum copyright Doppler ultrasonography, to determine the grade of varicocele based on the extent of vein dilation and reflux during Valsalva maneuver. Ca. Grading of varicocele, Sarteska classification, 1. Grade characteristics. Scent no visible varicosity. Grade reflux in vessels of the inguinal channel only when provoked by Valsalva maneuver. Scent stasis and small varicosities up to superior pole of the testes grade IL, V equals AL. Collapse fine text outline. Grading of varicocele, Sarteska classification, 6 grade characteristics. Gaudet scent. No visible varicosity. IRA scent. Reflux in vessels of the inguinal channel only when provoked by Valsalva maneuver. Grade IL stasis and small varicosities up to superior pole of the testes grade SE. C scent. Visible reflux in supratesticular region only during Valsalva maneuver. Asterisk. Dilation of veins at inferior pole of testes in standing position grade IL plus no enlargement in supine position. Scent. Reflux only when provoked by Valsalva maneuver. Scent. Enlarged veins even in supine position grade 4. Scent. Upright position and Valsalva maneuver intensifies dilation. Scent. Possible testicular hypotrophy. Venous enlargement evident in supine and prone position grade V*. Spontaneous basal reflux at rest that does not increase during Valsalva maneuver. Evidence of testicular hypotrophy. Scent treatment. Conservative management, scrotal support. Copyright. Invasive treatment equals indications equals testicular atrophy or delayed growth of the affected testicle in children and adolescents equals pain equals infertility, confirmed with an abnormal sperm analysis. 7 equals procedures. Laparoscopic varicocelectomy, affected dilated testicular vein. Veins, pampiniform plexus, are occluded by ligation equals percutaneous embolization. Scent complications. Copyright. Testicular atrophy and infertility equals sperm is produced in the testicles at 2 degrees Celsius below the average body temperature. Ina varicocele, blood stasis within the scrotum increases local temperature, resulting in a suboptimal environment for spermatogenesis. CS2. Copyright. Always perform an ultrasound of both testicles when varicocele is suspected, as the condition may occur bilaterally. Copyright. A unilateral right-sided varicocele is uncommon and should raise suspicion of a mass in the retroperitoneal space, Ormond disease, lymphoma, renal cell carcinoma, blocking the spermatic vein. CE. Hydrocele. Scent definition, painless accumulation of fluid in a sac around one or both testicles which derives from the tunica vaginalis, a tissue covering the testes. Scent etiology. Copyright. Idiopathic, most common. Copyright. Congenital hydrocele equals communicating hydrocele equals occurs due to the failed closure of the processus vaginalis during development, usually discovered in infancy. Non-communicating hydrocele, no connection to the peritoneal cavity present. EO acquired hydrocele equals secondary to underlying pathology, example trauma, tumor, torsion, infection. Wuchereria bancrofti infection is the most common cause worldwide, but virtually non-existent in the US, see lymphatic filariasis. Scent clinical features. Fluctuant, painless swelling of affected scrotum. May be present since infancy or childhood. May or may not be reducible. Copyright. Positive transillumination. Copyright. Palpation above the swelling is possible, a normal spermatic cord and inguinal ring are present. Asterisk. Diagnosis. Usually a clinical diagnosis. V equals ALD. Collapse fine text outline. Copyright. Always perform an ultrasound of both testicles when varicocele is suspected, as the condition may occur bilaterally. A unilateral right-sided varicocele is uncommon and should raise suspicion of a mass in the retroperitoneal space, Ormond disease, lymphoma, renal cell. Copyright. Carcinoma, blocking the spermatic vein. OE. Hydrocele. Scent definition, painless accumulation of fluid in a sac around one or both testicles which derives from the tunica vaginalis, a tissue covering the testes. Scent etiology. Copyright. Idiopathic, most common. Copyright congenital hydrocele equals communicating hydrocele equals occurs due to the failed closure of the processus vaginalis during development equals usually discovered in infancy non-communicating hydrocele, no connection to the peritoneal cavity present. 1 Copyright acquired hydrocele secondary to underlying pathology, example trauma, tumor, torsion, infection. Wuchereria bancrofti infection is the most common cause worldwide, but virtually non-existent in the U.S., see lymphatic filariasis. Scent clinical features. Copyright fluctuant, painless swelling of affected scrotum may be present since infancy or childhood equals may or may not be reducible. Copyright positive transillumination, copyright palpation above the swelling is possible, a normal spermatic cord and inguinal ring are present. Scent diagnosis, 8. Usually a clinical diagnosis. Ultrasound, hypochoy fluid confirms the diagnosis. Scent differential diagnosis. Copyright testicular tumor, negative transillumination test, copyright inguinal hernia. Scent treatment, congenital hydrocele usually resolves spontaneously within 6 months of birth. 9 Copyright indications for surgery if spontaneous resolution does not occur by 1 year of age, excessive discomfort and/or if scrotal skin integrity is compromised. Underlying pathology suspected equals testicle not palpable equals if infertility is a concern. 0. Procedures equals hydrocelectomy equals performed to correct a hydrocele and prevent its recurrence equals indicated for the reduction of large or thick-walled hydroceles involves incision and complete/partial resection of the hydrocele sac, tunica vaginalis, equals percutaneous aspiration of the hydrocele fluid combined with installation of a sclerosing promoter into the sac. A hydrocele must be differentiated from an inguinal hernia. Seer. Sources. Last updated August 29, 2023. V equals A. Collapse. Find text. A. Outline. Uroscrotal abnormalities, 1/1. Normal hydrocele spermatocele. IA/VA/4Y equals 4. F equals positive E. A transillumination test S. Pampani. /form testicular tumor. /plexus. /WT epididymis. /WH/X /testis/ YSSYOG. /parietal layer tunica. Equals vaginalis cavity, potential space, negative. Visceral layer transillumination test S$. Overview of scrotal abnormalities VV. Copyright emboss. //EY abdominal testis. Law, AP/inguinal testis. Suprascrotal testis US. Cryptorchidism VV. Failure of one or both testicles to descend to their natural position in the scrotum. Most common variations, from top to bottom. Abdominal testis, blue. The testicle is located proximal to the internal inguinal ring. Inguinal testis, green. The testicle is palpable and located inside the inguinal canal between the external and internal inguinal ring, preventing adequate mobilization, 90% of cases. Suprascrotal testis, purple. Testicular retraction into the scrotal pouch is possible, however, the testes immediately retract into the groin after manipulation. Copyright emboss. Unilateral cryptorchidism and anal atresia VV. Perineal view of a 5-month-old boy. While the left testicle is visible in the scrotum, the right testicle cannot be seen. On examination, the incompletely descended right testicle was palpable in the inguinal canal. Anal atresia, absence of an anal opening, can also be seen in this picture. Source, Figure 2, in, high anorectal malformation in a 5-month-old boy, A case report by A. Pandey, A. N. Gangopathyay, V. Kumar, S.P. Sharma, BMC, Journal of Medical Case Reports, licensed under CC by 2.0. Modifications, image cropped, time removed. Penile ectopic testis. 7. Perineal femoral ectopic testis. Ectopic testis VV. A congenital abnormality, where the testicle is located outside the normal path of descent. The most common locations in descending order, on top of the external oblique aponeurosis, inguinal epiphyseal ectopia, 70%, the anterior root of the penis, penile ectopia, the perineum, perineal ectopia, the femur, femoral ectopia, copyright emboss. 0. SE. Y trademark AYJ retractile testis yo ////. Retractile testis. Temporary displacement of the testicle in the inguinal canal by the cremasteric reflex. The testis may be easily repositioned back into the scrotal pouch. Copyright emboss. Pampiniform plexus. Varicocele VVA. Varicocele is a dilatation of the pampiniform venous plexus in the scrotum. Copyright emboss. Left inferior phrenic vein. Hepatic veins. Left inferior phrenic artery. Inferior vena cava. Venovenous anastomosis. Right suprarenal vein. Left superior suprarenal artery. Left middle suprarenal artery. Left inferior suprarenal artery. Left suprarenal vein. WZVA. ZLSE, AE. Celiac trunk. Superior mesenteric artery. Right renal artery. LART. Right renal vein. Left renal artery. Left renal vein. Left lumbar arteries and veins. I4. Inferior mesenteric artery. Left testicular/ovarian vein/artery. Right testicular/ovarian vein/artery. Left common iliac artery. Left common iliac vein. Abdominal aorta and inferior vena cava VV. Branches OT. The abdominal aorta, 3 single anterior branches, celiac artery, superior mesenteric artery, and inferior mesenteric artery, 8 paired lateral branches, right and left inferior phrenic arteries, middle suprarenal arteries, renal arteries, gonadal, testicular/ovarian, arteries, and 4 pairs of lumbar arteries, 3 terminal branches, right and left common iliac arteries and the median sacral artery, the latter is not shown in the image. Tributaries of the inferior vena cava, main confluencing tributaries, right and left common iliac veins and the median sacral vein, lateral tributaries, bilateral renal veins, right gonadal vein, the left gonadal vein drains into the left renal vein, right suprarenal vein, the left suprarenal vein drains into the left renal vein, lumbar veins, and inferior phrenic veins, anterior tributaries, hepatic veins. Note, as the left renal vein passes in front of the aorta, underneath the superior mesenteric artery, it is susceptible to compression between these structures, known as nutcracker phenomenon. Varicocele VV. Swelling of the left hemiscrotum with prominent tortuous veins and shiny appearance of the scrotal skin. Unlike secondary varicoceles, example due to a renal tumor, idiopathic varicoceles are usually more pronounced when the patient is standing up and disappear when he lies down. Source: Varicocele 1, TACO, Wikimedia Commons licensed under public domain. A. B. Varicocele VV. Ultrasound of the scrotum. Dilated pampiniform veins can be seen within the left scrotum, causing enlargement. Image A. Doppler sonography, Image B, shows the venous reflux. These findings are characteristic of varicocele. Source: Sonography of the scrotum by Chi Wei Mak and Wen Shengsen, Intech, licensed under CC by 3.0. Modifications: removed letters. Hydrocele VV. Pronounced swelling of the right hemiscrotum. Hydrocele is confirmed via detection of an anechoic fluid collection on ultrasound. Additional diagnostics may be indicated to rule out any underlying conditions, such as tumors or infections, depending on the individual patient, that may be causing hydrocele. This image is an adaptation. Source of original image, Wikimedia Commons. Original title, Hydrocele. Created by Tony Frizina. Licensed under public domain. Modifications to original image, cut off the white area at the bottom, contained rather limited information. Uroscrotal abnormalities, 2 halves. Normal. Parietal layer tunica cavity, potential space, vaginalis, visceral layer. Hydrocele. A hydrocele is an accumulation of fluid within the tunica vaginalis of the scrotum. Copyright Emboss. Hydrocele. X. Nephrolithiasis. Nephrolithiasis encompasses the formation of all types of urinary calculi in the kidney, which may be deposited along the entire urogenital tract, from the renal pelvis to the urethra. Risk factors include low fluid intake and high sodium, high purine, low potassium diets, which can raise the calcium, uric acid, and oxalate levels in the urine and thereby promote stone formation. Urinary stones are most commonly composed of calcium oxalate. Less common stones are composed of uric acid, struvite, due to infection with urease-producing bacteria, calcium phosphate, or cysteine. Nephrolithiasis manifests as sudden onset colicky flank pain that may radiate to the groin, testes, or labia, commonly called renal or ureteric colic, and it is usually associated with hematuria. Diagnostics include spiral CT without contrast and / or ultrasound of the abdomen and pelvis to detect the stone, as well as urinalysis to assess for concomitant urinary tract infection, UTI, and serum bun and creatinine to evaluate kidney function. Small stones that do not require urgent urological intervention can be managed with symptomatic treatment and a trial of medical expulsive therapy to promote spontaneous passage. If spontaneous passage appears unlikely or fails because of the size or location of the stone, first-line urological interventions include shockwave lithotripsy, ureteronoscopy, and, in patients with large kidney stones, percutaneous nephrolithotomy. The most important preventive measure is adequate hydration. In addition, the analysis of past stones may provide information to guide dietary changes and / or medical therapy, example thiazide diuretics, urine alkalinization, that can prevent future stone formation. WA X Epidemiology * sex, 79 ll. Cent peak incidence, 45 to 70 years. 1 cent risk factors for nephrolithiasis, see classification below. Copyright personal or family history. Copyright low fluid intake, dehydration. Copyright loop diuretics. Copyright post-colectomy and / or post-ileostomy. Epidemiological data refers to the U.S., unless otherwise specified. ZG Fay, SECS. Classification. Overview of kidney stones. Types. Incidence. Etiology / associated findings. Urine pH. Crystal api. Hypercalciuria. Hyperoxaluria. Hypocitraturia can result from increased intake of biconcave dumbbells or calcium oxalate, degree 75% * varies. 2. Radiopaque stones. Degree ethylene glycol, antifreeze, in bipyramidal envelopes. 1. PAD. Copyright vitamin C associated with inflammatory bowel disease, i.e., ulcerative colitis, and Crohn's disease due to malabsorption. Scent gout, hyperuricemia, and hyperuricosuriae. J. Urine pH, acidic, and volume plus rounded rhomboids or uric acid stones. * 10%. * radiolucent. * high cell turnover, example leukemia, chemotherapy, often seen in desert climates, rosettes. Degree equals 5 equals UTI with urease producing bacteria, example Proteus mirabilis, S, rectangular prisms, coffin lid plus weakly strivite stones, 7 urine pH, alkaline, A, 10% saprophyticus, Klebsiella, appearance, radiopaque. Calcium scent hyperparathyroidism. _7 colonase urine pH, alkaline plus wedge-shaped PRI, A radiopaque phosphate stones * type 1 renal tubular acidosis pH, EES degree PAG. Plus. Xanthine stones * xanthinuria, hereditary, scent generally independent of urine pH * amorphous * radiolucent. B urine alkalizers, example potassium citrate, prevent stones that form in acidic urine. Urine acidifiers, example cranberry juice, betaine, prevent stones that form in alkaline urine. Calcium oxalate stones 3. Scent types WV. Back collapse fine text outline. Calcium oxalate stones /31. Scent types degree calcium oxalate monohydrate, light brown or black calculi calcium oxalate dihydrate, wet light yellow calculi etiology degree. Hypercalciuria, presence of elevated calcium levels in the urine. G2 hyperoxaluria, presence of elevated oxalate levels in the urine equals dehydration equals increased intake of dietary oxalate. CI increased intestinal absorption of oxalate, example due to fatty acid malabsorption, example Crohn di, ulcerative colitis, short bowel syndrome. Equals in conditions associated with fatty acid malabsorption due to impaired bile acid reabsorption, calcium preferentially binds free fatty acids, leading to excess free oxalate and, therefore, to increased oxalate absorption. A. Vitamin C supplements, equals ethylene glycol poisoning. 14 pyridoxine deficiency, 5 equals obesity. Hypocitraturia, decreased level of citrate in the urine. Hyperuricosuriya, increased urinary excretion of uric acid. Develop in persistently acidic urine. Scent diagnosis degree urine microscopy, dumbbell-shaped or octahedron-shaped crystals. X-ray, or CT radiopaque stones * treatment 6IL7 degree. Hydration dietary modification reduced intake of salt, mainly sodium, and animal protein reduced intake of oxalate-rich foods and supplemental vitamin C * calcium intake should not be restricted. Restriction increases risk of hyperoxaluria, and thereby, the risk for osteoporosis. 1 thiazide diuretics for recurrent calcium-containing stones with idiopathic hypercalciuria, i.e., no hypercalcemia. 1 urine alkalinization, example with potassium citrate, possibly citrate. Supplementation. And Crohn disease leads to increased oxalate absorption via malabsorption of fatty acids, which can ultimately cause nephrolithiasis. Uric acid stones. Scent etiology degree. Hyperuricemia and hyperuricosuriya equals gout equals high cell turnover, example tumor lysis syndrome, myelodysplastic syndrome, diabetes mellitus, metabolic syndrome. Chronic diarrhea. 4 urine volume, example due to dehydration, often seen in desert climates, develop in persistently acidic urine. Is scent diagnosis degree urine microscopy, rhomboid/needle-shaped crystals. X-ray, radiolucent stones. CT, can be visible but are usually only minimally visible, not as visible as calcium stones. USN/or intravenous pyelogram may also be helpful in diagnosis. Scent treatment degree hydration. Oral chemolytholysis, example potassium citrate, via urine alkalinization. Follow purine diet. Allopurinol. Uricosuric agents, example probenecid, increase the excretion of uric acid, which can accelerate the formation of stones. Copyright uric acid stones are radiolucent, X-ray negative. V. Back collapse fine text. A. Outline. Struvite stones, magnesium ammonium phosphate stones. Scent etiology. O upper UTI with urease-producing bacteria such as Proteus mirabilis, Klebsiella, Staphylococcus saprophyticus, and /or Pseudomonas equals. These bacteria convert urea to ammonia, elevated ammonia causing alkaline urine, precipitation of the ammonium magnesium phosphate salt crystal, and stone formation equals can form very large stones that fill the entire renal pelvis and calyces. Staghorn calculi. Copyright use of indwelling catheter increases risk. 1. Copyright develop in persistently alkalic urine. Diagnosis. Copyright urine microscopy, rectangular prisms, coffin lid appearance, indicates struvite stones. O X-ray, or CT, equals weakly radiopaque stones, possibly staghorn calculi. Scent treatment. Copyright antibiotic treatment of urinary tract infections. O hydration. Copyright urine acidification. O usually requires surgical stone removal. QB urinary tract infections can lead to the formation of struvite stones, but struvite stones also increase the risk of urinary tract infections. Calcium phosphate stones / degree 1. Types. Copyright carbonate appetite. O brushite etiology. O hyperparathyroidism, brushite, copyright type 1 renal tubular acidosis, brushite. O upper urinary tract infections, carbonate appetite, develop in persistently alkalic urine. Diagnosis. O urine microscopy, wedge-shaped crystals. A copyright X-ray, or CT radiopaque stones. Prevention. O hydration. Copyright thiazide diuretics. Copyright diet low in sodium. Copyright urine acidification, carbon appetite stones. Cystine stones, 91. Scent etiology. O autosomal recessive defect in cystine reabsorbing PCT transporter, impaired proximal renal tubular absorption of dibasic amino acids. Cystinuria. Cystine stone formation, as cystine is poorly soluble. O develop in persistently acidic urine. Scent clinical features, recurrent kidney stones, manifesting with example flank pain, starting in childhood. Scent diagnosis. Copyright urine microscopy, hexagonal crystals. O X-ray, or CT, equals weakly radiopaque stones equals possibly staghorn calculi. Copyright positive cyanide nitroprusside test, prevention. Hydration. Copyright diet low in sodium. O urine alkalinization degree. Chelating agents, e.g. penicillamine, for refractory cases. Copyright giapronin IV. Back collapse. Fine text outline. And to remember that cystine crystals are hexagonal, think the Sistine Chapel has 6 sides. Xanthine stones. Scent etiology, xanthinuria. Copyright hereditary deficiency of xanthine oxidase, failure to convert xanthine to uric acid. Copyright allopurinol. Scent diagnosis. O urine microscopy, amorphous crystals. Copyright urine pH, plays little role in diagnosis. 20. Copyright X-ray, radiolucent stones, require further evaluation with CT, US, and / or intravenous pyelogram. Scent treatment, reduced dietary intake of purines. Drug-induced stones can be caused by scent crystallization of drug compounds in the urine, which is most commonly associated with copyright aciclovir. Copyright indinavir. Copyright sulfonamides. Copyright fluoroquinolones. Copyright ceftriaxone. Stone formation due to alterations in urine composition, which are most commonly associated with copyright acetazolamide. O furosemide. Copyright topiramate. O vitamin D, vitamin A. O aluminium magnesium hydroxide. Copyright calcium. OI. 2 shared. Clinical features. Stones usually form in the collecting ducts of the kidneys but may be deposited along the entire urogenital tract from the renal pelvis to the urethra. Their localization and size determine the specific symptoms. Small kidney stones may also be asymptomatic and detected incidentally. 11. Plus severe unilateral and colicky flank pain, renal colic. 12 radiates anteriorly to the lower abdomen, groin, labia, testicles, or perineum. Copyright paroxysmal or progressively worsening. 13 Copyright the area around the kidneys may be tender on percussion, costovertebral angle tenderness, scent hematuria, nausea, vomiting, and reduced bowel sounds. A. Scent dysuria, frequency and urgency. Passage of gravel or a stone. Patients are usually unable to sit still and move around frequently, opposed to patients with peritonitis, who usually prefer to lie still. And depending on the location of the stone, nephrolithiasis may resemble conditions such as appendicitis or testicular torsion. Diagnostics. Approach 14-15-16. V. Back collapse. Find text outline. Diagnostics. Approach 14-15-I-16. Asterisk clinical suspicion. Consider nephrolithiasis in patients with unilateral colicky flank pain associated with nausea, vomiting, and/or hematuria. Sent initial diagnostics. Copyright laboratory studies, CBC, BMP urinalysis, BHCG. Copyright imaging studies, CT abdomen and pelvis without contrast preferred if imaging is indicated. Sent further evaluation. O. Determine stone composition. Copyright identify metabolic risk factors with a dietary history and laboratory studies. Laboratory studies, 4LL15. Asterisk CBC, TWBC compound 1, 7 plus BMP. Copyright typically within normal limits. O. Elevated BUN and creatinine suggest an acute kidney injury. Urinalysis, 5117. Sent nonspecific findings of nephrolithiasis. Copyright gross or microscopic hematuria. Copyright crystalluria. Asterisk nonspecific urinalysis findings of UTI, example positive leukocyte esterase or nitrites, leukocyturia, bacteriuria. Sent findings suggestive of stone composition. Copyright alkaline urine, pH 7.5 to 8, suggests struvite stones associated with urease producing organisms. 81L19. Copyright acidic urine, pH. Imaging studies 211L22I23. In general, an initial presentation suspicious for nephrolithiasis requires confirmatory CT imaging. Imaging is also indicated for acute flank pain of uncertain etiology, example to rule out AAA. Copyright CT abdomen and pelvis without contrast and ultrasound of the abdomen and pelvis are the preferred diagnostic tests for nephrolithiasis in patients for whom imaging is indicated. CT abdomen and pelvis without for contrast. CT has the highest accuracy of the imaging modalities to identify kidney stones. Sent indication, first line for non-pregnant patients with suspected nephrolithiasis. E findings. Copyright calculus size, location, density, and degree of obstruction. O hydronephrosis and/or hydroureter. O paranephric fat stranding. Ultrasound abdomen and pelvis. Indications, suspected nephrolithiasis in patients for whom radiation exposure should be minimized, example pregnant patients, pediatric patients, those with recurrent stones. E findings. Copyright obstructive uropathy, example hydronephrosis, hydroureter, paranephric fluid. Copyright stone, hyperechoic signal with acoustic shadowing = 17. X-ray kidney, ureter, and bladder, KUB. Sent indications, follow-up for previously identified radiopaque stones after the initiation of treatment. Sent findings, radiographic densities, example stones. And because KUB sensitivity is proportional to stone size, it is usually only suitable for larger stones. V. Back collapse. Find text outline. Intravenous pyelogram, IVP. Sent indications, rarely indicated given the broad availability of CT. Sent findings. 5. Copyright provides a complete outline of the urinary tract system. Copyright size and location of stone, degree of obstruction. Differential diagnoses. Sent pain. Copyright causes of acute abdomen, see differential diagnoses of acute abdominal pain. Copyright causes of acute back pain, e.g., see non-spinal causes of acute back pain. O causes of testicular pain, see differential diagnosis of scrotal pain. Sent other findings or clinical features. Copyright causes of hydronephrosis, see upper urinary tract obstruction. Copyright urinary tract infection, cystitis I or pyelonephritis. For copyright see also hematuria. The differential diagnoses listed here are not exhaustive. 2 asterisk. OQO. Treatment. Approach 221I-28. Initiate symptomatic management prior to confirmatory imaging for patients with renal colic. Sent consult urology urgently for interventional treatment in the following cases. Copyright uncontrolled symptoms, example intractable pain, inability to tolerate PO, large stones, 10 mm, copyright infected kidney stones, example signs of sepsis in combination with high-grade obstruction, acute renal failure. Copyright solitary kidney or kidney transplant with obstruction. Attempt a trial of conservative management for patients with small. And the larger the stone, the less likely it is to pass spontaneously. Symptomatic management, 171I-22. Analgesia. Copyright first line, NSAIDs, example ketorolac. Copyright second line, opioids, example morphine, antiemetics, example ondansetron. Intravenous fluids for dehydration. Conservative management 22-28. Asterisk. Initiate medical expulsive therapy, MET. First line, tamsulosin, alpha blocker, equals relieves ureter muscle spasms, equals promotes the passage of ureteral stones. Interventional management 28 QVA. Back collapse. Q. Find text. Al. Outline. Interventional management 128. Overview. Ureteral stones. Copyright ureteronoscopy, URS. First line for mid or distal ureter stones. Degree or extracorporeal shockwave lithotripsy, ESWL, 1 renal stones 20 mm or lower renal pole stones 10 mm, percutaneous nephrolithotomy, PCNL. Procedures. Lithiacy 301I-28. Logical inter-I for nephro intervention. Description. Extracorporeal shockwave lithotripsy. Acoustic shockwaves used to fragment stones, non-invasive, ESWL, asterisk. Stones are localized using fluoroscopy or ultrasound. Sent transurethral endoscopic visualization of the upper urinary tract with a rigid or flexible endoscope used for stone extraction and intraureteral ureteronoscopy, URS, lithotripsy, minimally invasive, I commonly combined with temporary ureteral stenting. Percutaneous insertion of a nephroscope into the renal pelvis under ultrasonographic and/or fluoroscopic guidance to remove stones, minimally PFROLITH, PCNL, invasive, can be combined with lithotripsy. Open, laparoscopic, or robotic surgery, invasive, ureterolithotomy. An incision is made into the ureter and the stone is removed. E.j. Yifei, Co. Complications. Sent recurrent urinary tract infections. Risk of pyelonephritis, urosepsis, and paranephric abscess. Sent urinary obstruction. Inflammation of the kidney and hydronephrosis, dash. Permanent glomerular damage if left untreated. Asterisk. Acute kidney injury. 7. We list the most important complications. The selection is not exhaustive. Yoir FO, SUS. Prognosis. Stone size and location determine the likelihood of spontaneous passage. Stones. WA. Yes. Prevention. Sent hydration, sufficient fluid intake, 2.5 L/day, sent diet O for calcium. Stones, reduced consumption of salt and animal protein. /31 Reduced consumption of oxalate-rich foods and supplemental vitamin C, for oxalate. Stones, 821I-83 equals calcium intake should not be restricted. Restriction increases risk of hyperoxaluria, and thereby, the risk for osteoporosis. Copyright for uric acid stones, low in purine O for cystine stones, low in sodium scent chemoprophylaxis degree calcium stones. Thiazide diuretic for recurrent calcium-containing stones with idiopathic hypercalciuria, i.e., no hypercalcemia, 3134 allopurinol in the case of high urine uric acid. Copyright uric acid stones, allopurinol 3. Copyright cysteine stones, sheapronin. Copyright struvite stones, antibiotic treatment for UTIV. Back collapse. Fine text outline. Prevention. Plus hydration, sufficient fluid intake, equals 2.5 L/day, 81% diet. O for calcium stones, reduced consumption of salt and animal protein, 231 reduced consumption of oxalate-rich foods and supplemental vitamin C, for oxalate stones. 3233 * calcium intake should not be restricted, restriction increases risk of hyperoxaluria, and thereby, the risk for osteoporosis. Copyright for uric acid stones, low in purine. O for cysteine stones, low in sodium chemoprophylaxis. Copyright calcium stones. Thiazide diuretic for recurrent calcium-containing stones with idiopathic hypercalciuria, i.e., no hypercalcemia, 1811 I34 equals allopurinol in the case of high urine uric acid. Copyright uric acid stones, allopurinol 31, copyright cysteine stones, sheapronin. Copyright struvite stones, antibiotic treatment for UTI. Scent change. Urinary pH, depends on stone composition. Copyright urine alkalinization, a treatment regimen to raise urinary pH to 6.5 to 7.5. Equals achieved via diet rich in fruits and vegetables or supplementation of potassium citrate. Used to prevent recurrence of calcium oxalate, uric acid, and cysteine stones. AO urine acidification, a treatment regimen to lower the urinary pH to at low calcium diets increase the risk of calcium-containing stone formation because they increase oxalate reabsorption. OOEI. Special patient groups. Nephrolithiasis in pregnancy. Epidemiology, 1:3000 pregnancies. 35136, risk factors. Copyright percent calcium excretion, excretion of magnesium and citrate. FAO. Urine pH. O urinary stasis due to hormonal changes, example due to increased progesterone levels. O late pregnancy. J fluid intake resulting from bladder capacity due to altered position and increasing size of uterus. Scent clinical features, see above. Diagnostics, renal ultrasonography is preferred. Scent treatment. Copyright focuses on pain control because the majority of stones pass spontaneously. For details on analgesia during pregnancy, see overview of analgesics to avoid during pregnancy. Copyright surgical interventions are similar to those for non-pregnant individuals, see conservative management and interventional management in treatment. OS. CE. Related 1-minute telegram. Sent 1-minute telegram 71-2023-3/3, Nostone left unturned. Interested in the newest medical research, distilled down to just 1 minute. Sign up for the 1-minute telegram in tips and links below. 6. Tips and links. Sources. Last updated February 7, 2024 v. Back collapse. Fine text outline. Overlay. Calcium oxalate crystals in urine VV. Photomicrograph of a urine sample, urine sediment wet mount, intermediate magnification, multiple envelope-shaped crystals can be seen, cf illustration, examples indicated by yellow overlay, throughout the sample. These are composed of calcium oxalate dihydrate and have an octahedral structure. Source: the micrograph shows calcium oxalate crystals in urine. These small crystals can develop to form renal stones. NASA, NASA/JSC, NASA licensed under public domain. Further notes, NASA CC, https://www.nasa.gov/multimedia/guidelines/index.html. Copyright Overlay. Calcium oxalate crystals in urine VV. Photomicrograph of a urine sample, urine sediment wet mount, intermediate magnification, multiple envelope-shaped crystals can be seen, cf. illustration, examples indicated by yellow overlay, throughout the sample. These are composed of calcium oxalate dihydrate and have an octahedral structure. Source: the micrograph shows calcium oxalate crystals in urine. These small crystals can develop to form renal stones. NASA, NASA/JSC, NASA licensed under public domain. Further notes, NASA CC, https://www.nasa.gov/multimedia/guidelines/index.html. C. Nephrolithiasis, 2/7. Uric acid crystals. Photomicrograph of a urine sample with a pH of 5, phase contrast microscopy, high magnification, multiple crystals of varying sizes and shapes can be seen, blue overlay. Their diamond-shaped, rhomboid, form is one of the characteristic appearances of uric acid crystals, which only form in urine samples with a pH R/RRA, A, PFFSSSEYENISNSWZEYIL equals star. MPs equals RYALE equals BA. AA equals WY-FI-IA. 7 Fa YS/NCC at a /1 HAZ. PFN. MPOE, 4 foot J7s J, SE. /RAAV. I. A. /. EESSRISS asterisk SAR OASSS, A. 3 equals SSRAS if underscore /EELY /4 WA. Amon /JY/ underscore trademark 50 microns /S can Z Wi-Fi ETS, 42A, S. /A4 IE equals EE New York /LAE. G. Overlay. Struvite crystals VV. Photomicrograph of a canine urine sample. Sample shows clear, euhedral, rectangular prism crystals, struvite crystals with their characteristic coffin lid appearance, cf. Illustration, examples indicated by green overlay, composed of magnesium, ammonium, and phosphate. In humans, struvite crystals are only seen in upper urinary tract infections caused by urease-producing organisms, example Proteus or Klebsiella species. Source: Struvite Crystals Dog with Scale 1 by Joel Mills, Wikimedia Foundation, licensed under CC by SA 3.0. Nephrolithiasis, 3/7. PA/N in equals JF V /Rem /So TF MS EBOS /SZ /RAP ARI, A, MA DOS yen SX, /E2 and equals 4 XJ, A, Y, plus HSA. A. 1 SY, _2 IA. Li N. A yen I /SSF as IE. 4, MT. A TE Rev, 4Y75 / incent jump 4 XIYRRNE, on, mast, RASN, re, if. /YNG yen %FF equals X lay 7 AF. SN. I4. _50 microns /SFMITSWD, /Pi Re, Me OS. X /NFA. Overlay. Struvite crystals. Photomicrograph of a canine urine sample. Sample shows clear, euhedral, rectangular prism crystals, struvite crystals with their characteristic coffin lid appearance, cf. Illustration, examples indicated by green overlay, composed of magnesium, ammonium, and phosphate. In humans, struvite crystals are only seen in upper urinary tract infections caused by urease-producing organisms, example Proteus or Klebsiella species. Source: Struvite Crystals Dog with Scale 1 by Joel Mills, Wikimedia Foundation, licensed under CC by SA 3.0. Calcium phosphate crystals. Photomicrograph showing crystals with the appearance of wedge-shaped prisms, can also be described as blunt-ended needles, some bound together forming a rosette. Source: VVV Calcium Phosphate Rosette by Kayla Devine, Flickr, licensed under CC by 20. LLAEN /SY, AAF. 5 Cystine crystals. Photomicrograph of cystine crystals from a canine urine sample, 1000x magnification, a clump of multiple, clear, hexagon-shaped crystals is visible. This is the characteristic appearance of cystine crystals. Source: Cystine crystals in canine urine sediment.jpg by Lance Wheeler, Wikimedia Commons, licensed under CC by SA 4.0. Modifications: image was cropped. Nephrolithiasis, 6/7. Calcium oxalate crystals. Urine microscopy. Clumps of dumbbell-shaped calcium oxalate monohydrate crystals can be seen, yellow overlay. An envelope-shaped, octahedral, calcium oxalate dihydrate crystal, black arrowhead, and multiple erythrocytes, examples indicated by white arrowheads, are also present. Calcium oxalate stones are the most common type of kidney stones. Source: Calcium oxalate crystals, urine, calcium oxalate crystallary, IDRUR, by Deruxalan C., Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Staghorn calculus VV. X-ray abdomen, AP view. A large branching structure is seen within the renal pelvis and several enlarged calyces, green overlay. The appearance is typical of a struvite staghorn calculus. The term staghorn calculus is used when at least two calyces are involved, giving rise to the appearance of a stag's antlers. Struvite calculi are caused by urease-producing bacteria. Calcium carbonate precipitates with struvite to form large calculi that are radiographically visible and conform to the renal collecting system. Severe lumbar rotatory scoliosis is also seen on the radiograph. P. Renal pelvis, VB, vertebrae. Source: Staghorn kidney stone 08779 by Nevitt Dillman, Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Staghorn calculus VV. X-ray abdomen, AP view. A large branching structure is seen within the renal pelvis and several enlarged calyces, green overlay. The appearance is typical of a struvite staghorn calculus. The term staghorn calculus is used when at least two calyces are involved, giving rise to the appearance of a stag's antlers. Struvite calculi are caused by urease-producing bacteria. Calcium carbonate precipitates with struvite to form large calculi that are radiographically visible and conform to the renal collecting system. Severe lumbar rotatory scoliosis is also seen on the radiograph. P. Renal pelvis, VB, vertebrae. Source: Staghorn kidney stone 08779 by Nevitt Dillman, Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Non-obstructive renal calculus, 1/2. CT abdomen, with oral contrast, axial plane, the calcific density, circled, in the left renal pelvis is a calculus. There is no dilatation of the renal pelvis to indicate obstruction. Atherosclerotic calcification, red arrowhead, of the abdominal aorta is seen. Metal streak artifacts, examples indicated in green, over the spine are caused by an internal spinal fixator, white arrows. A. Aorta, IVC, inferior vena cava, K, kidney, L, liver are great thanks to Dr. Kissig, Center for Diagnostic and Interventional Radiology, Hedwig, St. Hedwig, Berlin, and St. Joseph's Hospital, Potsdam, for kindly providing this image. Copyright. Overlay. Non-obstructive renal calculus, 1/2. CT abdomen, with oral contrast, axial plane, the calcific density, circled, in the left renal pelvis is a calculus. There is no dilatation of the renal pelvis to indicate obstruction. Atherosclerotic calcification, red arrowhead, of the abdominal aorta is seen. Metal streak artifacts, examples indicated in green, over the spine are caused by an internal spinal fixator, white arrows. A. Aorta, IVC, inferior vena cava, K, kidney, L, liver are great thanks to Dr. Kissig, Center for Diagnostic and Interventional Radiology, Hedwig, St. Hedwig, Berlin, and St. Joseph's Hospital, Potsdam, for kindly providing this image. Overlay. Non-obstructive renal calculus, 2/2. CT abdomen, with oral contrast, coronal plane, a non-obstructive hyperdense calculus, red circle, is present in the left renal pelvis. Atherosclerotic calcifications, red arrowheads, of the abdominal aorta, red overlay, are also seen. Metal streak artifacts, white arrows, between the aorta and inferior vena cava, blue overlay, are caused by an internal spinal fixator. K and dashed lines, kidney, liver, lung, PM, psoas major muscle, S, stomach with oral contrast, UB, urinary bladder are great thanks to Dr. Kissig, Center for Diagnostic and Interventional Radiology, Hedwigshohe, St. Hedwig, Berlin, and St. Joseph's Hospital, Potsdam, for kindly providing this image. Nephrolithiasis, 2/6. Copyright. Overlay. Non-obstructive renal calculus, 2/2. CT abdomen, with oral contrast, coronal plane, a non-obstructive hyperdense calculus, red circle, is present in the left renal pelvis. Atherosclerotic calcifications, red arrowheads, of the abdominal aorta, red overlay, are also seen. Metal streak artifacts, white arrows, between the aorta and inferior vena cava, blue overlay, are caused by an internal spinal fixator. K and dashed lines, kidney, liver, lung, PM, psoas major muscle, S, stomach with oral contrast, UB, urinary bladder are great thanks to Dr. Kissig, Center for Diagnostic and Interventional Radiology, Hedwig, St. Hedwig, Berlin, and St. Joseph's Hospital, Potsdam, for kindly providing this image. Overlay. Ureterolithiasis with obstructive uropathy. CT abdomen, with contrast, coronal plane, the left renal collecting system, green overlay, is dilated to the level of a hyperdense calculus, yellow overlay, within the proximal third of the ureter. The left renal parenchyma shows less enhancement than the right renal parenchyma as a result of impaired excretion from ureteral obstruction. Blue overlay, inferior vena cava, red overlay, abdominal aorta are great thanks to Dr. Kissig, Center for Diagnostic and Interventional Radiology, Hedwig, St. Hedwig, Berlin, and St. Joseph's Hospital, Potsdam, for kindly providing this image. Copyright. Overlay. Ureterolithiasis with obstructive uropathy. CT abdomen, with contrast, coronal plane, the left renal collecting system, green overlay, is dilated to the level of a hyperdense calculus, yellow overlay, within the proximal third of the ureter. The left renal parenchyma shows less enhancement than the right renal parenchyma as a result of impaired excretion from ureteral obstruction. Blue overlay, inferior vena cava, red overlay, abdominal aorta are great thanks to Dr. Kissig, Center for Diagnostic and Interventional Radiology, Hedwig, St. Hedwig, Berlin, and St. Joseph's Hospital, Potsdam, for kindly providing this image. Overlay. Hydronephrosis. Ultrasound left kidney, longitudinal plane, the calyces, green overlay, are dilated and have lost their normal cup-shaped appearance. Flattening of papillae and blunting of fornices can be seen. Where visible, the renal cortical parenchyma is not thinned. RP, renal parenchyma, arrowheads, hyperechoic renal sinus source, ultrasonographic picture taken from a patient with left ureteral stone with hydronephrosis, created in Taiwan by Morning 2K, Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Hydronephrosis. Ultrasound left kidney, longitudinal plane, the calyces, green overlay, are dilated and have lost their normal cup-shaped appearance. Flattening of papillae and blunting of fornices can be seen. Where visible, the renal cortical parenchyma is not thinned. RP, renal parenchyma, arrowheads, hyperechoic renal sinus source, ultrasonographic picture taken from a patient with left ureteral stone with hydronephrosis, created in Taiwan by Morning 2K, Wikimedia Commons, licensed under CC by SA 3.0. Nephrolithiasis, 5/6. Overlay. Nephrolithiasis VV. Ultrasound kidney, longitudinal plane, imaged from flank, a left lower pole renal calculus is seen as a hyperechoic structure, red overlay, with posterior acoustic shadowing, green overlay. Posterior acoustic shadowing is an ultrasound artifact that occurs when beam penetration is severely impeded by a structure with a high attenuation coefficient, e.g. calculus, bone, dense fibrous tissue. Our great thanks to Albertin and Krankenhaus, Hamburg, Germany, for kindly providing this case. Further notes, removal of in-image text. Nephrolithiasis, 5/6. Copyright. Overlay. Nephrolithiasis VV. Ultrasound kidney, longitudinal plane, imaged from flank, a left lower pole renal calculus is seen as a hyperechoic structure, red overlay, with posterior acoustic shadowing, green overlay. Posterior acoustic shadowing is an ultrasound artifact that occurs when beam penetration is severely impeded by a structure with a high attenuation coefficient, e.g. calculus, bone, dense fibrous tissue. Our great thanks to Albertin and Krankenhaus, Hamburg, Germany, for kindly providing this case. Further notes, removal of in-image text. Overlay. Obstructing ureteral calculus. Excretory urography, AP view, left, pre-contrast, right, 2.5 hours post-contrast, a calcification medial to the lower pole of the right kidney on the pre-contrast radiograph, red overlay, is shown post-contrast to be an obstructing proximal ureteral calculus, UC, red overlay. The right kidney is enlarged, with persistent enhancement, green overlay. There is pelvic aleectasis and poor contrast filling of the right ureter, region indicated by dashed lines. The left renal collecting system is normal, green overlay. RP, renal pelvis, U, ureter, UB, urinary bladder source, copyright IMPP. Overlay. Obstructing ureteral calculus. Excretory urography, AP view, left, pre-contrast, right, 2.5 hours post-contrast, a calcification medial to the lower pole of the right kidney on the pre-contrast radiograph, red overlay, is shown post-contrast to be an obstructing proximal ureteral calculus, UC, red overlay. The right kidney is enlarged, with persistent enhancement, green overlay. There is pelvic aleectasis and poor contrast filling of the right ureter, region indicated by dashed lines. The left renal collecting system is normal, green overlay. RP, renal pelvis, U, Ureter, UB, urinary bladder source, copyright IMPP. X. Vesicoureteral reflux. Vesicoureteral reflux, VUR, is the retrograde flow of urine from the bladder into the ureter. Primary VUR is the most common type and is due to a congenital defect of the terminal portion of the ureter. Bladder outlet obstruction, cystitis, and congenital ureteral anomalies, example ureteral duplication, ectopic ureter, may cause secondary VUR. Children with VUR are usually asymptomatic until they develop a urinary tract infection, presenting with fever, dysuria, urgency, flank pain. Other manifestations include hypertension, uremia, and kidney failure in advanced cases of reflux nephropathy. The initial workup for VUR includes laboratory tests, creatinine levels, electrolytes, and renal ultrasound for evaluation of kidney function and possible structural damage. Voiding cystourethrogram is the diagnostic test of choice for demonstrating urinary reflux and the severity of the disease. Most cases of primary VUR resolve spontaneously as the child ages. Medical management with prophylactic antibiotics, example, trimethoprim sulfamethoxazole, nitrofurantoin, and behavioral modification, timed micturition, has proven successful in treating and preventing complications. Patients with higher grades of primary VUR with ureteral dilation and hydronephrosis or with recurrent UTIs require endoscopic/surgical correction of the vesicoureteral junction. Treatment of the underlying cause corrects secondary VUR. Complications of VUR include hydronephrosis, obstructive nephropathy, pyelonephritis, and chronic kidney disease. OSOE. Epidemiology. Plus incidence, 1% of newborns 1 cent age, children 3, 2:1, 4, plus race, more common in white children 21. Epidemiological data refers to the U.S., unless otherwise specified. WR and etiology. Primary VUR, most common type, 31. Cent short intramural ureter vesicoureteric junction, VUJ, fails to close completely during bladder contraction. VURCS secondary VUR. Cent bladder outlet obstruction, anatomic/functional high pressure within the bladder, reflux of urine through the VUJS degree anatomic, posterior urethral valves, urethral meatal stenosis degree functional, bladder and bowel dysfunction. Copyright cystitis 4, neurogenic bladder 4. Cent congenital anomalies of the ureter. Copyright ureteral duplication, most common renal abnormality, 1% of the population. Copyright ectopic ureter o ureterocele * latrogenic. And percent. Clinical features. Cent suspected in the prenatal period when hydronephrosis is detected on routine antenatal ultrasound. Postnatal presentation. O recurrent febrile urinary tract infections equals neonates, irritability, fever, and listlessness equals older children. Urinary urgency, frequency, incontinence, and dysuria associated with fever. O reflux nephropathy, renovascular hypertension, kidney failure, uremia. 150 flank or abdominal pain before or during voiding. Copyright VUR is generally asymptomatic until it causes a urinary tract infection. V. Back collapse. Fine text outline. Diagnostics. Laboratory studies. Cent urinalysis and urine culture, indicated in all children with hydronephrosis to rule out infection. Renal function tests, serum creatinine, urea, and electrolytes imaging. Ultrasound. Cent indicated in children with febrile UTI and for follow UPS. Cent detection of hydronephrosis and dilated ureter. Contrast voiding cystourethrogram, mixture rating cystourethrogram. Cent indications. Copyright children with 2 episodes of febrile UTIs or copyright first febrile UTI in a child and any of the following, OE arenal anomaly detected on ultrasound. Copyright fever equals 39 degrees Celsius 102.2 degrees Fahrenheit and a pathogen other than E. coli detected in urine culture. O hypertension scent procedure. Contrast is instilled into the bladder through a urethral catheter. Images are obtained via fluoroscopy while the child is voiding. Scent findings. Retrograde reflux of the contrast into the ureters during micturition is diagnostic of VUR. Scent grading. VUR is divided into 5 grades of severity based on the results of the voiding cystourethrogram. Grading of vesicoureteral reflux. 6. Grades findings on voiding cystourethrogram * reflux limited to the ureter. Grade Fe no ureteral dilation. Scent reflux up to the renal pelvis. Grade 2 8 Scent no ureteral dilation. Scent reflux up to the renal pelvis. Grade ill Scent mild dilation of the ureter. Scent blunting of the calyces. Scent reflux up to the renal pelvis. Grade 4 * gross dilation of the ureter. Moderate ureteral tortuosity. Scent gross dilatation of the ureter, pelvis, and calyces. Grade V Scent significant ureteral tortuosity. Loss of papillary impressions. Copyright DMSA renal scan 71. Scent nuclear imaging method based on the injection of radioactive dimercaptosuccinic acid. Assessment of cortical tissue, renal function, and scarring, indicated in the case of hypodense photopenic lesions, further indicated for follow UPS and treatment monitoring. MAG3 scan, radionuclear cystourethropography. A nuclear medicine scan using the radio-labeled isotope MAG3, mercaptostal triglycine, detects VUR, especially if caused by obstructions. 1. Measures renal function. Scent follow UPS. Urodynamic testing. Scent indicated in the evaluation of secondary VUR. 7 * Fe, so. Treatment. Conservative treatment. Falter WVR's back collapse. A. Find text. O. Outline. DMSA renal scan 71. Scent nuclear imaging method based on the injection of radioactive dimercaptosuccinic acid. Assessment of cortical tissue, renal function, and scarring, indicated in the case of hypodense photopenic lesions. Scent further indicated for follow UPS and treatment monitoring. MAG3 scan, radionuclear cystourethropography. A nuclear medicine scan using the radio-labeled isotope MAG3, mercaptostal triglycine. Scent detects VUR, especially if caused by obstructions. Measures renal function. Follow UPSJ. Urodynamic testing. Scent indicated in the evaluation of secondary VUR. GOFE, FU. Treatment. Conservative treatment. Scent indications, VUR grades I3 in children 3 months, trimethoprim sulfamethoxazole, nitrofurantoin. Copyright infants. Scent indications OVUR equals grade 4. Copyright bilateral grade 3 VUR, especially in children 6 years. Copyright worsening renal function / breakthrough urinary tract infections despite prophylactic antibiotics. Scent subureteric transurethral injection, sting procedure. 11 Copyright cystoscopic guided injection of dextranomer / hyaluronic acid below the mucosa of the ureterovesical junction keeps the intravesical ureter in place, alters its angle, and, thereby, corrects the VUR. O daycare procedure. O success rates of up to 90%. Surgery, ureteral reimplantation, ureteroneocystostomy. VAN. OS. Complications. Scent infections. O urosepsis. O pyelonephritis. Copyright paranephric abscess. E renal complications. O megaureter. E hydronephrosis. E renal scarring. Copyright chronic kidney disease. 1. We list the most important complications. The selection is not exhaustive. OEOES. Sources. Last updated February 28, 2024. V. Back collapse. Find text outline. Normal posterior urethral valves. Kidney. Hydronephrosis. Ureter. Ureter dilation. Bladder. Bladder distension and bladder wall hypertrophy. Urethra. Obstructed urethra due to posterior urethral membrane. Penis. Posterior urethral valves. VV. Copyright Boss. Bifid renal pelvis. Bifid /y ureter / pi LQQ. Q4. At YTXIX4 copyright *2 ureteral E orifices. Duplex collecting systems. VV copyright Boss. Posterior view. Interureteric crest. Anterior view. Urinary bladder, median umbilical S /IPI body /ligament I ureters, Y urogenital IB peritoneum /A rugae. Ureteric orifice, F, OE registered vas, a phi deferens muscular layer. Y, ampulla of P. ductus deferens seminal vesicle neck of urinary bladder prostate prostatic ductules. Urethral orifice. Prostatic, urethroprostatic utricle opening of the ejaculatory duct seminal colliculus. Q4, X4 membranous transverse perineal muscle urethropubic bone. Spongia 3. Bulbourethral gland trigone internal urethral orifice urethra. GI 99-7 bulb of penis internal sphincter. WI external urethral orifice, so bulbospongiosus muscle. M external sphincter. Urinary bladder, male, VV. Left, ventral view of the bladder, urethra, prostate, and penis, coronal section, right, dorsal view of the bladder, seminal vesicles, terminal ureters, and prostate. The coronal section of the seminal vesicle and vas deferens is depicted on the right. Copyright Boss. Cut urogenital me peritoneum J ureters *yo, cent _ureters _ D /urogenital, E8 VA / peritoneum fundus E47 AE, base, Y cent year J, NI /neck _% of J4, equals end body of urinary equals IISFP plus ureteric orifice NS bladder plus 4. Fundus of urinary bladder, lateral view trigone of bladder. Neck of urinary bladder internal sphincter muscle of urethra urethral glands. External sphincter muscle of urethra anterior view. Urinary bladder, female, VV. Copyright Boss. Overlay. Vesicoureteral reflux VV. Fluoroscopy, voiding cystoureterogram, supine, frontal view, reflux of contrast, vesicoureteral reflux, green overlay, from the bladder, B, into the right ureter is seen, without dilation of the ureter. The proximal collecting system and kidney are not visible on this image. U, urethra source, copyright IMPP. Copyright overlay. Vesicoureteral reflux VV fluoroscopy, voiding cystoureterogram, supine, frontal view, reflux of contrast, vesicoureteral reflux, green overlay, from the bladder, B, into the right ureter is seen, without dilation of the ureter. The proximal collecting system and kidney are not visible on this image. U, urethra source, copyright IMPP. Overlay. Bilateral vesicoureteral reflux VV. Voiding cystoureterogram, AP view, bilateral vesicoureteral reflux, VUR, has resulted in dilatation of the ureters and pelvic-calyceal systems. The right ureter is tortuous and moderately dilated, with blunting of calyceal fornices, example indicated by arrow, but preserved papillary impressions, green line, grade 4 VUR. The left ureter is markedly dilated with loss of the fornices and papillary impressions, grade 5 VUR. B, bladder source, copyright IMPP. Overlay. Bilateral vesicoureteral reflux VV. Voiding cystourethrogram, AP view, bilateral vesicoureteral reflux, VUR, has resulted in dilatation of the ureters and pelvic-calyceal systems. The right ureter is tortuous and moderately dilated, with blunting of calyceal fornices, example indicated by arrow, but preserved papillary impressions, green line, grade 4 VUR. The left ureter is markedly dilated with loss of the fornices and papillary impressions, grade 5 VUR. B. Bladder source, copyright IMPP. X. Urinary tract infections in children and adolescents. A urinary tract infection is an infection of the bladder, urethra, ureters, and/or kidneys and is a common infection in infancy and childhood. Risk factors include congenital anomalies of the kidneys and urinary tract, K-cut, female sex, lack of circumcision in young boys, and bladder and bowel dysfunction. As in adults, the most common causative pathogen is Escherichia coli. Children and adolescents often present with classic symptoms of UTI, example dysuria, urinary frequency. However, nonverbal and/or young children often have nonspecific symptoms, which may include fever, irritability, poor feeding, and new-onset urinary incontinence. Diagnosis is based on symptoms and urinalysis and urine culture results. Imaging is not required for diagnosis but is used to evaluate for suspected acute complications, example renal abscess, and underlying structural anomalies, example vesicoureteral reflux. The first-line imaging modality is renal and bladder ultrasound, RBUS, further imaging depends on the patient's history, ultrasound results, and/or specialist recommendations. Treatment of pediatric UTIs involves antibiotics, oral or for, and management of any underlying causes. Recurrent UTIs are common in children, and patients and/or their caregivers should be educated on preventive measures. Complications of pediatric UTIs, especially if severe or recurrent, include sepsis, renal scarring, chronic kidney disease, and hypertension. UTI in adults is discussed in a separate article, see urinary tract infections. 7. OOBOD. Epidemiology. UTIs are common in children, up to 7% of girls and 2% of boys are diagnosed with a UTI by 6 years of age. 2% and I 12 months of age, 2 at I. Epidemiological data refers to the U.S., unless otherwise specified. OO. CES. Etiology. Pathogen/LL4. Scent bacterial copyright Escherichia coli, in up to 90% of cases, copyright Klebsiella pneumoniae copyright Proteus mirabilis, 5, O. Enterococcus faecalis O. Enterobacter species O. Rarely, Pseudomonas aeruginosa, Group B Streptococcus, Staphylococcus aureus 4 Scent non-bacterial copyright viral, Adenovirus 4 copyright fungal, rare Candida, Cryptococcus neoformans, Aspergillus 41. UTIs caused by a pathogen other than E. coli are considered atypical pediatric UTIs. ILL. Risk factors for pediatric UTI, 3. All age so female sex copyright personal or family history of K-cut 4O bowel and bladder dysfunction, example chronic constipation, L2O instrumentation of the urinary tract 1, scent children. OCE. Clinical features. V. Back collapse fine text outline. Clinical features. Scent clinical features of UTI in children and adolescents are similar to those in adults, e.g., copyright urinary frequency O dysuria E suprapubic pain O flank pain O fever, 1SL2L scent caregivers may report the following in young children, copyright new onset urinary incontinence, if toilet trained, 3O irritability 121 copyright crying when urinating, 2, copyright poor feeding, 121 Copyright malodorous urine. 2I 121 Copyright neonates, jaundice, hypothermia, SIL-SI8. 6. Symptoms of a pediatric UTI may be nonspecific, fever may be the only sign, particularly in neonates. 3L2 LF OES. Diagnostics. Approach 2I141I15. Determine the need for urinalysis based on age and clinical features. Indications include A14 Copyright age 24 months with clinical features of pediatric UTI. Send urine culture if copyright urinalysis is positive, copyright urinalysis is negative but clinical suspicion is high. 14 Imaging studies are required for copyright children aged. Urine studies /LL2. The diagnosis of UTI typically involves urinalysis, may detect bacteria and/or pyuria, and urine culture, confirms bacteriuria, J. Raltsy, 2. Collection methods, 41L3. Scent not toilet trained, copyright preferred, sterile collection, example transurethral catheterization or suprapubic aspiration. 2IS4 Copyright alternatives, clean catch urine sample or bagged urine sample, not suitable for culture, J. 08 Lald Lionel equals a negative urinalysis result can rule out a UTI. If positive, obtain a sterile sample for culture. Scent toilet trained, clean catch urine sample. Ado. Urinalysis. Asterisk dipstick urinalysis. 2 Copyright positive urinary nitrites, suggests bacteria. Copyright positive leukocyte esterase, suggests pyuria plus microscopy, presence of bacteria on gram stain and/or pyuria. 2 equals DH code, AMI, V. Back collapse. Find text outline. underscore QVCV4L underscore SX underscore X underscore VVVV Chu QVOVM REESSSEEE urine culture. Scent significant bacteriuria confirms the diagnosis. Scent thresholds vary based on collection method and across guidelines, follow local protocols. ALA, copyright midstream clean catch, 100,000 CFU/ml1, 6LL2 ITS, copyright transurethral catheterization or suprapubic aspiration, 50,000 CFU/ml1 and LL4 imaging in pediatric UTI. Plus first febrile UTI in children aged. 6. Most abnormalities can be detected on RBUS but VCUG is required if vesicoureteral reflux is suspected. See Diagnostics of VUR for further information. OS. OOXO. Treatment. Scent start empiric antibiotics for pediatric UTI, example cephalosporins, while awaiting urine culture results. Scent adjust treatment when culture results become available. Scent provide supportive treatment, example analgesia, supportive care for pediatric fever. If fever persists for 72 hours, consider urgent imaging for pediatric UTI to rule out renal abscess. 3. Educate patients and caregivers on prevention of pediatric UTI. ZOE. Differential diagnoses. Plus vulvovaginitis, example from poor hygiene, irritation, 211, 22I plus appendicitis or mesenteric lymphadenitis J, 221L23, diabetes mellitus or diabetes insipidus, may cause urinary frequency, 21 * genital injury, 24, plus sexually transmitted infections 121. Copyright consider sexual assault in all pediatric patients presenting with genital injury or sexually transmitted infections, in adolescence, screen for signs of human trafficking. The differential diagnoses listed here are not exhaustive. WI. CE. Complications. Scent acute IL-2E dehydration and hypovolemia O sepsis o renal abscess. Copyright acute kidney injury * chronic, due to recurrent UTIs. 2. Copyright renal scarring. 2. Copyright chronic kidney disease. Hypertension in children. We list the most important complications. The selection is not exhaustive. WA and V. Back collapse. Find text outline. OCE. Treatment. Sent start empiric antibiotics for pediatric UTI, example cephalosporins, while awaiting urine culture results. Adjust treatment when culture results become available. Sent provide supportive treatment, example analgesia, supportive care for pediatric fever. Sent if fever persists for 72 hours, consider urgent imaging for pediatric UTI to rule out renal abscess. 3. Educate patients and caregivers on prevention of pediatric UTI. 700. Cs. Differential diagnoses. Plus vulvovaginitis, example from poor hygiene, irritation, 2, 21,122, plus appendicitis or mesenteric lymphadenitis 22/I23 plus diabetes mellitus or diabetes insipidus, may cause urinary frequency, 21 plus genital injury 224 plus sexually transmitted infections 21. Copyright consider sexual assault in all pediatric patients presenting with genital injury or sexually transmitted infections, in adolescence, screen for signs of human trafficking. The differential diagnoses listed here are not exhaustive. VES. Q shared note. Complications. Plus acute, 1L2 copyright dehydration and hypovolemia copyright sepsis or renal abscess copyright acute kidney injury * chronic, due to recurrent UTIs, 21 copyright renal scarring, 21 copyright chronic kidney disease. Hypertension in children. We list the most important complications. The selection is not exhaustive. OS. Prevention. Educate caregivers on nonspecific symptoms of pediatric UTI and the need to seek early treatment. Promptly identify and treat any underlying conditions including bladder and bowel dysfunction. See constipation in children and adolescents, 210 copyright K-cut, example hydronephrosis, vesicoureteral reflux, plus encourage children to urinate regularly. 20. OS. CES. Tips and links. Sources. Last updated September 1, 2023 v. Back collapse. Find text outline. LTT antiseptic Phi 0. Suprapubic aspiration in infants, materials. Sterile materials, A. Gloves, B. Tray, C. Gauze, D. Forceps, E. Fenestrated drape, F. 5 ml syringe and 22 gauge needle, G. EMLA topical anesthetic cream, H. Occlusive dressing. Non-sterile materials, I. Surgical mask, J. Antiseptic solution. Copyright Emboss. Suprapubic aspiration in infants, technique, VV. 1. A topical anesthetic, example EMLA cream, is applied to the aspiration site, in the midline approximate 1 to 2 cm cranial to the pubic symphysis. The area is covered with an occlusive dressing, example Tegaderm, and the anesthetic is allowed to act for approximately 30 minutes before proceeding. 2. An assistant holds the infant's legs in a frog-legged position, i.e., hips and knees are flexed and hips are externally rotated. 3a. After removal of the occlusive dressing and wiping away the remaining anesthetic, not pictured, ultrasound is used to confirm bladder location. Note that needle insertion may also be performed under real-time ultrasound guidance, in which case a sterile cover is required for the ultrasound probe. 3b. Using sterile forceps and sterile gauze soaked in an antiseptic solution, the skin is cleaned from the pubic symphysis to the umbilicus and the antiseptic is allowed to air dry. 4. The cleaned area is covered with a sterile fenestrated drape. The aspiration site is marked by placing 2 fingers above the suprapubic aspiration in infants, technique, VV. 4. The cleaned area is covered with a sterile fenestrated drape. The aspiration site is marked by placing 2 fingers above the pubic symphysis. This may be done by a second assistant as shown here, or by the clinician themselves. 5. The clinician inserts a 22-gauge needle attached to a 5 ml syringe perpendicular to the abdominal wall. This usually means aiming approximate 10 to 20 degrees caudally from true vertical due to the slope of the abdominal wall. 6. While aspirating, the needle is advanced 2 to 3 centimeters until urine appears in the syringe. A minimum of 2 ml of urine should be collected. Following the procedure, the needle and syringe are withdrawn, the needle safely removed from the syringe, and the urine emptied into a sterile urine collection cup. The cup is then placed in a specimen transport bag and sent to the laboratory. Note: in older children and/or children with thicker abdominal walls, additional subcutaneous infiltration of local anesthetic is preferred over a topical anesthetic alone. This is performed between steps 4 and 5 using a sterile technique. Urinary tract infections in children and adolescents, 3/6. Voiding stimulation technique for clean catch urine in infants VV. Illustration depicting a voiding stimulation technique to accelerate the collection of a clean catch, i.e., midstream, urine sample in an infant. It is also known as the quick wee method. Sterile materials: A. Urine collection cup, B. Forceps, C. Surgical swab. Non-sterile materials: D. Towel, cloth, or urine towelette. 1. The caregiver may offer a bottle or breastfeed before the procedure. 2. The urethral opening, and perineum, if female, is cleaned, first with an antiseptic and then with sterile water. 3. Using a cold saline-soaked gauze held with forceps, the suprapubic area is gently rubbed in a circular motion while holding the collection cup. No pressure is required. The cold and wet stimulus is thought to trigger cutaneous voiding reflexes. 4. Urine is collected without skin contact to avoid contamination. 3A 3B4 and ANSN, EE/1. Wee FI/A. Cent/L/ _AE, LU. Bagged urine collection technique in infants VV. Sterile materials: A. Urine collection cup, B. Urine collection bag, example U-bag. Non-sterile materials: C. Specimen transport bag, D. Towel, cloth, or urine towelette. 1. The urethral opening and perineum are cleaned, first with an antiseptic and then with sterile water. 2. The urine collection bag is opened and the adhesive sticker removed without touching the adhesive collar underneath. 3. The adhesive collar is applied to the skin of the genital area by pressing on the non-adhesive side of the collection bag and gently pulling down on the bag to open it. To prevent leakage and contamination, it is essential to ensure the adhesive has fully adhered around the entire collar without skin folds or gaps. The urethral opening and labia of female children, 3A, and the penis and scrotum of male children, 3B, must be inside the opening of the bag. 4. After the child has urinated, the bag is held above a sterile urine collection cup and opened, either via a dedicated mechanism, example by pulling the blue square tab on a U-bag, or by cutting the bottom corner with sterile scissors. The urine is 3A 3B4 and equals JNXESA/A L/H E /equals _LU1. Bagged urine collection technique in infants VV. 1. The urethral opening and perineum are cleaned, first with an antiseptic and then with sterile water. 2. The urine collection bag is opened and the adhesive sticker removed without touching the adhesive collar underneath. 3. The adhesive collar is applied to the skin of the genital area by pressing on the non-adhesive side of the collection bag and gently pulling down on the bag to open it. To prevent leakage and contamination, it is essential to ensure the adhesive has fully adhered around the entire collar without skin folds or gaps. The urethral opening and labia of female children, 3a, and the penis and scrotum of male children, 3b, must be inside the opening of the bag. 4. After the child has urinated, the bag is held above a sterile urine collection cup and opened, either via a dedicated mechanism, example by pulling the blue square tab on a U-bag, or by cutting the bottom corner with sterile scissors. The urine is drained into a sterile cup without the bag touching the cup. The cup is then sealed with its lid, placed inside the specimen transport bag, and sent to the laboratory. Or in Tokeren Abstrefen, Abelsen knock pip briefly remove excess urine, read Symergia brevirement eliminate 21 GXCE $0 e ong erger repeatment, e gouter, lire en irghe. Urinalysis, urine analysis, test strip. Left, test strip following immersion in urine. Right, test strip packaging with instructions on how to interpret findings. Source, urine quick test by Uwe Gill, Wikimedia Commons, licensed under CC by SA 3.0. Pyuria and bacteriuria on microscopy. VV. Photomicrograph of a urine specimen, high magnification, multiple white blood cells, large, light-colored structures, and bacteria, small black structures, are visible. The presence of white blood cells, pyuria, and bacteria, bacteriuria, in the urine is characteristic of urinary tract infection. Source, Bacteriuria Pyuria 4 by Stephen Fruitsmock, Wikimedia Commons, licensed under CC by SA 3.0. X. Pyelonephritis. Pyelonephritis is an infection of the renal pelvis and parenchyma that is usually associated with an ascending bacterial infection of the bladder. It occurs more commonly in women and risk factors include pregnancy and urinary tract obstruction. Patients typically present with flank pain, costovertebral angle tenderness, fever, and other features of cystitis, example dysuria, frequency. Urinalysis shows pyuria and bacteriuria. Urine cultures should be taken in all patients before initiating treatment to identify the pathogen and possible antibiotic resistance. Early empiric antibiotic treatment is essential to avoid renal complications and urosepsis. Definitive treatment depends on the drug sensitivities of the causative pathogen and the patient's clinical profile, example possible comorbidities. See also urinary tract infections. O. CES. Etiology. Usually caused by an ascending bacterial infection of the bladder, cystitis, a less commonly due to hematogenous spread of infection to the kidney, example infectious endocarditis, E. pathogens O. gram-negative bacteria. Escherichia coli, 75 to 90% of cases, leading cause of pyelonephritis, equals Pseudomonas aeruginosa equals Klebsiella pneumoniae equals Proteus mirabilis. E. gram-positive bacteria equals Enterococcus faecalis equals Staphylococcus aureus equals Staphylococcus saprophyticus. 2. Copyright Candida infection, especially in immunocompromised patients, is possibly risk factors for pyelonephritis. EO most common in women because they have shorter urethras. O. pregnancy. Copyright urinary tract obstruction, potentially leading to pyonephrosis, foreign bodies, example indwelling urinary catheters or other urologic instrumentation, anatomical abnormalities, example benign prostatic hyperplasia, vesicoureteral reflux, nephrolithiasis, ureteral strictures. Copyright cystitis. Copyright recent administration of antibiotics, possible antibiotic resistance, O. immunosuppression, example HIV, diabetes mellitus. Copyright renal transplant. 2. Sil 4. FO. Fe, XO. Classification. The terminology used for classifying pyelonephritis is somewhat controversial and serves primarily to estimate the risk of atypical or antibiotic-resistant pathogens. Uncomplicated pyelonephritis, pyelonephritis in an immunocompetent, non-pregnant female with normal genitourinary anatomy and renal function SLT 7 ILS, SENT complicated pyelonephritis, pyelonephritis associated with any of the following risk factors for complications, else. Degree failure of outpatient therapy sepsis male sex age 60 years urinary tract abnormalities, example obstruction, indwelling catheter, history of surgery to the urinary tract or kidneys hospital acquired infection renal impairment history of nephrolithiasis immunosuppression and/or severe comorbidities, example diabetes mellitus, chronic corticosteroid use, pregnancy. Degree FO OES. Clinical features: fever, chills v. Back collapse fine text outline. Clinical features: SENT fever, chills SENT flank pain SENT costovertebral angle tenderness, pain upon percussion of the flank, usually unilateral, maybe bilateral, dysuria as well as other symptoms of cystitis, example frequency, urgency, weakness, nausea, vomiting, diarrhea may also be present, SENT possible abdominal or pelvic pain. Copyright suspect pyelonephritis in any patient presenting with fevers, chills, and flank pain, irrespective of lower urinary tract symptoms. Copyright pyelonephritis symptoms may overlap with those of other life-threatening causes of flank pain, see differential diagnosis of pyelonephritis. Diagnostics. Laboratory tests. SENT urinalysis ES low, copyright non-specific findings of UTI pyuria, positive esterase on dipstick test, leukocyturia, WBCs 5/HPF, bacteriuria positive nitrites on dipstick test indicate bacteria that convert nitrates to nitrites. 5 hematuria, including microhematuria, copyright other findings WBC casts, rare finding, but considered to be a strong indicator for pyelonephritis 9, registered L101 urine pH of equals 7.5 to 8.0, associated with urease-producing organisms, 2, 1L12 at 1 epithelial cells 5/HPF, suggests contamination. Gram stain, direct visualization of bacteria, seldom performed, urine culture with susceptibilities copyright perform in all patients with suspected pyelonephritis to determine the pathogen and any associated drug resistance. Copyright to 105 colony forming units/ml suggests bacterial infection, see urine culture for more details. 31L14 SENT blood cultures, 2 sets should be performed in all patients with suspected complicated pyelonephritis. SENT urine pregnancy test in women of childbearing age. Additional blood tests copyright CBC, leukocytosis copyright inflammatory markers, TCRP ESROBMP, may be normal or show elevated BUN and creatinine. Collect urine and blood cultures before administering empiric antibiotic therapy. Imaging, 15. Indications. SENT imaging is not routinely indicated in patients with suspected acute uncomplicated pyelonephritis. Imaging serves to identify obstruction, abscess, or emphysema to pyelonephritis. SENT consider in the following situations: complicated pyelonephritis copyright sepsis or septic shock copyright known or suspected nephrolithiasis 116O new decline in eGFR2. Back collapse fine text. Degree. O. Outline. CT abdomen and pelvis with and without for contrast 18. Modality of choice in non-pregnant patients who need imaging. SENT findings supportive of pyelonephritis or renal parenchyma may appear normal, early, or edematous or infected parenchyma may be visible as wedge-shaped areas of streaky contrast enhancement, striated nephrogram. 18E findings supportive of urinary tract obstruction. O hydroureter, hydronephrosis. O nephrolithiasis, urolithiasis. And other findings that may be present. Copyright congenital abnormalities of the renal tract. O abscess. O emphysema. 2 pyelonephritis, presence of gas within the renal parenchyma, collecting system, or paranephric space. 19 O hemorrhage in the parenchyma. Ultrasound of the kidneys and bladder. 8. Scent indications, patients with contraindications to CT scan, example allergy to contrast. E findings supportive of pyelonephritis. O renal enlargement. Copyright loss of corticomedullary differentiation. O edema. O hemorrhage in the parenchyma. O abscess. E findings supportive of urinary tract obstruction. O hydroureter, hydronephrosis. Copyright thickened bladder wall. Copyright high bladder residual volume. O prostate enlargement. Scent disadvantages, low sensitivity compared to CT, particularly in early acute infections. 18. Pathology. Scent acute pyelonephritis. EO most commonly affects the cortex, spares glomeruli and vessels. O purulent inflammation of the interstitium with destruction of the parenchyma, the renal tubules, and, in some cases, the renal pelvis. Copyright histology. Neutrophilic infiltration of the renal tubules and the interstitium. Sparing of the glomeruli and interarenal vessels. Scent chronic pyelonephritis. Copyright chronic inflammatory changes with rough, asymmetric scarring and fibrosis of the corticomedullary junction. O blunted calyces from recurrent urinary reflux. Copyright histology. Eosinophilic casts in the tubules that resemble thyroid tissue with colloid, thyroidization of the kidney. O xanthogranulomatous pyelonephritis. A rare form of chronic pyelonephritis characterized by chronic destructive granuloma formation associated with Proteus mirabilis and Escherichia coli infections. Large, irregular, yellow-orange masses on gross examination of the kidney, may be mistaken for a true renal neoplasm. Histology, granulomatous tissue with lipid-laden foamy macrophages and multinucleated giant cells. V. Back collapse. Fine text outline. Pyelonephritis. Differential diagnoses. See also differential diagnoses of acute abdomen and differential diagnoses of acute back pain. Scent other kidney and urinary tract disorders. O lower UTIs. Copyright renal colic. O renal vein thrombosis. Copyright renal infarct. Scent other intra-abdominal, retroperitoneal, and pelvic disorders. O psoas abscess. Copyright splenic infarct or abscess. O retroperitoneal hematoma or infection. Copyright acute cholecystitis. O appendicitis. Copyright diverticulitis. Copyright pelvic inflammatory disease. O endometriosis. Scent disorders outside the abdomen, pelvis, and retroperitoneum. O musculoskeletal disorders, example spinal, paraspinal. O plural empyema. EO pulmonary infarct. Copyright shingles. The differential diagnoses listed here are not exhaustive. FOFA, Cs. Treatment. Antibiotic therapy, source control, and supportive care are the mainstays of treatment of pyelonephritis. The choice of empiric antibiotic regimen should be guided by the risk of infection with resistant organisms, i.e., complicated versus uncomplicated pyelonephritis, and antibiotics should be tailored as soon as culture results become available. Consider specialist consultation in cases of complicated pyelonephritis, especially if urinary tract obstruction is suspected. Uncomplicated pyelonephritis /5271 I241. Scent empiric antibiotic therapy for uncomplicated pyelonephritis 24. Copyright most patients can be treated with an oral fluoroquinolone, example ciprofloxacin, levofloxacin, for 5 to 7 days, L2-All-2S, O alternatives. Trimethoprim sulfamethoxazole, for 10 to 14 days, only recommended if susceptibility is known. 5. 1 amoxicillin clavulanate for 10 to 14 days. 241 cefpodoxim for 10 to 14 days. 24. Copyright consider a single dose of a broad-spectrum parenteral antibiotic prior to the administration of oral antibiotics, especially when the local rates of drug-resistant E. coli are unknown or known to be 10%. 24L1 equals ceftriaxone equals or gentamicin 251L 24 cent supportive care. Encourage the patient to drink adequate amounts of fluids. Cent additional considerations. Copyright outpatient treatment is generally appropriate. If there is no response within 48 hours of starting empiric antibiotic therapy, equals consider imaging to evaluate for urinary tract obstruction or formation of renal abscess, see diagnostics. Equals check urine culture results and adjust treatment accordingly. 1. FV. Back collapse. Find text outline. Repeat urine culture, i.e., test for cure, is not routinely indicated. 5. Complicated pyelonephritis/LL71I24. Patients with complicated acute pyelonephritis should be admitted to the hospital and started on parenteral empiric antibiotic therapy as soon as possible. Severely ill, i.e., septic, and/or with risk factor, S, for multi-drug. Not severely ill and no risk factors for multi-drug. Patient characteristics. Empiric antibiotic jonephritis, 1 measles. Bacterial infection, or MRSA. Bacterial I. Pi. Antibiotic regimens to consider. One of the following. Copyright Fluoroquinolone equals ciprofloxacin levofloxacin E and extended spectrum cephalosporin equals ceftriaxone equals cefotaxime. Cefepime E and extended spectrum penicillin with a B-lactamase inhibitor, example piperacillin tazobactam. Consider adding an aminoglycoside until culture results are available. Degree gentamicin, degree tobramycin. One of the following. Carbapenem equals meropenem equals doropenem ertapenem. Copyright an extended spectrum penicillin with a B-lactamase inhibitor, example piperacillin tazobactam. Degree aztreonam. Copyright an extended spectrum cephalosporin, equals ceftriaxone equals ceftazidime. Cefepime. Consider adding an aminoglycoside until culture results are available. Degree gentamicin, degree tobramycin. Consider colistin if there is a known MDR organism with resistance to aminoglycosides and carbapenems. Consider adding vancomycin. Or if there is concern for VRE, add one of the following. Copyright daptomycin, copyright linezolid. Copyright fluoroquinolone monotherapy should be avoided in severely ill patients with complicated pyelonephritis due to the high prevalence of fluoroquinolone resistant. Cent supportive care. Cent additional considerations. Subsequent management. Copyright analgesics as needed, see pain management, antiemetics as needed. Aggressive for resuscitation for patients with sepsis, C for fluid therapy. Copyright source control. Consider imaging to identify urinary obstruction, see diagnostics above. Degree duration of antibiotic therapy, 10 to 14 days. 24 antibiotic therapy should be adjusted once blood and urine culture sensitivity reports are available. Consider repeat urine culture in pregnant women and those with recurrent pyelonephritis 2 to 4 days after completion of the antibiotic course. 5.29. Identify and treat the underlying cause. Patients with concurrent urinary tract obstruction are at very high risk of clinical deterioration and require immediate intervention to remove the obstruction. AOE. Complications. Cent urosepsis, septic shock. Cent paranephric abscess, renal abscess. Cent renal papillary necrosis. Emphysema 2 pyelonephritis 18. Copyright rare form of pyelonephritis characterized by gas formation within and around the kidney. Copyright most common in patients with poorly controlled diabetes or immunodeficiency. Copyright typically caused by E. coli or K. pneumoniae. NAL collapse. Find text outline. AO plus emphysema 2 pyelonephritis 18. Copyright rare form of pyelonephritis characterized by gas formation within and around the kidney. OE most common in patients with poorly controlled diabetes or immunodeficiency. Copyright typically caused by E. coli or K. pneumoniae. Copyright treatment includes 4 antibiotics, percutaneous drainage, and, in some cases, nephrectomy. Sent recurrent bacterial pyelonephritis, copyright if recurrence is caused by the same organism despite adequate treatment, then prolong the course of antibiotics for 6 weeks. If a new pathogen is identified, change antibiotics accordingly and treat for 2 weeks. Sent atrophic kidneys MS sent end-stage renal disease, ESRD if both kidneys are affected, the patient has a single kidney, or the other kidney has been damaged by a different pathology. Copyright rule out urosepsis in elderly patients with altered mental status. We list the most important complications. The selection is not exhaustive. CE. Special patient groups. See also urinary tract infections in children and adolescents. Pyelonephritis in pregnancy 24LL1. Sent epidemiology copyright the risk of pyelonephritis is increased during pregnancy. As many as 1/3 of pregnant women with asymptomatic bacteriuria will progress to develop pyelonephritis, if left untreated. Copyright one of the most common complications of pregnancy, with potentially severe consequences for both mother and fetus. Sent diagnosis, see diagnostics above, the imaging modality of choice in pregnancy is MRI. 8+ treatment 24IL1 copyright hospitalization is recommended, definitive indications for hospitalization are, 34 equals signs of sepsis dehydration, example due to vomiting, equals contractions copyright a third or fourth generation cephalosporin copyright parenteral broad-spectrum antibiotics are recommended at least until the patient is afebrile, after which transition to oral antibiotics, example penicillins, cephalosporins, is possible. 8 degrees copyright C antibiotics during pregnancy. All asymptomatic cases of bacteriuria during pregnancy must be treated to prevent the development of pyelonephritis. Copyright avoid fluoroquinolones, trimethoprim/sulfamethoxazole, and aminoglycosides in pregnant women. GPVU. OE. Chronic pyelonephritis. Sent description, a consequence of recurrent or persistent acute pyelonephritis. Sent predisposing factors vesico-ureteric reflux copyright urinary tract obstruction, example nephrolithiasis, neurogenic bladder. Sent clinical features copyright nonspecific, mild fever, anorexia, malaise, abdominal or flank pain. Sent diagnostics urinalysis, pyuria, proteinuria, WBC casts copyright imaging, ultrasound, intravenous urogram corticomedullary scarring, mainly upper pole, blunt/clubbed renal calyces. FA copyright biopsy. Thyroidization of the kidney, see pathology. Sent treatment copyright treat the underlying cause. Copyright antibiotics 1 and V. Back collapse fine text outline. Kurs eintrocknen abstreifen, Abelsen knock in briefly, remove excess urine, read Fabrevement, eliminate C1 excess de outrepedement, eguter, lire enerzit. Urinalysis, urine analysis, test strip. Left, test strip following immersion in urine. Right, test strip packaging with instructions on how to interpret findings. Source, urine quick test by Uwe Gill, Wikimedia Commons, licensed under CC by SA 3.0. Euro__pyelonephritis, 2/11. Pyuria and bacteriuria on microscopy VV. Source, Bacteriuria Pyuria 4 by Stephen Frutzmock, Wikimedia Commons, licensed under CC by SA 3.0. Euro__pyelonephritis, 3/11. T. Re-registered EI Wisplinghoff Laboratories. Overlay. White blood cell casts VV. Photomicrograph of urine sediment, phase contrast microscopy, high magnification, white blood cell, WBC, casts, blue overlay, contain leukocytes, examples outlined in yellow, that are compressed in a matrix. Sharp margins are characteristic of WBC casts, differentiating them from randomly assembled leukocyte conglomerates. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Pyelonephritis, 3/11. I. Wisplinghoff Laboratories. Copyright overlay. White blood cell casts VV photomicrograph of urine sediment, phase contrast microscopy, high magnification, white blood cell, WBC, casts, blue overlay, contain leukocytes, examples outlined in yellow, that are compressed in a matrix. Sharp margins are characteristic of WBC casts, differentiating them from randomly assembled leukocyte conglomerates. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Pyelonephritis, 4/11. EI, Wisplinghoff Laboratories. Overlay. Granular cast in urine sediment VV. Photomicrograph of urine sediment, phase contrast microscopy, high magnification. The granular cast in the center of the image is comprised of a hyaline matrix, green overlay, with large droplets of plasma proteins embedded within. Granular casts can be an indication of proteinuria, example in glomerulonephritis or pyelonephritis. However, they may also be present in healthy individuals, example after severe physical stress. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Pyelonephritis, 4/11. CE, Wisplinghoff Laboratories. Copyright. Overlay S. Granular cast in urine sediment VV. Photomicrograph of urine sediment, phase contrast microscopy, high magnification. The granular cast in the center of the image is comprised of a hyaline matrix, green overlay, with large droplets of plasma proteins embedded within. Granular casts can be an indication of proteinuria, example in glomerulonephritis or pyelonephritis. However, they may also be present in healthy individuals, example after severe physical stress. Our great thanks to Dr. Wisplinghoff, Dr. Wisplinghoff's laboratory, for kindly providing this image. Uro__pyelonephritis, 5/11. Overlay. Acute pyelonephritis and renal calculi VV. CT abdomen, with for contrast, venous phase, axial plane, of a patient with acute pyelonephritis. The left ureter and renal pelvis are slightly dilated, red overlay, and contain hyperdense calculi, white arrowheads. The left kidney is larger than the right and the left renal parenchyma, green overlay, shows reduced contrast enhancement. There is also paranephric stranding, yellow overlay and white arrow, which is an important sign of renal inflammation or obstruction. V. Inferior vena cava, A. Aorta source, copyright IMPP. Uro__pyelonephritis, 5/11. Copyright. Overlay. Acute pyelonephritis and renal calculi VV. CT abdomen, with for contrast, venous phase, axial plane, of a patient with acute pyelonephritis. The left ureter and renal pelvis are slightly dilated, red overlay, and contain hyperdense calculi, white arrowheads. The left kidney is larger than the right and the left renal parenchyma, green overlay, shows reduced contrast enhancement. There is also paranephric stranding, yellow overlay and white arrow, which is an important sign of renal inflammation or obstruction. V. Inferior vena cava, A. Aorta source, copyright IMPP. Uro__pyelonephritis, 6/11. Striated nephrogram VV. MRI abdomen, kidneys, T1 weighted fat saturated, with contrast, arterial phase, alternating high and low attenuation linear bands, striations, arrows, radiate through the cortex and medulla of the kidney parallel to the axis of tubules and collecting ducts. A striated nephrogram can result from stasis and concentration of contrast in edematous or necrotic renal tubules. Source: Figure 3, in Allergic interstitial nephritis manifesting as a striated nephrogram by Yvonne Moynadin, Erica Bracamonte, Bijan Thajadine, Amy Sussman, Muchaya Hamadrira, and James Costello. Case Reports in Medicine, licensed under CC by 3.0. Uro_pyelonephritis, 7/11. Estatin, 13 hours 8 minutes and 28 seconds MRN. Overlay. Chronic ureteral obstruction. CT abdomen and pelvis, without contrast, coronal plane, of a patient with a history of neurogenic bladder and recurrent urinary infections. The renal calyces, pelvis, and ureters are dilated, green overlay, with normally concave, cup-shaped, renal calyces appearing convex, club-shaped, examples indicated by arrowheads. Thinning of the renal parenchyma, examples indicated by white dashed lines on the parenchymal edge, suggests that the dilatation is chronic rather than acute. Marked thickening of the bladder wall, red overlay, is likely responsible for chronic ureteral obstruction. Source: Figure 3, computed tomography, coronal view, confirmed moderately severe bilateral hydronephrosis and hydroureter by Subramanian Vaidyanathan, Fahd Selmi, Kotaratal Abraham, Peter Hughes, Gurprat Singh and Bakul Soni, Patient Safety in Surgery Journal, licensed under CC by 2.0. Uro_pyelonephritis, 7/11. Biotny, 13 hours 8 minutes and 28 seconds MRN. Overlay. Chronic ureteral obstruction. CT abdomen and pelvis, without contrast, coronal plane, of a patient with a history of neurogenic bladder and recurrent urinary infections. The renal calyces, pelvis, and ureters are dilated, green overlay, with normally concave, cup-shaped, renal calyces appearing convex, club-shaped, examples indicated by arrowheads. Thinning of the renal parenchyma, examples indicated by white dashed lines on the parenchymal edge, suggests that the dilatation is chronic rather than acute. Marked thickening of the bladder wall, red overlay, is likely responsible for chronic ureteral obstruction. Source: Figure 3, computed tomography, coronal view, confirmed moderately severe bilateral hydronephrosis and hydroureter by Subramanian Vaidyanathan, Fahd Selmi, Kotaratal Abraham, Peter Hughes, Gurprat Singh and Bakul Soni, Patient Safety in Surgery Journal, licensed under CC by 2.0. Uro_pyelonephritis, 8/11. Overlay. Ureter calculus with hydronephrosis VV. CT abdomen, without contrast, axial plane, the rounded hyperdense structure, red arrow, medial to the left kidney is a ureteral calculus. Mild dilatation of the ureter, green overlay, is also visible. An additional, very small calculus, red overlay, is present in a dilated calyx. K. Kidney source, Midureter stone hydro by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Modifications, arrow removed. Uro_pyelonephritis, 8/11. Copyright overlay. Ureter calculus with hydronephrosis VVCT abdomen, without contrast, axial plane, the rounded hyperdense structure, red arrow, medial to the left kidney is a ureteral calculus. Mild dilatation of the ureter, green overlay, is also visible. An additional, very small calculus, red overlay, is present in a dilated calyx. K. Kidney source, Midureter stone hydro by James Heilman, MD, Wikimedia Commons, licensed under CC by SA 3.0. Modifications, arrow removed. Uro_pyelonephritis, 911. Overlay. Pyelonephritis VV. Ultrasound kidney, longitudinal plane, the renal sinus and cortex, C, are not well differentiated from one another. Much of the central kidney is replaced by a poorly marginate area of hyperechogenicity, green overlay. Source, Figure 26, in Ultrasonography of the Kidney, a pictorial review by Christopher Linskov Hansen, Michael Bachman Nielsen, Caroline Uertzen, Diagnostics, licensed under CC by 4.0. Uro__pyelonephritis, 911. Copyright overlay. Pyelonephritis VV ultrasound kidney, longitudinal plane, the renal sinus and cortex, C, are not well differentiated from one another. Much of the central kidney is replaced by a poorly marginate area of hyperechogenicity, green overlay. Source, Figure 26, in Ultrasonography of the Kidney, a pictorial review by Christopher Linskov Hansen, Michael Bachman Nielsen, Caroline Uertzen, Diagnostics, licensed under CC by 4.0. Uro__pyelonephritis, 10/11. Overlay. Hydronephrosis. Ultrasound left kidney, longitudinal plane, the calyces, green overlay, are dilated and have lost their normal cup-shaped appearance. Flattening of papillae and blunting of fornices can be seen. Where visible, the renal cortical parenchyma is not thinned. RP, renal parenchyma, arrowheads, hyperechoic renal sinus source, ultrasonographic picture taken from a patient with left ureteral stone with hydronephrosis, created in Taiwan by Morning 2K, Wikimedia Commons, licensed under CC by SA 3.0. Uro__pyelonephritis, 10/11. Overlay. Hydronephrosis. Ultrasound left kidney, longitudinal plane, the calyces, green overlay, are dilated and have lost their normal cup-shaped appearance. Flattening of papillae and blunting of fornices can be seen. Where visible, the renal cortical parenchyma is not thinned. RP, renal parenchyma, arrowheads, hyperechoic renal sinus source, ultrasonographic picture taken from a patient with left ureteral stone with hydronephrosis, created in Taiwan by Morning 2K, Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Obstructing ureteral calculus. Excretory urography, AP view, left, pre-contrast, right, 2.5 hours post-contrast, a calcification medial to the lower pole of the right kidney on the pre-contrast radiograph, red overlay, is shown post-contrast to be an obstructing proximal ureteral calculus, UC, red overlay. The right kidney is enlarged, with persistent enhancement, green overlay. There is pelvic aleectasis and poor contrast filling of the right ureter, region indicated by dashed lines. The left renal collecting system is normal, green overlay. RP, renal pelvis, U, ureter, UB, urinary bladder source, copyright IMPP. Overlay. Obstructing ureteral calculus. Excretory urography, AP view, left, pre-contrast, right, 2.5 hours post-contrast, a calcification medial to the lower pole of the right kidney on the pre-contrast radiograph, red overlay, is shown post-contrast to be an obstructing proximal ureteral calculus, UC, red overlay. The right kidney is enlarged, with persistent enhancement, green overlay. There is pelvic aleectasis and poor contrast filling of the right ureter, region indicated by dashed lines. The left renal collecting system is normal, green overlay. RP, renal pelvis, U, ureter, UB, urinary bladder source, copyright IMPP. Uro. Overlay. Acute pyelonephritis VV. Photomicrograph of a renal tissue biopsy specimen, H&E stain, very high magnification, areas of neutrophilic infiltration are visible throughout the renal interstitium, example indicated by hatched green overlay, especially in the tubules, example indicated by green overlay, which appear dilated. These findings suggest acute pyelonephritis. Source: acute pyelonephritis, 2, very high mag by nephron, Wikimedia Commons, licensed under CC by SA 3.0. Uro__pyelonephritis, 1/3. Overlay. Acute pyelonephritis VV. Photomicrograph of a renal tissue biopsy specimen, H&E stain, very high magnification, areas of neutrophilic infiltration are visible throughout the renal interstitium, example indicated by hatched green overlay, especially in the tubules, example indicated by green overlay, which appear dilated. These findings suggest acute pyelonephritis. Source: acute pyelonephritis, 2, very high mag by nephron, Wikimedia Commons, licensed under CC by SA 3.0. Chronic pyelonephritis kidney specimen. Macroscopic preparation of a kidney specimen. There are multiple irregular areas of fibrosis. This is the typical appearance of fibrosis in chronic pyelonephritis. Source: copyright IMPP. Chronic pyelonephritis VV. Photomicrograph, H&E stain, 150x magnification, of an autopsy kidney specimen of a 60-year-old patient with prostate and bladder carcinoma. A chronic interstitial infiltrate, highlighted red, is seen in scarred fibrous tissue, highlighted green, replacing most of the renal parenchyma. Tubules are partly atrophic with flattened epithelia, arrowheads, or cystically dilated with colloid-like luminal material, so-called tubular thyroidization because of its resemblance of thyroid follicles. A single normal glomerulum, marked G, can be seen. The overall reduced thickness of the parenchyma speaks for a dilated renal pelvis and an obstructive problem, e.g. by tumor or after radiation. These findings are consistent with chronic pyelonephritis. Source: copyright IMPP. Suspected acute pyelonephritis. E fever, chills, E flank pain, CVA tenderness, E lower urinary tract symptoms. Check vitals. Hemodynamic instability? No. V** CBC, BMP, CRP. Yes. Fluid resuscitation, admit to ICU, initiate sepsis workup. E urinalysis and urine culture. F uncomplicated pyelonephritis. Indications for initial imaging? E new eGFR decrease to. Perform CT abdomen with and no without contrast. 1 Cernin, ILI findings V persistent nausea/vomiting, ongoing hypovolemia. No abscess, obstruction, emphysema. 2 Pyelonephritis. Complicated pyelonephritis. Inpatient management. 4 E obtain blood cultures, 2 sets, E perform CT abdomen with and without contrast. A E for fluids. No suitable antibiotic. Yes. Poor adherence to medication/poor social support. And E for empiric antibiotics. E analgesia, antiemetics. No. Outpatient complications management present. Consider single dose of 4-ceftriaxone or gentamicin U prior to PO antibiotics if life-threatening. Local rates of drug-resistant, abscess obstruction, urosepsis. 9 Shock none. E. coli are unknown or high. Mohs answers Barkutersound urology/IR consult urology/surgery aggressive fluid Z encourage fluid intake Henel for ureteral stenting consult for possible resuscitation +9 or nephrostomy nephrectomy vasopressors. E adjust antibiotic therapy according to blood and urine culture sensitivities. E switch to PO antibiotics and follow up outpatient. E consider repeat urine culture in pregnant women and those with recurrent pyelonephritis 2 to 4 days after completion of antibiotic course. Management of acute pyelonephritis. Identify and reverse risk factors, example neurogenic bladder, Foley catheter. Febrile for no clinical improvement at least 48 HR within 48 HR. Repeat renal imaging or consider MRI to rule out abscess, emphysema to pyelonephritis, obstruction. Treat accordingly. Sexually transmitted infections. The term sexually transmitted infections, STIs, refers to a group of infections that are mainly transmitted via sexual intercourse. The most common symptoms of STIs are pain in the suprapubic and genital area, urethral or vaginal discharge, and genital lesions, which may or may not be painful. Some STIs, example HPV, may induce or predispose to malignant changes. The majority of STLs are asymptomatic, and therefore easily spread. If a patient is already infected with an STI, they are predisposed to co-infections with further STIs. There are various treatment options for each STI, with simultaneous treatment of the partner often necessary to prevent recurrent infections. In some cases, healthcare providers are required by law to report cases of STIs to county and health state departments, example HIV, hepatitis B. Overview of sexually transmitted infections. Overview of why. Pathogens associated disease management. Viral pathogens. Local cytotoxic therapy, example with 5-fluorouracil, cryotherapy. Operative management, curettage, surgical excision, laser surgery, or electrosurgery. Human papillomavirus type 6 Condylomata acuminata and 11 bonoid papulosis, Condylomata plana. Herpes simplex virus type 2 genital herpes acyclovir PO for episodic or suppressive treatment, HSV2. Opportunistic infections HIV lymphoma systemic antiretroviral therapy, heart/cart Kappa C sarcoma. Systemic antiviral therapy PO, example entecavir, hepatitis B virus, HPV, sent hepatitis B sent interferon, immune modulating, antiviral, and antiproliferative agent, injected SC or IM. Bacterial pathogens. Urogenital chlamydia infections. Copyright #urethritis, vulvovaginitis, cervicitis, salpingitis, tubo-ovarian abscess, pelvic inflammatory disease, PID, reactive arthritis. Copyright urethritis, epididymitis, reactive arthritis, prostatitis. Chlamydia trachomatis. DK drug of choice, doxyc or isin-PO alternative, fluoroquinolone, example ciprofloxacin, moxifloxacin, chlamydia trachomatis L1 L3 lymphogranuloma venereum. Klebsiella granulomatis granuloma inguinal. Haemophilus ducreyi chancroid ceftriaxone IM single dose. Gonorrhea plus azithromycin PO single dose, degree $, urethritis, salpingitis, tubo-ovarian abscess, pelvic inflammatory disease, cervicitis, expedited partner therapy. Bartholin gland cyst OO urethritis, epididymitis. Neisseria gonorrhea. Copyrights Efixime PO, if chlamydia has been excluded in the patient. Copyright viscous and purulent discharge. Copyrights Efixime PO plus doxycycline 1. Copyright arthritis. Sent penicillin GIM treponema pallidum syphilis alternatives if allergic to penicillin, tetracycline, macrolides, or cephalosporin. Parasitic pathogens. Trichomonas vaginalis trichomoniasis, cervicitis, metronidazole PO. Pediculosis pubis, pubic lice, crab louse, Thyrus pubis. Copyright irritated skin in the pubic hair region. Permethrin 1% lotion, insecticide. Copyright tiny brown lice droppings detectable. O/. Tunae St. Jots. Genital lesions. Overview of genital lesions. Pathogen clinical features. Diagnosis. Painless lesions. Condylomata acuminata. Copyright single or multiple skin-colored 1 to 5 mm papular eruptions, Genital warts, which can be smooth or varicose ma, copyright coilocytes. Back collapse. Fine text outline. Overview of genital lesions. Pathogen. Clinical features. Painless lesions. Asterisk. Condylomata acuminata. Copyright single or multiple skin-colored 1 to 5 mm papular eruptions, genital warts, which can be smooth or varicose, copyright coilocytes. Human papillomavirus type E. Copyright located on internal and external genitalia. 11 Bonoid papulosis. Copyright single or multiple small papules, may coalesce into larger plagues, copyright pigmented with a flat to varicose surface. Copyright most commonly on the penis shaft or external female genitals. Granuloma inguinal. Copyright large, 5 to 10 mm, beefy red, expanding suppurative ulcer. O bleeds easily. Copyright often malodorous because of bacterial co-infection. Copyright commonly located in skin folds. Copyright regional lymph nodes typically spared. Klebsiella granulomatis. Lymphogranuloma venereum. Copyright transient, small papule, or shallow ulcer. Rapid spontaneous healing without scarring. Chlamydia trachomatis. L1 L3. Copyright O, foreskin, glands, and scrotum. Degree O2, posterior vaginal wall, cervix, and vulva. Copyright possibly concurrent discharge, cervical/adnexal/testicular tenderness, and painful. Inguinal lymphadenopathy, may form buboes. Chancre. Copyright singular red, round, and raised ulcer with elevated edges. Copyright heals spontaneously within 4 to 8 weeks. Copyright O at glands. Penis. E2, vulva and cervix. Treponema pallidum. Copyright 5 to 10% of cases are extragenital. Degree. Copyright possibly concurrent regional adenopathy. Condylomata lat. Degree. Warty erosions on the genitals in the secondary phase of syphilis that are velvety, moist, and broad-based. Copyright resolve spontaneously after weeks to months. Painful lesions. Genital herpes. Degree. Multiple grouped, vesicles, 1 to 3 mm, on an erythematous ground. Herpes simplex virus type 1 and 2, mostly HSV2, copyright possibly concurrent malaise, myalgias, and fever. Copyright reactive painful inguinal lymphadenopathy. Common. Copyright O, glands and penis shaft. O, external female genitalia and cervix. Chancroid. Copyright single or multiple papules or pustules, 10 to 20 mm, with yellowish-grayish exudate in the center. Haemophilus tuckeri. Copyright O, glands. Penis, penis shaft, and scrotum. EO2, vulva and perineal area. Degree possibly concurrent painful inguinal lymphadenopathy and abscess formation. Equals. Vaginitis. Trichomonas vaginalis plus erythematous and papilliform appearance of the cervix, strawberry cervix. Diagnosis. Clinical exam and biopsy. Clinical exam and biopsy, cytoplasmic Donovan bodies, bipolar staining. PCR detects chlamydia trachomatis RNA or DNA. Dark field microscopy, spirochetes, serum antibody test. Clinical exam most accurate tests. Degree. Viral culture of lesion. Degree. PCR test of lesion. Most rapid test, direct fluorescent antibody confirmatory test, Zank smear, multinucleated giant cells. Clinical exam and culture. Modal trichomonads on wet mount examination. OE. Management of sexual partners. 3. The following applies to patients diagnosed with a bacterial STI or trichomoniasis, patients with viral STIs, herpes simplex, HPV, HIV, hepatitis B, hepatitis C, need to take lifelong precautions. See the respective articles for more information. Back. VWT collapse. A. Find text. O. Outline. Asterisk. Contact tracing of all sexual partners within the last 60 days, even if asymptomatic. Copyright offer expedited partner therapy, see below, when possible. 1 IL4 Copyright if expedited partner therapy is not possible, advise affected sexual partners to receive STI testing. Sent expedited partner therapy, the treatment of sexual partners of patients who have been diagnosed with STIs by giving prescriptions to the index patients. Copyright if chlamydia has been ruled out in the patient, only gonorrhea test reported positive single-dose cefixime PO. If chlamydia has not been ruled out, single-dose cefixime PO plus doxycycline PO for 7 days. 2. Avoid unprotected sex until all of the following criteria are met. Copyright completion of 7-day treatment regimen or 7 days have passed since a single-dose treatment. Copyright all symptoms have resolved. Any current sexual partners have also met the above criteria. Prevent STIs in patients and partners, see prevention below. Retest individuals to check for reinfection. 1. Copyright in patients with HIV, test at 3, 6, 9, 12, and 24 months. Copyright genitourinary chlamydia, LGV, gonorrhea, or, in patients with female genitalia, trichomoniasis, at 3 months. Copyright syphilis, 6 and 12 months. Copyright latent syphilis, additional test at 24 months. 6. Sexual partners must be treated simultaneously to avoid reinfections. O. Degree CE. Prevention 3. Pre-exposure prophylaxis. O. Safe sex practices. Abstinence. Condom use during vaginal sex or anal sex equals dental dam use during oral sex equals mutual monogamy. Reducing number of sex partners. Copyright vaccination. HPV, and HAV vaccine. See ACIP immunization schedule for details. Copyright disease-specific prophylaxis. See HIV pre-exposure prophylaxis for details. Adherence to screening guidelines for STIs. Post-exposure prophylaxis. Copyright HIV post-exposure prophylaxis. Copyright hepatitis B post-exposure prophylaxis. Copyright antibiotic post-exposure prophylaxis, example doxycycline for chlamydia or syphilis. 5. Copyright self-sampling/testing and pooled sampling. O. Expedited partner therapy. OO. HR. Screening for STIs. This is a summary of the most important screening interventions. For more detailed information, refer to the respective disease articles. STI screening for transgender and non-binary individuals is based on anatomy and risk behaviors. For STI screening recommendations in pregnancy, see prenatal screening for medical comorbidities. Infections equals 2. IG for population test frequency. All individuals equals 13 years of age. IL-6 individuals of any age who request screening at least once in a lifetime. 4th generation HIV test, combination HIV, 6, HIV screening antigen/antibody immunoassay, individuals with increased risk for HIV infection, every 3 to 12 months, depending on risk factors. Example: men who have sex with men, MSM, 8. Once for all individuals with indications for all individuals equals 18 years of age. Hepatitis B surface antigen screening. Hepatitis B screening, 110, individuals indivi of any age with other indications for hepatitis IB core antibody I*. Periodic repeat screening in patients with HPV. Screening hepatitis B surface antigen antibody. Ongoing risk factors for HPV IJL9. Once for all patients with indications for screening. Periodic repeat screening in patients with all individuals equals 18 years of age. 2S111 HCV screening, 1 Viat-Sophage. Anti-HCV antibody, 21 individuals of any age with risk factors for HCV. Ongoing risk factors for HCV J11V. Back collapse. Find text outline. X. Sexually transmitted infections. O. Safe sex practices. Abstinence equals condom use during vaginal sex or anal sex equals dental dam use during oral sex. Mutual monogamy. Reducing number of sex partners. Copyright vaccination equals HPV, and HAV vaccine equals ACIP immunization schedule for details. Copyright disease-specific prophylaxis, see HIV pre-exposure prophylaxis for details. Adherence to screening guidelines for STIs post-exposure prophylaxis EHIV post-exposure prophylaxis copyright hepatitis B post-exposure prophylaxis copyright antibiotic post-exposure prophylaxis, example doxycycline for chlamydia or syphilis, 5 copyright self-sampling/testing and pooled sampling O expedited partner therapy. OS. Degree RU. Screening for STIs. This is a summary of the most important screening interventions. For more detailed information, refer to the respective disease articles. STI screening for transgender and non-binary individuals is based on anatomy and risk behaviors. For STI screening recommendations in pregnancy, see prenatal screening for medical comorbidities. 1D ions, 31 screening for population test frequency. All individuals equals 13 years of age, M7 to 8 individuals of any age who request screening at least once in a lifetime. 4th generation HIV test, combination HIV-6 HIV screening antigen/antibody immunoassay, individuals with increased risk for HIV infection, every 3 to 12 months, depending on risk factors example men who have sex with men, MSM, CE. Once for all individuals with indications for screening periodic repeat screening in patients with ongoing risk factors for HPV-1 holds. Hepatitis B surface antigen hepatitis B core antibody hepatitis B surface antigen antibody. All individuals equals 18 years of age individuals of any age with other indications for HPV screening 9-10 hepatitis B screening. Once for all patients with indications for screening periodic repeat screening in patients with all individuals to 18 years of age 1 EY, individuals of any age with risk factors for HCV screening, 11 anti-HCV antibody 1 ongoing risk factors for HCV 111. All sexually active individuals 24 years of age with ongoing risk factors pound S113, female genitalia and risk factors for STIs NAAT. Annually, or as indicated based on new or chlamydia screening and gonorrhea screening S313 every 3 to 12 months, depending on risk factors *MSM. For STIs, 18. At least once in a lifetime every 3 to 12 months in patients with ongoing risk factors 14 syphilis screening 14 individuals with risk factors for syphilis testing algorithms. Copyright routine serological screening for asymptomatic infection with herpes simplex virus 2 is not recommended. 315. OS. Degree IEEE. Related 1-minute telegram. Sent 1-minute telegram 90-2024-3/3, PEP challenges amid rising STIs sent 1-minute telegram 70-2023-2/3, USPST reaffirms, do not screen asymptomatic patients for HSV. Interested in the newest medical research, distilled down to just 1 minute? Sign up for the 1-minute telegram in tips and links below. V. Back collapse fine text outline. Sexually transmitted infections, 1/13. Anogenital warts, condylomata acuminata. Multiple exophytic, cauliflower-like, confluent, erythematous lesions are seen in the perianal region. Source, copyright IMPP. Sexually transmitted infections, 2/13. Perianal warts, condylomata acuminata, VV. Multiple flesh-colored papules with a folded irregular surface have formed a plaque in this patient's perianal region. These findings are typical of condylomata acuminata due to HPV infection. Source, Figure 31, in Atlas of Pediatric HIV Infection by Regina E. Oladikan, Raniko J. Leloanya, Carol Hlila et.al., Open Books, licensed under CC by ND 4.0. ET granuloma inguinal VV perianal region of a female patient with Klebsiella granulomatis infection multiple confluent, partially ulcerated papules are visible. Diagnosis was confirmed via visualization of darkly staining Donovan bodies in biopsy crush preparations. Source, ID hashtag 15433, CDC/Joe Miller, Centers for Disease Control and Prevention licensed under public domain. Overlay. Granuloma inguinal, donavaniosis, VV exudate smear, Guiamsa stain, Coccobacilli are visible as inclusion bodies within macrophages, Donovan bodies. In some cases, the characteristic safety pin shape can be seen, examples indicated by arrowheads. Source, Donovanosis by Gerard M., Wikimedia Commons, licensed under CC by SA 3.0. Lymphogranuloma venereum VV. Bilateral enlargement of the inguinal lymph nodes above and below the inguinal ligament is visible, groove sign. The groove sign is characteristic of lymphogranuloma venereum, which is caused by acute chlamydia trachomatis infection. Source, Case 10, in, Images of Memorable Cases, 50 Years at the Bedside by Hendrik A. van Dijk, Herbert L. Fred MD, OpenStack CNX, licensed under CC by 2.0. Chancre of the glans penis in primary syphilis. A superficial ulcer with indurated borders is visible on the glans penis. This finding is consistent with primary syphilis. Source, primary stage syphilis sore, chancre, on glans, head, of the penis, unknown, Centers for Disease Control and Prevention, CDC, National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention licensed under public domain. Sexually transmitted infections, 7/13. Condylomata lata of the glans penis in secondary syphilis VV. Several discrete, broad-based, papular erosions are visible on the glans penis. These findings suggest condylomata lata, a cutaneous feature seen in secondary syphilis. Source, copyright IMPP. Gears bead. 2. Condylomata lata in secondary syphilis VV. Broad-based papular erosions are visible around this patient's anus. Clustering around the anus and the typical appearance are suggestive of condylomata lata, a sign of secondary syphilis. Source, copyright IMPP. Genital herpes VV. The entire genital area appears erythematous with an inflamed vaginal vestibule and urinary meatus. Solitary erythematous papules are visible inside the labia minora. Furthermore, there are white purulent lesions in the vaginal introitus. These findings are consistent with genital herpes, most likely caused by infection with herpes simplex virus type 2. Source, hashtag 16968, CDC/Dr. Wiesner, Public Health Image Library licensed under public domain. Zank cell VV. This smear from the base of a herpetic gingivostomatitis lesion shows a multinucleated giant cell, Pappenheim stain. This finding indicates a positive Zank test. Herpetic gingivostomatitis is caused by HSV1. Source, copyright IMPP. Chancroid lesion on the penis. There is an ulcer with an erythematous margin on the corona of the glans penis. This is a characteristic chancroid lesion, which is caused by Haemophilus duckeri infection. Source, ID hashtag 3728, CDC/Joe Miller, Centers for Disease Control and Prevention, CDC, licensed under public domain. Inguinal lymphadenopathy in chancroid VV. There is massive bilateral swelling of inguinal lymph nodes. The skin above the lymph nodes is livid. The causative agent is Haemophilus duckeri. Source, ID hashtag 5811, Susan Lindsley, Centers for Disease Control and Prevention, CDC, licensed under public domain. Overlay. Trichomonas vaginalis VV phase contrast photomicrograph of vaginal discharge, high magnification, These parasites with flagella, blue overlay, are Trichomonas vaginalis, the causative pathogen of trichomonal vaginitis. In the center, 2 squamous epithelial cells can be seen. Source, ID #5238, CDC, Centers for Disease Control and Prevention, CDC, licensed under public domain. Copyright overlay. Trichomonas vaginalis VV phase contrast photomicrograph of vaginal discharge, high magnification. These parasites with flagella, blue overlay, are Trichomonas vaginalis, the causative pathogen of trichomonal vaginitis. In the center, 2 squamous epithelial cells can be seen. Source, ID #5238, CDC, Centers for Disease Control and Prevention, CDC, licensed under public domain. X disorders of the glands penis and foreskin. Common disorders of the glands penis and foreskin include balanitis, balanoposthitis, phimosis, and paraphimosis. Balanitis refers to inflammation of the glands penis, while balanoposthitis refers to inflammation of both the glands penis and the foreskin. Management focuses on optimizing genital hygiene and topical treatments based on the underlying etiology. Phimosis is a congenital or acquired constriction of the foreskin causing inability to retract the foreskin. Physiologic phimosis is common in younger men and resolves with time. Pathologic phimosis is treated with careful genital hygiene and topical steroids, but circumcision may be required. Paraphimosis is a urological emergency in which the foreskin is trapped behind the glans penis in uncircumcised or partially circumcised individuals, causing constriction of the penis. Paraphimosis needs to be manually reduced, but if unsuccessful, surgical management is required to avoid penile necrosis. OOE. Balanitis and balanoposthitis. Definition 1. Scent balanitis, inflammation of the glans penis. Scent posthitis, inflammation of the foreskin. Scent balanoposthitis, inflammation of both the glans penis and the foreskin. Etiology 22321. Plus infectious I. Copyright Candida, example Candidal balanitis, diaperdermatitis, LA. Copyright sexually transmitted infections, example gonorrhea, chlamydia, syphilis, EO. Human papillomavirus E. herpes simplex virus plus inflammatory/4. Copyright irritant balanoposthitis, balanoposthitis due to irritation of the skin, example excessive cleaning with soap. Copyright allergic reaction, example contact dermatitis, fixed drug reaction, O. balanitis xerotica obliterans, lichen sclerosis of the glans penis and foreskin, characterized by pruritic, white plagues with epidermal atrophy and scarring. A. Copyright lichen planus. Copyright psoriasis. Copyright balanitis circinata, an inflammatory, ulcerating balanitis associated with reactive arthritis and premalignancy. O. Bowen disease. O. erythroplasia of Curie. Clinical features 5LL221. Scent pruritus, pain, and edema of the glans penis. Erythema of the glans and/or foreskin with possible erosions or ulcerative lesions. Penile exudate and/or discharge associated symptoms, example fever, arthralgias, malaise, lymphadenopathy. Diagnostics 21. Scent clinical diagnosis. Management 2. Scent optimize hygiene, example daily foreskin retraction and washing. Scent avoid known irritants, example soap, perfumes, consider emollients as an alternative to soap. Provide disease-specific treatments such as antibiotics for bacterial infections, topical antifungals, example clotrimazole, for mild fungal infections, and topical steroids for irritant or allergic reactions. Complications 21. Phimosis. Paraphimosis. Scent urethral stricture. Scent penile cancer. OXO. Back collapse. Fine text outline. X disorders of the glans penis and foreskin. O. Bowen disease. O. erythroplasia of Curie. Clinical features 5IL221. Scent pruritus, pain, and edema of the glands penis erythema of the glands and/or foreskin with possible erosions or ulcerative lesions penile exudate and/or discharge associated symptoms, example fever, arthralgias, malaise, lymphadenopathy. Diagnostics 21. Scent clinical diagnosis. Management 21. Scent optimize hygiene, example daily foreskin retraction and washing. Avoid known irritants, example soap, perfumes, consider emollients as an alternative to soap. Provide disease-specific treatments such as antibiotics for bacterial infections, topical antifungals, example clotrimazole, for mild fungal infections, and topical steroids for irritant or allergic reactions. Complications 21. Phimosis paraphimosis urethral stricture penile cancer. WA. OCE. Phimosis. Scent definition, a congenital or acquired constriction of the foreskin causing inability to retract it over the glands penis. Scent epidemiology, physiologic phimosis occurs in 10% of boys at 3 years of age, but decreases to 1% of boys by 16 years of age. 6 etiology 6 Copyright physiologic phimosis, the inability to retract the foreskin due to preputial adhesions between the glands and foreskin, congenital. Copyright pathologic phimosis refers to the inability to retract the foreskin due to distal scarring caused by, e.g., recurrent episodes of balanitis or balanoposthitis. Clinical features, copyright. Copyright inability to retract foreskin. Copyright white fibrous ring around the preputial orifice in pathologic phimosis. Symptoms of underlying etiology, example balanitis, balanitis xerotica obliterans. Scent diagnostics, clinical diagnosis plus treatment, and copyright all patients, optimize foreskin hygiene, example cleansing with soap and water. Copyright physiologic phimosis, provide reassurance, mostly self-limiting. Copyright pathological phimosis and physiological phimosis with recurrent complications, example paraphimosis, UTIs. Consider topical corticosteroids. 9 conservative treatment failure, surgical management, example circumcision. Scent complications. Paraphimosis lower urinary tract obstruction urinary tract infections. Copyright balantitis or balanoposthitis. WW. Back collapse. Fine text outline. Candidal balanitis VV. Source, courtesy of Dr. Gary M. White MD. Lichen sclerosis of preputial skin. Irregularly shaped, slightly hard white plaque surrounded by an inflammatory halo on the preputial skin. When retracted, the foreskin appears entrapped and constricts the penile shaft. This is most likely pathologic phimosis. Source, ID #6541, Susan Lindsley, Centers for Disease Control and Prevention, CDC, licensed under public domain. Lichen sclerosis. Photograph of the glans penis. A round white plaque surrounds the tip of the glans penis. This appearance is suggestive of lichen sclerosis. Source, copyright IMPP. Genital lichen planus VV. Localization, glans penis. Lesion, lace-like, papular lines, Wickham striae. Source, copyright IMPP. Anfe, CC3, 2I, vel EEIW is equals in 9. Equals 2, is IURTA SS on. These findings are typically associated with rheumatic diseases such as reactive arthritis. Several ulcerated, small, flat lesions are visible. Photograph of the glans penis. Balanitis circinata. Uro disorders of the glans penis and foreskin, 5/6. Zoon balanitis VV. Source, courtesy of Dr. Gary M. White MD. Uro disorders of the glands penis and foreskin, 1/3. Phimosis WS. Source, Figure 1, in, sutureless prepusplasty with wound healing by second intention, an alternative surgical approach in children's phimosis. Treatment by Efstratios Christianakis, BMC Urology, licensed under CC by SA 2.0. Uro disorders of the glands penis and foreskin, 2/3. Stenotic ring in phimosis VV. Source, Figure 3, in, sutureless prepusplasty with wound healing by second intention, an alternative surgical approach in children's phimosis. Treatment by Efstratios Christianakis, BMC Urology, licensed under CC by SA 2.0. Uro disorders of the glands penis and foreskin, 3/3. Phimosis. Penis of an adult male with and without foreskin retracted. The tight foreskin cannot be fully retracted over the penis. This is the typical presentation of phimosis. Source, Phimosis explained by Bossboy 1968, Wikimedia Commons, licensed under CC by SA 4.0. Modifications, image cropped. X. Testicular tumors. Testicular tumors most commonly occur in men between 20 and 35 years of age, and are the most common solid malignancy in this group. Most often, patients present with a painless nodule or swelling of the testis. Diagnosis is made primarily based on palpation and findings on testicular ultrasound. Diagnostic staging further includes an abdominopelvic and chest CT, determination of serologic tumor markers, AFP, HCG, LDH, and radical inguinal orchiectomy of the affected side to confirm the diagnosis and to evaluate the histopathology, seminoma versus non-seminoma. The necessity and choice of adjuvant treatment depends on tumor pathology, staging, and prognosis. Treatment options include active surveillance, retroperitoneal radiotherapy, retroperitoneal lymph node dissection, and platinum-based chemotherapy. The overall prognosis of testicular tumors is excellent. Patients can often be cured even in advanced, metastatic stages. WY and epidemiology. Most common solid malignant tumor in young men in the U.S. peak incidence, 20 to 35 years, non-seminomas peak in the third decade, seminomas in the fourth decade of life. References. Epidemiological data refers to the U.S., unless otherwise specified. OS. E. Etiology. Scent risk factors. Copyright cryptorchidism, increased risk for germ cell tumors, 2O contralateral testicular cancer, O germ cell neoplasia in situ, CNS, O family history of testicular cancer. Copyright Klinefelter syndrome, trisomy 21, increased risk for germ cell tumors, O subfertility/infertility, hypospadia. References, ISLL 4L. FO. G. Classification. Testicular tumors are classified according to pathology. Overview of testicular tumors. Type of tumor: frequency, AFP, HCG. Characteristics: germ cell tumors of the testis, 95%. Scent: malignant tumor that has slow growth and late metastases. Good radiosensitivity. Better overall prognosis compared to non-seminomas. Most common testicular tumor: increased placental ALP. Seminoma. Plus 40% equals. Pure embryonal carcinomas are rare, but are a very common element of mixed germ cell tumors. Aggressive tumor with high malignant potential and early metastases may be painful. Worse prognosis than seminoma. Embryonal carcinoma 2 degrees 25% OS degree. Rare in adults, but common in children, typically benign but may be malignant in adults. Teratocarcinoma, teratoma *25%, FA. Non-seminoma tumors. Highly malignant and most aggressive early hematogenous metastasis to the lungs or brain is common. Testicular, _my degree 75% choriocarcinomas 7. A. Find text. Pathology. Comparable to ovarian dysgerminoma in women. Macroscopic findings: uniform white cut section microscopy. Degree fried egg cell appearance. Copyright cells have an abundance of watery cytoplasm. E fibers septate divide the tumor into lobules. Macroscopic findings: gray-white regressive changes with hemorrhage, necrosis, and cysts. Microscopy: glandular or papillary pattern. Composed of tissue from different germinal layers. May be immature or may contain fully differentiated elements of muscle, cartilage, bone, teeth in mature pterodomosh. Consist of both cytotrophoblasts and syncytiotrophoblasts. Multinucleated giant cells. O. Outline. Most common prepubertal testicular tumor similar to the yolk sac tumor of the ovary. 5% TTOA. 5. Gross, yellow, mucinous cut surface. Coccycytime. Degree aggressive tumor with high malignant plus microscopy, Schiller-Duval bodies, perivascular potential glomeruloid structures. 2. Mixed germ cell, 30% 02 ROOM equals * even if seminoma component is present, it plus heterogeneous cut surface with solid areas, tumors is classified and treated as a non-seminoma. Hemorrhage, and necrosis. Non-germ cell tumors of the testis, 5%, rare tumors which arise from the hormone-producing stromal cells of the testes. Usually develop after the age of 4 * gross, characteristic golden brown color. Leydig cell tumors * 2% and copyright * produce large amounts of testosterone and microscopy, Reinke crystals, eosinophilic. A small amount of estrogen, progesterone, cytoplasmic inclusions, and corticosteroids * malignant transformation is very rare. Rare sex cord stromal tumor derived from Sertoli cells 7. Sertoli cell tumors *. Most common F equals Saman __, usually extranodal non-Hodgkin lymphoma 7, diffuse large B-cell lymphoma, usually diffuse large B-cell lymphomas. Men 60 years of age. Secondary testicular tumors. Copyright HCG is always elevated in choriocarcinoma and sometimes elevated in seminoma. AFP is always elevated in yolk sac tumors. Both AFP and HCG may be elevated in mixed germ cell tumors. Copyright testicular tumors metastasize early into the retroperitoneum via the lymphatic system, drain to the para-aortic lymph nodes first, with the exception of early hematogenous metastasizing choriocarcinomas. References: Lally Alto. Feedback. Your notes. Shared notes. Manage. Clinical features. Plus painless testicular nodule or swelling. 1 plus negative transillumination test. Dull lower abdominal or scrotal discomfort is more common than acute scrotal pain. In metastatic disease. Copyright cough, shortness of breath, chest pain. Lower back or bone pain. Gynecomastia, in Leydig cell tumors. Androgen excess features equals prominent external genitalia, pubic hair growth, accelerated skeletal and muscle development, and mature masculine voice equals may cause precocious puberty in boys. Copyright. Occasionally, estrogen excess features, gynecomastia, breast tenderness, and gonadogenital underdevelopment. Paraneoplastic hyperthyroidism, alpha subunits of HCG and TSH are identical, enabling weak stimulation of the TSH receptor in tumors with HCG overproduction. 12. Until proven otherwise, a firm nodule on the testis should be considered cancer. References. 212 Feedback. OV, Texia your notes. 2 Shared notes. Manage. Subtypes and variants. Extragonadal germ cell tumors. Definition: primary germ cell tumors that arise outside of the gonads, anywhere along the body's midline from the pineal gland to the coccyx. Scent epidemiology, 5 to 10% of all germ cell tumors, mostly affects young males v. Back collapse. Fine text outline. Subtypes and variants. Extragonital germ cell tumors. Asterisk definition, primary germ cell tumors that arise outside of the gonads, anywhere along the body's midline from the pineal gland to the coccyx. Scent epidemiology, 5 to 10% of all germ cell tumors, mostly affects young males. Scent location degree midline organs: mediastinal, retroperitoneal, intracranial, pineal gland and suprasellar region. Sacrococcygeal teratomosh, most common in infancy or early childhood. 13 equals presents as a mass near the caudal end, near the rectum. Equals can cause obstruction, weakness, pain, and / or paralysis. Asterisk symptoms underscore, chest pain, dyspnea, on exertion, cough. Copyright palpable abdominal mass, back pain. Weight loss, headache, nausea, vomiting, ataxia, change in vision. Scent diagnosis. Copyright testicular ultrasound, to rule out gonadal primary tumor. Copyright tumor markers, alpha-fetoprotein, AFP, and human chorionic gonadotropin, HCG. Copyright tumor biopsy, confirmatory, non-seminomas are more common than seminomas. Scent therapy. Degree determined by the location, size, and histology of the tumor. Copyright chemotherapy, radiation therapy, and / or surgical resection. Scent prognosis, the 5-year survival is 95% for seminomas and 45 to 60% for non-seminomas. References, 4LL151L16. And stages. Staging of testicular tumors is based on the American Joint Committee on Cancer, AJCC, groups, which combines TNM stage and serum tumor marker levels. Simplified AJCC classification: stage description, stage plus limited to the testicles without lymph node involvement. Asterisk retroperitoneal, beneath the diaphragm, lymph node involvement. Copyright stage LLA, affected lymph nodes 5 cm 1. Stage ill, distant metastases or non-regional lymph node involvement, or retroperitoneal lymph node involvement with moderately to highly elevated tumor markers. OE. Diagnostics. Suspicion of a testicular tumor is usually established based on the clinical findings and ultrasound, to localize the tumor. Scent laboratory tests. Copyright tumor markers, alpha-fetoprotein, AFP, human chorionic gonadotropin, HCG, see overview of testicular tumors, and lactate dehydrogenase, LDH. Scent imaging. Copyright ultrasound equals seminoma, hypochoy, homogeneous, sharp margins equals non-seminomas, variable echogenicity, inhomogeneous, may be calcified or cystic microlithiasis, disseminated calcification as a possible precursor of carcinoma, starry sky appearance. Copyright CT, because of the descended testis, the regional lymph nodes are located retroperitoneally, example para-aortocaval, beneath the diaphragm. High-resolution abdominopelvic and chest CT equals cranial CT or MRI if distant metastasis to the brain is suspected plus histopathological confirmation, following radical inguinal orchiectomy. Copyright seeding. If a testicular tumor is suspected, the testis should be removed and sent to pathology. Transscrotal biopsy should not be conducted because of the risk of tumor. Back collapse. Fine text outline. Testicular tumors. Difficile diagnosis of pain. Li swelling condition. Clinical features: ultrasound usually painless mass, however, may feel dull ache or heavy sensation in the testicle, palpation of solid mass. Asterisk negative transillumination test. Testicular tumor solid mass with variable echogenicity. Fluctuant swelling of the scrotum. Hydrocele testis. Scent palpation of an elastic soft swelling. Scent positive transillumination test. Hypochoy mass around the testis. Asterisk usually painless. 1. swelling may be reduced when supine. Scent visible or palpable strands and bag of worm sensation dilated hypochoy pampiniform vessel scent negative transillumination test varicocele testis. Scent fluctuant swelling of the upper testicular pole * positive transillumination test spermatocele testis, hypochoy dilation of epididymal duct or reedy testis. Visible groin protrusion bowel sounds on auscultation over scrotum scrotal hernia herniated bowels. 5s US. References, 8 The differential diagnoses listed here are not exhaustive. OSOES. Treatment. Surgery. Plus prior to surgery, sperm cryopreservation * radical inguinal orchiectomy - adjuvant radiotherapy and chemotherapy. Adjuvant therapy is based on the clinical staging group, histology, seminoma versus non-seminoma, and the prognosis. Adjective TR for ocular cancer staging according to the seminoma-non-seminoma classification. Active surveillance or standard, active surveillance stage 1 * alternatively chemotherapy, carboplatin, or radiation therapy of the RPLND registered plus cisplatin-based CH therapy regional lymph nodes chemotherapy, BEEP. In patients with normal post-orchiectomy tumor markers, RPLND registered plus cisplatin * radiation therapy, or based chemotherapy, CCC. Chemotherapy BEP or EP. Sent in patients with elevated post-orchiectomy tumor markers, chemotherapy with BEP or EP. Stage IA, * chemotherapy, depending on prognosis BEP, or EP, followed by evaluation of any residual disease that may require resection. AEI BEP equals CH therapy with ISIN, etoposide, and CI, in, EP equals with etoposide, CI3 RPLND equals retroperitoneal lymph node dissection. References 191 L20 LL21 I9. OSO. Prognosis. The overall prognosis of testicular tumors is excellent, with a high cure rate and 5-year survival rates of 95%. Even in advanced, metastatic stages, testicular tumors are often curable. Copyright testicular tumors, particularly seminomas, are one of the few cancers that can be cured even in very advanced stages with adequate treatment. Patients with non-seminomas have a significantly poorer prognosis but still an excellent overall survival rate. Back collapse. Fine text outline. And testicular tumors, 1/7. Sagittal section of the testis. Seminiferous tubules. Cellular origins of testicular tumors. Copyright Boss. Cell type distribution of primary tumors, %. Tumor type. Leydig cell tumor cells. Non-germ cell tumors, 5%. Sertoli, Sertoli cell tumor. Seminoma. Germ cell eye tumors, 95%. Non-seminomas, embryonal carcinoma teratoma testicular choriocarcinoma yolk sac tumor. Overlay. Seminoma VV. Microscopic image of the testicle, H&E stain, 400x magnification, green overlay, tumor tissue white overlay, lymphocytic infiltrate white arrows, nucleoli of tumor cells black arrows, regular spermatogonia. Click on the microscope icon to view the entire specimen through a virtual microscope. Source, copyright Smart Zoom, Smart in Media. Image and annotations in digital microscopy, PDDRMED Alberto Perez Buza, Fock Arst für Pathology. Smart Zoom Viewer. Powered by Smart Zoom. Copyright 2023 Smart in Media. Smart Zoom Viewer. Tunica albuginea. The tunica albuginea is a thick fibrous layer which envelopes the testicles. Powered by Smart Zoom. Copyright 2023 Smart in Media. And AOOAEOCOC pound equals Rs equals A 20532 N Fe 2 no AO2, ROAO equals EO2 Fe, 2 ONO equals O and equals D equals REO equals copyright G. Healthy seminiferous tubules with plentiful XXX Smart Zoom Viewer SS or equals root OA4 plus AL registered A AE SN glycogen. In the cell, a centrally located, large, round nucleus with a prominent nucleolus. In a classical seminoma, the cytoplasm is typically stained as it does elsewhere in the sample. Seminoma cell. AEE algae. X Smart Zoom Viewer. X Smart Zoom Viewer. AE TES 8 Re ES Remi A. 4TXET3 plus FSEE wet. A.VN. Recognized with their high condensed chromatin content. Should the cell be in metaphase or anaphase, 44 ASIS here the case, the division between the two cell poles becomes visible. Smart Zoom Viewer. Seminoma cell. Here we can also see a large, round seminoma cell with a centralized nucleus. The nuclei in seminomas are relatively homogeneous. AEE is asterisk plus. EAE senior EYBSE WO LEVE AK Phi OEIJA. TJS2EXE. PLLAE Lethi the E. Smart Zoom Viewer. PESEEBS. Bay. Aric lymphocytic infiltration is a classic symptom of a seminoma. E. CAEOS POO. TEED in air, I% EAE at TAA PA YWODCE May, 3% He's AE% plus SAR. BH7 Yen AUT7/IT rate Pacey. II trademark at Smart Zoom Viewer. Ha. M4PT VAT powered by Smart Zoom copyright 2023 Smart in Media. Z. Overlay. Seminoma VV. Photomicrograph of a testicle biopsy specimen, H&E stain, very high magnification, lymphocytic infiltrates are clearly visible, examples indicated by yellow overlay. Tumor cells appear with a central nucleus with nucleolus and clear cytoplasm, examples indicated by green overlay. These features are suggestive of seminoma. Source: Seminoma High Mag by Nephron, Wikimedia Commons, licensed under CC by 3.0. Overlay. Seminoma VV. Photomicrograph of a testicle biopsy specimen, H&E stain, very high magnification, lymphocytic infiltrates are clearly visible, examples indicated by yellow overlay. Tumor cells appear with a central nucleus with nucleolus and clear cytoplasm, examples indicated by green overlay. These features are suggestive of seminoma. Source: Seminoma High Mag by Nephron, Wikimedia Commons, licensed under CC by 3.0. Overlay. Embryonal carcinoma, EC, VV. Photomicrograph of a tumor tissue biopsy specimen, H&E stain, medium magnification. This testicular tumor tissue has a sheet-like, blue outline, and papillary architecture, green outlines, prominent fibrovascular cores marked by black dashed lines. However, gland-like or tubule-forming patterns may also occur, not seen here. In this case, the tumor cells are pale, large, and epithelioid with prominent nucleoli, indicated by black arrowheads, and nuclear atypia. Necrotic areas, green overlay, and apoptotic bodies, examples marked by green arrowheads, are commonly seen. The diagnosis of EC should be verified by immunohistochemical stain, positive, CD30, cytokeratins, negative, CD117/C-kit, and further stains must be used if in doubt of a non-pure EC to rule out presence of a mixed germ cell tumor. Source: Embryonal Carcinoma, High Mag by Michael Bonert, Wikimedia Commons, licensed under CC by SA 3.0. Overlay. Embryonal Carcinoma, EC, VV. Photomicrograph of a tumor tissue biopsy specimen, H&E stain, medium magnification. This testicular tumor tissue has a sheet-like, blue outline, and papillary architecture, green outlines, prominent fibrovascular cores marked by black dashed lines. However, gland-like or tubule-forming patterns may also occur, not seen here. In this case, the tumor cells are pale, large, and epithelioid with prominent nucleoli, indicated by black arrowheads, and nuclear atypia. Necrotic areas, green overlay, and apoptotic bodies, examples marked by green arrowheads, are commonly seen. The diagnosis of EC should be verified by immunohistochemical stain, positive, CD30, cytokeratins, negative, CD117/C-kit, and further stains must be used if in doubt of a non-pure EC to rule out presence of a mixed germ cell tumor. Source: Embryonal Carcinoma, High Mag by Michael Bonert, Wikimedia Commons, licensed under CC by SA 3.0. G. Overlay 4. Choriocarcinoma. Photomicrograph of choriocarcinoma, H&E stain, very high magnification. Cytotrophoblasts are visible throughout the tissue as polygonal-shaped cells with clear cytoplasm, single uniform nuclei, and distinct cell borders, examples indicated by green arrowheads. Nuclear enlargement and mitosis are visible. Syncytiotrophoblasts appear as multinucleated cells with eosinophilic cytoplasm, examples indicated by green overlay, and surround the mononuclear cytotrophoblasts. These findings are characteristic of choriocarcinoma. Source: Choriocarcinoma-2 Very High Mag by Nephron, Wikimedia Commons, licensed under CC by 3.0. Overlay 4. Choriocarcinoma. Photomicrograph of choriocarcinoma, H&E stain, very high magnification. Cytotrophoblasts are visible throughout the tissue as polygonal-shaped cells with clear cytoplasm, single uniform nuclei, and distinct cell borders, examples indicated by green arrowheads. Nuclear enlargement and mitosis are visible. Syncytiotrophoblasts appear as multinucleated cells with eosinophilic cytoplasm, examples indicated by green overlay, and surround the mononuclear cytotrophoblasts. These findings are characteristic of choriocarcinoma. Source: Choriocarcinoma-2 Very High Mag by Nephron, Wikimedia Commons, licensed under CC by 3.0. SW overlay. Schiller-Duval body VV. Photomicrograph of a testicle biopsy sample, H&E stain. Cuboidal cells are organized in a solid pattern. A central blood vessel, red overlay, is surrounded by germ cells, blue overlay, resulting in a glomerulus-like appearance. Schiller-Duval body. Schiller-Duval bodies are pathognomonic of yolk sac tumors. Source: Yolk sac tumor Schiller-Duval body by Jens Florian, Wikimedia Commons, licensed under CC by SA 3.0. Copyright overlay. Schiller-Duval body VV photomicrograph of a testicle biopsy sample, H&E stain. Cuboidal cells are organized in a solid pattern. A central blood vessel, red overlay, is surrounded by germ cells, blue overlay, resulting in a glomerulus-like appearance. Schiller-Duval body. Schiller-Duval bodies are pathognomonic of yolk sac tumors. Source: Yolk sac tumor Schiller-Duval body by Jens Florian, Wikimedia Commons, licensed under CC by SA 3.0. Sertoli cell tumor VV. Photomicrograph of testicular tumor biopsy specimen, H&E stain, intermediate magnification, irregular tissue architecture and abnormal arrangement of cells in cords and tubulous structures are visible. The cells are rather pale with foamy cytoplasm and occasional cytoplasmatic vacuoles. Also, the chromatin inside the nucleoli has a granular appearance. The architecture is suggestive of a sex cord stromal tumor. Immunohistochemistry should be performed to determine the cellular origin and to rule out a testicular germ cell tumor. Positive stains for inhibin and calretinin confirm the diagnosis of a Sertoli cell tumor. Source: Sertoli cell tumor low mag by Nephron, Wikimedia Commons, licensed under CC by SA 3.0. Urotesticular tumors, 1/3. Normal. Pyureal layer. Tunica cavity, potential space, vaginalis, visceral layer. Hydrocele. A hydrocele is an accumulation of fluid within the tunica vaginalis of the scrotum. Copyright Embark. Hydrocele. Normal spermatocele. Spermatocele VV. A spermatocele is a cystic collection of sperm arising from the epididymis, efferent ductules, or rete testis. Copyright Embark. Urotesticular tumors, 2/3, normal varicocele. Pampiniform plexus. Varicocele VV. A varicocele is a dilatation of the pampiniform venous plexus in the scrotum. Copyright Embark. Ex-testicular torsion. Testicular torsion is the sudden twisting of the spermatic cord within the scrotum. It most commonly affects neonates and young men. Because of the risk of ischemia and possible infarction of the testis, it is considered a urological emergency. Testicular torsion is characterized by sudden onset unilateral testicular pain, which may radiate to the lower abdomen with nausea and vomiting. Clinical findings include a high-riding testis with an absent cremasteric reflex. Imaging with duplex ultrasound of the scrotum may be required if the clinical diagnosis is in doubt. If testicular torsion is suspected, prompt surgical exploration within 6 hours of symptom onset is essential to salvage the testis. Important differential diagnoses, example orchitis and epididymitis, should be ruled out before initiating treatment. OES. Epidemiology. Peak incidence, neonatal period, first 30 days of life, and during puberty, 10 to 14 years, 1 cent prevalence. Copyright 3.8 per 100,000 male individuals under the age of 18, 2/3 of cases occur between 12 and 18 years of age. 2 Copyright accounts for 10 to 15% of acute scrotal illness in children within the United States. 3 Epidemiological data refers to the U.S., unless otherwise specified. FOOE. Etiology. Idiopathic copyright. Copyright proposed causes include Bell-Clapper deformity, intravaginal torsion, see pathophysiology below, and along mesorchium. Copyright in fetuses and neonates, extravaginal torsion of the entire tunica vaginalis. Latrogenic scent occurs as a result of vigorous physical activity or trauma in very rare cases for predisposing factors, especially in adults, testicular malignancy. WA. RO. Pathophysiology. Testicular torsion is a sudden twisting of the spermatic cord and vascular pedicle, associated with a poorly secured testis. Scent. 3 mechanisms of testicular torsion may be identified. Copyright intravaginal torsion. Hypotheses suggest this occurs because of a congenital abnormality in which the tunica vaginalis attaches to the superior pole of the testis. Bell-Clapper deformity, increased mobility of testis within tunica vaginalis, with possible abnormal transverse lie of testis. Torsion of the testis, along the spermatic cord. 5O extravaginal torsion, lack of fixation of the tunica vaginalis to the gubernaculum. Concomitant torsion of the testis and tunica vaginalis, along the spermatic cord. 61O long mesorchium. Elongated mesorchium, thick band of connective tissue between the efferent ductules of the epididymis and the posterior surface of the testis. Torsion of the testis along the mesorchium 7. Scent torsion results in venous engorgement with consequent arterial compromise, tissue ischemia, and possible infarction. Scent irreversible damage occurs after 6 to 12 hours of torsion. 3. Z and clinical features. Asterisk abrupt onset of severe testicular pain and/or pain in the lower abdomen, typically swollen and tender testis and/or lower abdominal tenderness. 8. Nausea and vomiting, abnormal position of the testis, copyright scrotal elevation, high riding testis, EO abnormal transverse position, copyright possible undescended testes, predisposes to testicular torsion, I9 absent cremasteric reflex 1 cent negative praying sign V. Back collapse, fine text outline. Scent neonates, copyright possible absent testis 50 firm, painless scrotal mass, copyright possible acute inflammation, swollen, erythematous, or blue discolored in venous engorgement, and tender hemiscrotum. Sudden, severe, unilateral scrotal pain in a patient with a tender, abnormally positioned testis on examination should be managed as testicular torsion until proven otherwise. References. OOES. Diagnostics. Copyright testicular torsion is typically a clinical diagnosis. Do not delay definitive treatment for diagnostic workup if clinical suspicion is high. Imaging. Duplex ultrasound of the scrotum 14ILS 1611-17S. Either formal ultrasound or POCUS can be used to diagnose torsion, depending on operator skill and availability. I-18. Asterisk indication, inconclusive clinical findings 14 plus characteristic findings 2 IL-16O enlarged testis I copyright twisting of spermatic cord, whirlpool sign, copyright reduced or absent blood flow to / from the affected testis O heterogeneous appearance of testicular parenchyma indicates testicular necrosis. 4. Other imaging modalities. Plus radionuclide imaging 3. Degree indications inconclusive clinical findings equals evaluate for epididymitis copyright characteristic findings equals testicular torsion areas that do not absorb radionuclide as a result of decreased blood flow to the affected testis, cold spots, asymmetric blood flow equals epididymitis, areas where there is increased radionuclide absorption as a result of increased blood flow in inflammation, hot spots, plus MRI with 4 contrast, may be used as an alternative to radionuclide imaging. 121. Copyright surgical intervention is recommended for suspected testicular torsion, regardless of radiological findings. Laboratory studies. Scent not routinely indicated asterisk urinalysis for copyright indications, rule out epididymitis copyright findings. Leukocytes and erythrocytes in the urine suggest epididymitis but do not exclude torsion, see epididymitis. Why? Differential diagnoses. Differential diagnosis of scrotal pain 3 disorder history examination laboratory studies asterisk swollen, edematous, tender testis. Abnormal position of testis, example transverse lie, scrotal 7, asterisk sudden onset AE elevation, normal inflammatory markers SDQD. Differential diagnosis of scrotal pain 3 disorder history examination laboratory studies swollen, edematous, tender testis abnormal position of testis, example transverse lie, scrotal sudden onset I, elevation, negative praying sign absent cremasteric reflex. Normal inflammatory markers testicular torsion, equals normal urinalysis unilateral painful testis / lower abdomen nausea or vomiting non-tender spermatic cord, 20. Gradual onset, example. Very tender, physical examination is painful, positive praying sign positive cremasteric reflex increase in generalized epididymitis inflammatory markers possible history of urethral discharge possible pyuria during urinalysis tender spermatic cord, 20, fever, dysuria, urinary frequency. Easy palpation of solid mass slow progression, example weeks to months, Possible manifestations of metastatic disease, example usually painless mass, however, the patient may distant lymphadenopathy, chest pain, gastrointestinal possible increase in serum tumor experience a dull ache or describe a heavy sensation symptoms, markers, example alpha-fetoprotein, in the testis, possible swelling of the ipsilateral lower limb, venous engorgement due to obstruction. Testicular tumor. Typically normal inflammatory of fepulated OT insidious onset of unilateral scrotal pain tender testis APJ appendage, hydatid O, markers asterisk usually seen in boys 7 to 14 years of age may manifest with blue dot sign Morgagni, YNBSGY, typically normal urinalysis. Torsion of testicular appendage, hydatid of Morgagni, 221. Scent description, an embryological remnant on the upper pole of the testes or at the epididymis, the remnant of the Müllerian duct, that has the potential to rotate. Scent clinical features, symptoms resemble acute testicular torsion. Copyright typically seen in boys 7 to 14 years of age. Copyright insidious unilateral scrotal tenderness. Copyright blue dot sign, infarction of the hydatid of Morgagni that appears blue through the scrotal skin. Imaging, Doppler ultrasound may show an enlarged testicular appendix and / or mild hydrocele with preserved testicular blood flow. Management. Copyright a conservative approach with NSAIDs may be considered. Copyright if the diagnosis is in doubt, surgical intervention is required to examine the testes. The differential diagnoses listed here are not exhaustive. OS. Good. Treatment. Testicular torsion is a medical emergency and should ideally be treated within 6 hours of the onset of symptoms for the best chance of testicular salvage. Manual detorsion in the emergency department may be attempted prior to surgery for immediate pain relief, but should not delay transferring the patient to the operating room. Manual testicular detorsion, IL-121. Indication, may be attempted prior to surgery for immediate pain relief or if surgery is not immediately available. Procedure. O. Rotate the testis laterally toward the thigh. 1. 2/3 of torsions occur toward the midline. O. If lateral rotation does not provide symptom relief, rotate the testis toward the midline. 1/3 of torsions occur laterally. 23. Copyright surgery should still be performed in all patients to resolve any possible degree of remaining torsion, and to prevent recurrence. Rajtun 4. Because of the risk of infertility, surgical exploration of the scrotum is recommended in any patient suspected of having testicular torsion, even if manual detorsion has been attempted. Exploratory surgery, 4LL3. Scent indication, suspected testicular torsion * timing, ideally, within 6 hours of symptom onset. 1-3 procedure O. Immediate surgical exploration of the scrotum with reduction, untwisting, and orchiopexy of the affected testis. Copyright orchiopexy of the contralateral testis is recommended because the risk of testicular torsion on the contralateral side increases with previous or current testicular torsion. 1. Copyright orchiectomy if the testis is grossly necrotic or non-viable. V. Back collapse. Fine text outline. X. Testicular torsion. Torsion of testicular appendage, hydatid of Morgagni, 22. Scent description, an embryological remnant on the upper pole of the testes or at the epididymis, the remnant of the Müllerian duct, that has the potential to rotate. Scent clinical features, symptoms resemble acute testicular torsion. Copyright typically seen in boys 7 to 14 years of age. Copyright insidious unilateral scrotal tenderness. Copyright blue dot sign, infarction of the hydatid of Morgagni that appears blue through the scrotal skin. Scent imaging, Doppler ultrasound may show an enlarged testicular appendix and / or mild hydrocele with preserved testicular blood flow. Management O. A conservative approach with NSAIDs may be considered. O. If the diagnosis is in doubt, surgical intervention is required to examine the testes. The differential diagnoses listed here are not exhaustive. OS. OOE. Treatment. Testicular torsion is a medical emergency and should ideally be treated within 6 hours of the onset of symptoms for the best chance of testicular salvage. Manual detorsion in the emergency department may be attempted prior to surgery for immediate pain relief, but should not delay transferring the patient to the operating room. Manual testicular detorsion/LL121. Scent indication may be attempted prior to surgery for immediate pain relief, or if surgery is not immediately available, scent procedure. O rotate the testis laterally toward the thigh. 1. 2/3 of torsions occur toward the midline. O if lateral rotation does not provide symptom relief, rotate the testis toward the midline. 1/3 of torsions occur laterally. 23. Copyright surgery should still be performed in all patients to resolve any possible degree of remaining torsion and to prevent recurrence. A14. Copyright because of the risk of infertility, surgical exploration of the scrotum is recommended in any patient suspected of having testicular torsion, even if manual detorsion has been attempted. Why? Exploratory surgery, 74L3. Scent indication, suspected testicular torsion plus timing, ideally, within 6 hours of symptom onset. 1/3 scent procedure. O immediate surgical exploration of the scrotum with reduction, untwisting, and orchiopexy of the affected testis. OE orchiopexy of the contralateral testis is recommended because the risk of testicular torsion on the contralateral side increases with previous or current testicular torsion. I copyright orchiectomy if the testis is grossly necrotic or non-viable. O. CE. Prognosis. Testicular salvage rates depend on the interval of time between symptom onset and restoration of testicular blood flow. 2 LST25 copyright within 6 hours, 90 to 100%. 1/3 copyright greater than 12 hours, 20 to 60% copyright 24 hours, up to 20% scent late or absent surgical intervention. Testicular ischemia, with/without necrosis, disruption of the blood-testis barrier, formation of anti-sperm antibodies. Infertility, 251-24. WA. OIOE. Tips and links. V. Back collapse. Find text outline. Testicular torsion, 1/1. Intermittent testicular torsion. VV. Color Doppler ultrasound of both testes, transverse plane, of a 14-year-old boy who woke up with acute right scrotal pain. The right testis lies in an abnormal horizontal position, white arrow, with intratesticular flow slightly reduced compared to the left testis. These findings are consistent with intermittent testicular torsion. During orchiopexy, a bell clapper deformity was seen bilaterally, determined to be the most likely cause. Source: Fig. 5, in Testicular Torsion with Preserved Flow, Key Sonographic Features and Value-Added Approach to Diagnosis by Bandarkaran, Blask AR, Springer Link, licensed under CC by 4.0. Modifications: image cropped and letter removed. Right testicular torsion. Manual detorsion. Tunica vaginalis. Testicular torsion and manual detorsion. Testicular torsion is the twisting of the spermatic cord containing testicular blood vessels, leading to testicular ischemia. Testicular torsion most commonly occurs in the medial direction. Manual detorsion may be attempted before definitive surgical therapy, orchidopexy, if the duration of symptoms is less than 6 hours. This involves untwisting the spermatic cord by rotating the testis in a lateral direction, i.e., counterclockwise for the right testicle, clockwise for the left testicle. Copyright Boss. X. Epididymitis. Epididymitis is the inflammation of the epididymis and is commonly associated with genitourinary tract infections. Epididymitis is a clinical diagnosis, with patients typically presenting with a gradual onset of pain and swelling of the affected scrotum and a positive Prain sign. Urinalysis and testing for sexually transmitted infections, STIs, can help confirm the diagnosis. Testicular torsion is the most important differential diagnosis of epididymitis. If it cannot be ruled out clinically, an urgent ultrasound must be performed. The treatment for epididymitis includes empiric antibiotic therapy based on the most likely source of infection and symptomatic management, example scrotal elevation, and NSAIDs. 57AE. Etiology. Plus acute epididymitis, an inflammation of the epididymis, usually as a result of an infection. 10 Urinary tract infections equals most common cause among older men and children equals pathogens, E. coli, most common, Pseudomonas, common, Proteus mirabilis, Klebsiella pneumoniae. Sexually transmitted infections most common cause among young males, usually 6-week course of the disease, E. recurrent and/or untreated acute epididymitis. Copyright tuberculosis, usually associated with renal tuberculosis, E. rare, non-infectious causes. Amiodarone-induced epididymitis. Autoimmune diseases, example Behçet disease associated with granuloma formation in seminiferous tubules. Clinical features. Sent acute epididymitis. Unilateral scrotal pain and swelling, which develops over several days and radiates to the ipsilateral flank. Tenderness along the posterior testis. Copyright positive Prain sign, reduced pain when the affected hemiscrotum is elevated. Copyright scrotal skin overlying the epididymis may appear red, shiny, and edematous. Low-grade fever, especially among children. Symptoms of lower urinary tract infection, example dysuria, frequency, urgency, including urethritis. Urethral discharge, sent chronic epididymitis. Copyright recurrent bouts of scrotal pain. Copyright swelling is minimal when compared to acute epididymitis. Copyright thickened epididymis. OSFO, IEEE. Diagnostics. General principles. Sent epididymitis is a clinical diagnosis. Sent urine and urethral studies help tailor antibiotic therapy and identify the causative organism. Imaging is primarily used to rule out testicular torsion but can confirm epididymitis if the diagnosis is uncertain. Testicular torsion is the most important differential diagnosis of epididymitis and must be ruled out first. Routine laboratory studies. 22324. Sent urinalysis, to identify pyuria and/or bacteriuria plus urine culture, to identify the causative organism and assess for antibiotic resistance. 4 nucleic acid amplification testing, NAAT, for chlamydia trachomatis and Neisseria gonorrhea, urine sample or urethral swab. 1 gram stain of urethral secretions, to identify urethritis. 1 and gonococcal infections. 1. Registered testing for HIV and syphilis is recommended for all patients with acute epididymitis. 2. V. Back collapse. Fine text outline. X. Epididymitis. Routine laboratory studies. 2I324. Sent urinalysis, to identify pyuria and/or bacteriuria. Urine culture, to identify the causative organism and assess for antibiotic resistance. 4. Sent nucleic acid amplification testing, NAAT, for chlamydia trachomatis and Neisseria gonorrhea, urine sample or urethral swab. 4. Sent gram stain of urethral secretions, to identify urethritis. 1 and gonococcal infections. Copyright testing for HIV and syphilis is recommended for all patients with acute epididymitis. 2. Duplex ultrasound of the scrotum. 2. May be used to rule out testicular torsion and scrotal abscess, findings, an enlarged, hyperemic epididymis with increased blood flow indicates epididymitis. WA and differential diagnoses. Sent testicular torsion. Sent hydrocele. Sent varicocele. 1 Sent inguinal hernia. 1C differential diagnosis of scrotal pain. The differential diagnoses listed here are not exhaustive. So. Treatment. Empiric antibiotics for epididymitis. Indicated for all patients with acute epididymitis. Start empiric antibiotic treatment based on the most likely causative organism. 2. Patients with a suspected UTI. Source 1, example enteric organisms. Fluoroquinolone, example levofloxacin. Copyright. Patients with a suspected ST. Source, example chlamydia or gonorrhea. Ceftriaxone plus doxycycline. Adjust antibiotic therapy once the causative organism is identified. Scent. If symptoms do not improve within 72 hours after starting treatment, reconsider other diagnoses. Symptomatic management. Indicated for all patients as needed. Scent. Scrotal elevation. NSAIDs. Avoidance of aggravating activities. Scent. Application of a cold pack. Surgical intervention. Not generally indicated. Exceptions include intrascrotal abscesses and some cases of chronic epididymitis. Co. CE. Complications. Plus epididymal abscess. 71. Scent. Epididymo-orchitis, the spread of infection from the epididymis to the testicle. Scent. Testicular infarction. Scent. Infertility. We list the most important complications. The selection is not exhaustive. V. Back collapse. Find text outline.